The first speaker. No, pero estamos... urologist from Saudi Arabia. Said will talk about flexible ureteroscopy.
Thank you very much. Thank you very much. Buenos días. Thank you. Gracias, Pablo. Thank you for having me, Dr. Pablo and Dr. Gonzalo. Thanks for having me. And it's always a pleasure to come to Argentina. 2 years ago, I was in the World Cup, so I was forced to make cheers with the Argentinian people. So first lecture, please.
Hola, hola. Para despertarlos a todos. ¿Cómo están? Muy buenos días. Bueno, muchas gracias, Pablo.
Good morning. Thanks, Pablo. Thanks, Gonzalo, Luis, Carlos, for the invitation. Pleasure to be here one more year at this course. Question: how many of you use suction today for flexible percutaneous access? And how many do you use it in percutaneous access, and how many flexible access? Great. Well, this is the idea. Now with the presentations by the teachers, the professors who are most experienced, see how we can modify or not these results in terms of use, which is what is coming, but it is important to know where we are standing today in the region to modify this. Sahid, you have the floor.
I wish I speak Spanish for better communication. So, does this work? So these are my declaration. I work with these companies. So Pablo asked me to talk about, okay. The green one. Yeah, first.
Chicos, no está pasando el pasador. Just a moment. Okay, yeah.
Oops. Yeah, okay. So one. Okay, so these are my declaration. So what are the objectives of suction urethral access sheath? Is the history of access sheath, is the pressure reduction, reforming, and types of access sheath, and suction advantages. So I will talk about everything. So urethral access sheath to come to, most importantly, to decrease the pressure. As we know, multiple publication was there, and it's proven that access sheath used to reduce the pressure to have a balanced pressure inside the kidney. Otherwise, you will have multiple problems. Access sheath came into the market for the last 15 years with the multiple shapes at the beginning. So what we know about the access sheet at the beginning is the hydrophilic coating, is the type of insertion technique, is the outer inner diameter size. As you can see, the hydrophilic coating was the most important factor, but nobody cares about it, which is playing a role inside the ureter. You can see these images. If you use it again, you might have a problem because the coating disappeared. Look at this. If you don't have an access sheet with a good hydrophilic coating, you might lose it inside the ureter. So the next thing, what are the types of access sheet? You have an access sheet with one guide wire like parallel. From Cook, you have the coloplast retrace, dual lumen from Bflex, Rocamed, coaxial navigator, flexor from Cook, and you have the famous, the beginning, the radial dilating access sheet. So 4 types at the beginning of the access sheet, as you can see. The standard size 10 years ago was at 12-14, but now they came down because the scope went down to 10-12. And this gives you an idea because we want to avoid the injuries inside the ureter, as you can see here. The second important one, why we decrease the size, we have to decrease the scope to have less pressure inside the kidney. As you can see here, the space is very important, especially if you're using 7.5 or 9 French inside an access sheet 10-12. Look at the drainage inside, which is very, very important to reduce the pressure and take out the heat of the kidney. By this, we have some dust coming from the access sheet in that space. So we thought that this might be a good idea for us to have more dust. Why we cannot use the suction? As you can see, the space getting bigger. So we have the chance to use the suction. Clearpetra was the first. They introduced a standard one, not flexible one. This is the 5th type of urethral access sheet. Drainage and suction at the beginning. This one was in 2019 or 18. Publication came with the Chinese people, multiple access sheet standard. Look at these, the Niago, ZSR, Innovex, and gives you an idea why the companies rush to do these flexibles with the suction, because it gives us more stone-free, it gives us more relax. This is one of the publications we participated, that feasibility and the clinical utility of this access sheet. Multiple publication came after that. And then we have to talk about the flexible urethral access sheet. We have to talk why it came, because the TFL came, which is dusting. It is dusting, so we can suction the dust. And the design of this access sheet and the deflection, which is important, because some people, they said it is difficult. So the dusting, yes, because with the TFL when it came, we were seeing the dust. We cannot see anything. So that's why the suction helped us to take these dust away from our vision. As you can see, the value of the TFL at the beginning, or the dusting laser, that the holmium or Moses. And you can see this suction sheet sweep away the dust and take the heat outside. This is an idea that it came to the endourologist at the beginning. Next. Okay, so you can see here that the suction, how does it work? So what about the fiber? The TFL fiber, better deflection, so it helps the flexible urethral access sheet to come down, better irrigation to avoid the heat. And you can see here, it's better than the holmium, because the holmium has a micro fissures. The TFL stands very good. And this, with the 150, it gives you more deflection with the flexible urethral, with the fans. The design, what about the design? The first generation was a little bit hard. The tip was not flexible. You can see here, this is a whip, like whipping the screen of your car, of the front of your car. And then you can see even other company like from Hong Kong, ZSR or Clearpetra, they try to make you very soft, collecting the dust from the calyceal system. What about the hydrophilic coating? Improved. They made it better. This is from Innovex. And then they made you a sliding port, because they want you to do like open surgery, suction, close it, or like leave it open. It's upon your request as an endourologist. And then they gave you a catcher. At the beginning, they gave you a catcher of PCNL. Then they modified it to a small catcher because they thought it's not necessary to give you a big one. Maybe you want to ask him a question while we waiting? You want some questions?
When when you use access sheet and flexible scope, which size do you prefer to use? The size of the access sheet, and what do you think that is the best to perform this action and to use this action during the procedure?
The smaller is better. I will present it because the 1012 for the pressure and the suction is much better than 1214 because of the diameter and the space. So the suction, if you apply low suction in the 1012, you need more suction in 1214. And the other principle about the smaller access sheet, because you avoid injuries, the primary access is more. So you don't need the 1214 because your scope now is 7 French, 8 French maximum, which is, I will present maybe next slide, that 9 French should be abandoned from the market. So smaller access sheet comes with the smaller scope. The suction, every advantage is in that. Oh, the length I will present it now, the length. It is very important, yes, it is one of the factors. I'm sorry.
What's the ideal gap between the scope and the access sheet? Because there are some different data.
What is the ideal gap between the PCNL? We believe that it's a 4 French to 6 French. In the scope, it's between 1.5 to 2.5. The ideal gap between scope, and if you have between 2 to 3, it's a bliss.
Why?
Because you have more space to have the micro dust, because when you dust less than 200 micron. So 200 micron can go into that space easily without going out multiple times. If you have 1 French, you will have the pressure will be high, the fragments and dusting will come out beside the heteroscope and the access sheet, so if they accumulate, they will obstruct the drainage. And this is very important to keep the pressure. You have to have a good high flow. That's why with a 6 French, maybe, or 7 French, and access sheet 9 French, you will have 3 French, which is a bliss for any surgeon.
Antonio, in your daily use, how is your gap? What is your preferred scope and your preferred
we don't have, we can't have a preference because we have only a little view. So now we're using 1113 access sheet and little view. And with that, for us, it's working very well. So it's enough, I think, for me at least.
So I come to the question of the gentleman, and he told me what is the better length. What is the main problem for choosing why? Because if you think 55 is good for the north of Europe, it's good. But for the guys from America Latina, we are maybe short. So how do we solve this problem? Some companies, they beat you the introducer with a mark. So you can put it inside the ureter to know what is the best length for you. Otherwise, we blocked. For this, you look, this is the idea. If you have a long one, you will work from away, and your scope will be blocked at there. And this is the most vulnerable point you can break your scope. So it's a very important to know, look at this matching between scopes. You can tell if any company comes to you and said, take 55, but you are a huge med, you will tell him that I have only space 4 centimeters to swim inside the kidney, and my scope will be blocked inside. So do not be deceived by some companies when if you have a 40 centimeter for a guy, 180 centimeter, it will stop at the junction. So you have to measure it very well, because the aim of fans is to swim inside the kidney. And look at this. This is a huge med 6.3 with an access sheet 9 French, 911 from this from the SR from Hong Kong with a good hydrophilic coating. You can see that how we are going down with the size, as you can see here with the space 2.7. And this is what I was with by Pablo, that the space here is 2.7 between the access sheet, as you can see here, Pablo. If you are doing dusting, you don't have a problem, but if you have some fragments, you can wait until these fragments come away behind you. But if you are blocked there as your big fragment with the laser that gives you a big fragment, you have to go out to take these fragments outside from the sheet. And this is the idea of that space. It gives you less reduction, it gives you more space to reduce. So it's not only for pressure, it's for the elimination. And you can see here the deflection, and you can see the deflection as well in the lower pole. You can see clearly that we can go down without, and this gives you an idea why do we need basket anymore. You can reduce the number of baskets that you are using in certain cases. These are the lower pole, 8.7. I have to go fast. This is a kid, 6 French, 5 years old. Good deflection. It shows you that how the deflection of the fans comes in. And you have one of the tips that if you cannot go by the flexible access sheet, you have to go by scope. Then you call it slide over. You push the access sheet inside. You can use the access sheet for taking the clots, because before we used to have the basket. You can take the clots outside with no problem. You can use it for kidney with the infection. Before we were afraid of flexible ureteroscope because PCNL is having more space to, but with this, look at the dust comes from the kidney with no problem. So we created a new era. Look at these debris and dust. You just over the stone because the stone was dirty. So the risk of sepsis will be much less, and it's proven by the publication, and the pressure there is low, and this will give you an idea. Even we can go look at these fragments inside a small infundibulum. You take these fragments, you don't need basketing, then it gives you something we call it a genuine stone-free in the future. You can even, instead of lasering the Randall plaque, you can just take it out by the flexible urethral access sheath. I'm sorry. So even the small stones impacted inside the diverticulum, because most of these stones, you can push the access sheet in front of the door, you open it, all the fragments will come out with no problem. So you seize the problem. You are controlling everything, and less basketing. And this is what you can put the price of the basket over the price of access sheet, because we are dreaming of one device in endourology, not many. Before, like 20 years ago, we used to mud. Now this is a basket. This is Encompass from Cook, which is the better to catch 2 millimeter. But if you have an access sheet swimming inside your ureter, you can take all the dust, so you don't need by the end of the operation. Again, cystine bubbles, and look at the cystine bubbles. You know that if you are doing cystine, these bubbles, you can be absorbed and suctioned by the access sheet easily. I'm sorry, the time is up. But I will keep that back. Impacted stone, you can take the fragments, as you can see here. This is impacted stone. I have to go back. Impacted stone, you can see that the fragments will never go to the kidney. It will come to the access sheet, goes out. Yes. So these are one of the advantages. You can have a 3-year-old pediatric stone. You can have a 3-year-old girl, 1.5 centimeter. And in certain cases, you can do some, but in new era of the extreme, sorry, maybe a problem. I went fast, right? Oops. I have a virus. It's okay. If you want to ask questions, I have no problem. I'm sorry.
What do you think? ¿Preferís que sigamos con la próxima?
Yeah. So you have to go fast. So last minute. I'm sorry for the late, but I need 2 minutes. Yeah, this is the extreme we have think about it, that bilateral partial staghorn with the fans, 2.5 an hour. You can achieve more. Even people, they said this is a Housefield law. It's a mixed stone with calcium oxalate. At the end, you will end up of everything bilateral simultaneously surgery. This gives you a space, but I cannot lie about you. Fans has a problem. We're still accelerating things toward these. Look at this fans. Uterine access sheet is still uterine access sheet. It might injure the ureter, as you can see here, with a problem. You can, instead of having access sheet fixed in the ureter, now you are manipulating the access sheet. You are twisting the UPJ. You are doing bad things we don't know yet about it, but it's a dream for us. You can, this is one of the, you can play the video, please. Por favor. The video, play it, please, that one. It is very important to see this point of the access sheet, and I wish that everybody, no, I'm sorry. So the tip of the access sheet that was soft, it plays like an angle. So it causes an injury of the ureter. So do not push a fans inside the ureter over a scope, because it might play and cause a knife as a fan. Access sheet, if not, you have a small scope, it might be broken, as you can see, which is a problem. You can leave it inside the ureter, as you can see here, if you don't do things rightly. I think you have to restart it. Maybe I can put? Yeah. Can you play the video, please? Yes, you can see that access sheet lift inside. So everything looks beautiful with the operation, but we forget there are some catastrophic things can happen. You can leave hydrophilic coating inside, as I showed you with the access sheet. So my home test message is fans is for sure decreasing the pressure, more stone-free, it's a paradise. Dusting laser is preferred, it's not a must, because if you have fragments, you can take it in out. Smaller is better, hydrophilic coating is a must, and it is a single use. You cannot reuse it. Thank you very much.
Bueno, seguimos con el programa. El doctor Somani ahora nos presentará sobre DIS.
Dr. Somani will speak about DIAS.
Thank you very much for this kind invite. This is my first time to Argentina, but won't be the last, I promise you. I'm very grateful to Pablo and the whole team, Bernardo, and for being here. So after that Said's talk, which almost crashed with all the videos, I would promise you I'll try not to crash it. So this is direct in-scope suction. Is this the future of endourology, having suction through either the scope or the sheath? We'll find out, but definitely having suction through either the scope or sheath is going to be the future in one way or the other. So we have seen how the sheath helps you take the fragments out, but what about the scope? When you're doing the procedure, what are the three main things? You want the operative time to be low, you want the intrarenal pressure to be low, you want the temperature to be low because you're using laser all the time, so you're worried you can have thermal injury. And having the scope suction helps you to solve all those problems. So you can have suction through various ways. You can have it through the sheath, you can have it through the scope, you can have it through a catheter or steerable catheters. But effectively, in the journey of ureteroscopy, if you see, the last innovation was the suction scope. So there's been lots of different innovations in ureteroscopy, right from the early 1940s and 50s. But this is the last innovation that has come. And I think this won't be the last. We will see more innovations in the future. So just going through the ins and outs, it's like a typical scope. It has got a better sort of handle, and it's got a suction port, and you can deflect it either way to connect the suction. Going forward, of course, you've got the 7.5 French, but you also now have a bigger scope with a slightly bigger suction channel. And this allows you to suck out fragments maybe up to 1 millimeter, maybe 0.5 millimeter to 1 millimeter, something like that. But again, remember, this is not to suck out large fragments. You need the sheath for that. This is to suck out large dust particles or small fragments. Because it's about single-use scope, I'm also going to mention cystoscope quickly. So you also have suction cystoscopes now. We use it regularly. I won't go through the features, but I'll just show you a small video of this. So hopefully it will play. Yeah, so you can see it's a cystoscope we are doing. You can have the same principle. There's a lot of debris in the bladder. You use the suction. Normally you'd need to use a syringe or whatever. Use suction. It sucks out the bits. You come out after you've done the cystoscopy. So how does it help? You can do local anesthetic bladder tumors, small bladder tumors. You can do small bladder stones. Because you're sucking it all the time, the patient doesn't feel the pressure in the bladder so much. And of course, when the view is not good, rather than having to suck manually, this is very good because it allows you to suck out, and you can see the fluid there later on. Going forward, what is the first impression? And I'll show you some videos in my next session of this. I think the vision is excellent, and suction allows clearance of debris very well. So we have actually just done the first paper on the scope suction. It was a multi-national study with 5 European and 1 Asian center, prospective consecutive patients, and we had 57 patients with a decent stone volume, the stone diameter of about 18 millimeter roughly, with a third of patients with multiple stones. And suction, when we asked the clinician, was it helpful? Almost 95% said the suction was helpful for this case. So in terms of intraoperative data, the operative time was good, 50 minutes. Access sheath was used in about 2/3 of the cases, but you don't have to have an access sheath because in some cases, the patients were not pre-stented, so the ureter is a little bit narrow, so you can just railroad the scope and use suction. And again, the suction was used by almost everybody, and it was helpful for almost everybody. So let's look at some results. The post-op stent rate was 84%. There was one minor bleeding, but no other complications, no infection and no sepsis. And I think this is a big advantage because when you are sucking during the procedure, the pressure is low, so it is less risk of hematoma, bleeding, and probably infection. And that is very important, as we know. Stone-free rate was good, and even for large stones, the stone-free rate was good. This is bearing in mind, this is after one procedure. Of course, some patients might need a second procedure, and this was the follow-up duration. So we then asked the parameters in terms of quality of the scope. 1 being not good, 5 being very good. Most of them scored between sort of 4 and 5, which meant it was good or very good. Similarly, when you compare it to the pre-existing scope, how was it? And similarly, there was no scope failure, and if cost was not an issue, everybody would want to use it. So it clearly shows that suction scope has got a very bright future, but you need to use it for the right reason. This is another paper that was done recently where it showed the suction cleared almost 100% of the dust. So if it's real dust, suction scope will completely clear it. Of course, if the dust fragments or if the dust is bigger than 500, then it's a problem because the scope is not designed to clear that. But because it's clearing up the smaller dust particles, your vision is maintained throughout the case all the time. And you can go much quicker because normally what happens, you do lasering, there's a snow globe effect. That doesn't happen when you're lasering and you have got the suction along with it. And the clearance rate, of course, if it's a big particles, then it's a problem. Suction helps it clear very well. So I think this technology, they concluded, was excellent in terms of intraoperative clearance of vision and progressing without having to stop and start. So I think the suction scope was good visibility, maneuverability, suction quality, and this was the conclusion of one of the papers, you need bigger channels. So here we are, we have got now bigger channels. So this is, I'll show the full video in my next presentation, but this is big stones in the lower pole, the left one, and we are using the larger suction channel, the 5.18 channel, and you can see that we are continuously, there is no blockage in terms of the vision, we are continuously lasering. So when you're continuously lasering, you go quicker, you're not worried about pressure and temperature, otherwise you would stop, wait for the vision to clear, and you're going on. So that does speed up the procedure, and that helps go more quickly, more fast. So this was a recent suction meta-analysis that we did about, is suction helpful? And there were 16 studies, and actually suction, either through the scope or sheath, improved stone-free rate, reduced the overall and infectious complications, and the length of hospital stay. So clearly, there is a lot to be said about the role of suction, and it is not just going to stay, it is going to push the limits, it is going to change the way we look at endourology and completely revolutionize endourology. So what are the advantages then of suction? The advantage, intrarenal pressure control. You don't have to worry about it so much because you are sucking it, the pressure is minimized, which means the patients get less pain, there is less reflux, there is less risk of infectious complications. Temperature control. Again, we have seen that there is a lot of issues with high temperature, with ureteric injury, etc., stenosis. With this, you don't have to worry so much because you're sucking it, the temperature is maintained a little bit better. Vision, of course, is much better because you are using suction intermittently, so you are clearing out the debris, so the vision is improved. You are pushing procedural limits, whether it's a good or bad thing, I don't know, but you definitely are doing bigger stones, stones which you would normally do maybe a PCNL. You are pushing the limits both in terms of the operating time as well as the type of stones you'd be doing. And definitely, there's no question, it reduces complication rates like sepsis and bleeding. I'm just going to briefly mention the disadvantage because I know Thomas will, so before my challenger does it, I'll do it for you. So what are the slight disadvantage? Only slight. One, I think there is a little bit more cumbersome. You have one more extra tube, which is attached. Maybe it's a little bit cumbersome. The suction parameters are not defined yet. What suction? Is it 100? Is it 150? Is it 200? And that we still don't know enough about it. And it's not always working excellent in all the cases. It works very nicely, but may not be excellent in all the cases. And you do need more irrigation. So normal, what irrigation you use, you do need a bit more irrigation. So if you ask me, how do I use it? So when I'm doing the procedure, I use the scope suction during the procedure. After the procedure is finished, all I do is change the tube from the scope to the sheath, and then you let the sheath, as Saeed has shown beautifully, extract the fragments. So the question is there a role for both? Of course, because they are not doing the same job. They are doing different job. If they were doing the same job, then you can argue. But during the procedure, the scope suction allows you a much better control because you have the control of the scope, much better than the sheath. And after you have finished the procedure, to extract the fragments, that is where the sheath suction comes in handy. So what is the future? What does it look like to me? Use the smallest scope, that is the least invasive, that dusts the stone through laser. You have suction through the scope or sheath to clear it. You have temperature and pressure monitoring, perhaps, although we may not need it, but perhaps monitoring will help. You have artificial intelligence to predict outcomes because you already know what the outcomes will be like, and there is no recurrence. And that is what the future should look like. And suction goes a long way in getting to that future. Thank you so much.
Sí, ahora seguimos con el... Okay, seguimos con el doctor Thomas Talley.
And now we will follow with Dr. Thomas Talley, who will present on problems with discs and fans.
Good morning, everyone. Thank you, Pablo, and thank you to all the organization and the sponsors for having us all here. It's a true honor to be here again in Argentina. It's my third time. It's probably not my last time. Do you hear me enough? Do I need to speak louder? Do I need to grow or shrink? I'm good like this? Okay, thanks. I have still 9 minutes and 45 seconds. Should be okay to talk to you about problems with direct in-scope suction and fans, and these are my disclosures. One is a disclosure that's not on there is that I actually believe that suction may help. But anyway, so thank you, Pablo, for giving me this talk. This is me agreeing to come to the meeting, and this is you giving me the talks, saying that, well, there's a lot of problems with the discs and fans. But also, I'm giving a talk on the benefits of suction in the era of pressure, or pressure in the suction era. Thank you very much, Pablo, and to all of you, forgive me, Pablo made me do it, so sorry. So what are we talking about? What are fans and what are the direct in-scope suction? Direct in-scope suction, we just had a very nice talk from Bashar Somani, and we had a great exhibition from Said bin Hamri about the flexible vacuum access sheets as well, so I don't need to go into more detail about this. We've seen these publications before. This is a retrospective study, 214 patients. They already started with the suction access sheets 3 years ago. I was here 3 years ago and I hadn't heard about it, but they already started doing studies with it. And mind you, 46% were pre-stented. And they compared traditional access sheets versus the new ones, and they had some slightly better or lower sepsis rates, but this was not statistically significant yet. This is another study looking at 224 patients. All of them were pre-stented, and this is important. They used a 1214 suction sheet. And if you look at the results are pretty good, even for large stones, but they're not that great for very large stones or stones that are in the lower pole or very hard stones. And if you look into detail, only 2 patients developed fever out of 200 patients. It's just 1%, that's fine. But if you look into detail to this paper, they actually say the maximal deflection is limited and depends on the flexibility of the scope. It cannot reach into the inferior calyx when the inferior calyx is sharp, the angle is sharp. So that's one disadvantage. So disadvantages of fans, are they not so fantastic? You can have loss of deflection of the scope. And Said already showed us how to gain access to that lower pole by sliding the access sheet over the scope into that lower pole. But mind you, this is in vitro data, and this was not measured with the laser inside of the working channel. So when using it as a vacuum cleaner, you use the scope at the tip of the sheath, but if you need to go into that lower pole, you actually shove it over. And so if you do this, I would urge you not to do this with a reusable scope. You will break your reusable scope faster. So if you're using a disposable access sheath with flexible tip and suction, you need to use this with a disposable scope as well, which will probably add cost to your procedure, unless of course you re-sterilize everything. How about this study, the feasibility study? Well, maybe we just need smaller access sheets like Said showed, not the 1214, but the 1012. Sure, let's use the 1012 instead of the 1214. But, and they said, well, the results are a lot better with the 1012, but a lot of these patients, a lot more of the patients in this group were actually pre-stented in the 1012 group, in contrast to the 1214 group. And they showed here that this is one of the small disadvantages. The surgeon has to play a dynamic role in both navigating the sheath and the desired calyx, as well as intermittently withdrawing the scope in the sheath of the wide junction when fragments need to be aspirated. So it's a really, really not that ergonomic movement to do. So how about failures? Can you always get the access sheath up? Even the 1012. The primary failure rate of uteroscopy in my hands with an 8.5 French scope is 7%, and 7.5 French scope even. And this is my own data from my own over 1,000 flexible uteroscopies, and that's 7% in non-pre-stented patients. How about the failure rate of 1012 access sheets? This will be a lot higher, and if we look into the literature, we know that the failure rate of getting an access sheath of 1012 up is between 10 and 40%. So you don't get it up all the time. 10 to 40%, you need a second procedure at least. So a lot of these patients need to be pre-stented if you want to use an access sheath. And by the way, if you look into detail into the literature that has been published on FANS, the prospective observational studies, only patients in whom a sheath was successfully deployed were included in the study. What happened to all the other patients? They weren't treated, or they get a PCNL, or a regular ureteroscopy, or not a FANS. Did they get as much infections? We don't know. And even Olivier Traxer himself said, okay, this is very interesting about a year ago, but we need more evaluation to conclude safety and efficiency. So it means that there's a learning curve. And although my colleagues will tell you, this is how you use a vacuum sheath, it's super easy and this is the most easy thing in the world, it comes with a learning curve. You start off like this. It's difficult. You need to find the right suction settings. You need to find the most ergonomic way of holding on to the sheath, or switching between irrigation and suction on the direct in-scope suction. It comes with a learning curve, I tell you. Let's look at this very nice study from my two esteemed colleagues here, step-by-step guide to using a flexible access sheets. They told me they never have infections, but 36% had infections. I don't understand. What's going on? Am I missing something? Please tell me, explain it to me. So let's move to direct in-scope suction. And we saw this paper already, very much. Thank you so much, Bashkar. We saw this paper. And yes, for dust, it's great. It's great for dust. But do you get dust all the time? And even with dust, you get blockages. Blockages with dust. Only 0.25 millimeters. I can even see 0.25 millimeters. It's too small. And with larger fragments, 0.5 millimeters, it's not even useful at all. This is the 7.5 scope. I have to be honest, not the 9.2, but it's not applicable. And although it was possible to selectively aspirate all dust particles within this range, it was not possible to do that in presence of larger fragments. So in vivo, where you don't only have dust, it's not that useful. And it reduces the stone clearance rate to 0.09 grams per minute. You might as well look angry at the fragments. It will be as efficient. How about CVAC? So it's the big scope. I'm not going to go into too much detail because, well, it's not even available outside of North America. It's a very big device. It's also very costly. It's over $3,000. If you have a lot of money to spend, then sure, why not? And you do have a larger working channel, which allows you to aspirate larger fragments, but it also means that your laser will vibrate a lot more, so you need an extra device to hold on to the fiber, and fragments may get stuck in the working channel. You may need to unclog it, which is an extra maneuver you have to do. You have to take out the scope, you have to put a mandrel in there, and you have to unclog the scope. Ergonomic? I don't think so. How about this? Another paper that you already mentioned, the first clinical evaluation of a flexible digital ureteroscope with direct in-scope suction. Great paper, I liked it. Let's look at the post-operative results. Patients get completely stone-free, right? The visual stone-free rate is 70%. If you do direct in-scope suction, you say, okay, we suck out everything that we see. Why is the direct in-scope suction Visual stone-free rate, only 70%. I don't understand. It must be me. And there are definitely limitations, and you already hinted towards them, but the suction is, as you say, limited by the size of the working channel, and switching between those irrigation and suction manually increases the hand fatigue and wrist stiffness. Bhaskar had this on his slide. He didn't mention it, but it was on his slide, because the score for hand fatigue and thumb fatigue was 3, and not that great, but it's the honest data. So fans work better than direct in-scope suction, do they, right? And Saeed says, and Bhaskar say, trust me, it works, this is better. So let's look at the data, and this is the most recent one from looking at 10, 12, and 12, 14s. And this is the stone-free data, 100% stone-free by visual inspection. This is like 53, 56%. Really? That's so great. And 30-day CT outcomes, 67% at best. It must be me. I don't understand. So what are the other disadvantages? There are probably none left, but there are, sorry. The outflow channel is the same as the inflow channel. So if you keep the instrumental dead space in mind, you have to suck out more than you have to put back in, because otherwise you suck out and then you flush your fragments back inside. How efficient is that? And you're continuously inflating and deflating the collecting system. And as we've seen, you have a lot of, while we're trying to go to wireless ureteroscopy, we have a big tube hanging on our scope or the access sheath, so that really increases the surgical strain. I know the time is up, but I'm going really fast now. There are some more disadvantages. You have to be careful of negative pressure, and the ergonomics more looks like this now, that you need to be a four-handed maneuver instead of a two-handed flexible ureteroscopy. But luckily, Bhaskar has a small robot on his back that helps him to do so. And we already saw this horrible scenario from Saeed himself. Thank you again for showing the disadvantages so I don't have to. And like we know, there is no such thing as a perfect device. New technology always comes with a learning curve, and results are great, but superiority has to be demonstrated in an RCT. Disposable scope would be advisable when using fans, and higher need of pre-stenting even apparent with the 1012 access sheath in contrast to the scope only, and ergonomics, honestly, they could be better. Thank you.
Creo que Bhaskar y Said tienen un amigo menos, ¿no?
Bhaskar and Said have one less friend. Mariano, questions before we start with the cases? Any open question for the presentations? Please raise your hand, approach the mic. The idea is to exchange opinions. Esteban. I still haven't had the fortune of using the discontinuous ureteroscope system. I have used fans, and I think it is superior. In your experience, what is the best access sheath that will experience the least collapse? I have used 3 brands, and I'm using Gigadomeo. And what is the preferred length? You show that D55 is too short. I like the 51 to move comfortably, but with 43, it was too short for a female patient. So what is your preference?
That's very true. I prefer it's a worldwide. If you go to the tall people in North Europe, as I said, different, but the most common that the female is between 40 to 50, 40 to 45, the male between 45 to 50. You don't need 55, you don't need 40. So keep in this range. The length of a scope, we will never have its problems as I showed, but it's only for 55. If you use 55 and he's very long guy, you will have difficulty hitting the scope here, and you have difficulty in swimming inside the kidney. But the most important thing that you have to know which access sheet you're using for each patient, otherwise you will have a problem. So that's why they created the measure. You need to have the measure from the office outside to be comfortable.
So I don't normally measure. Previously, without fans, I would use a 35-45. 35 female, 45 male. Now, you need an extra 5 to 7 centimeter inside. So now it's 42 to 45. And again, for 45 previously, now it's 50 to 52. That's it. So just a ballpoint figure, this is what I use. In terms of size, with the scopes going small, 7.5, I think 10-12 works perfectly. And that is probably the best combination.
Como Thomas nos dijo, esto es un procedimiento
As
diferente.
Thomas said, it's a different procedure which requires a learning curve. Bhaskar, what is the limit to start using fans and no longer use DISS or DIS? What is the limit in volume?
I think there is no limit provided you know your limit. So, you know, the things that will take into picture is what laser do you have? How fast does it go? What is the operating time? What is the patient characteristics? I generally, if you ask me, what is the operating time limit for me? For most cases, 60 minutes. For some cases, up to 90, but never above 90, never, because that's when real complications happen. But by and large, you should be able to do about 80-90% cases within 60 minutes.
Okay. Mariano.
Sí, cuando ustedes hablaban muy bien.
When you spoke about getting started with this, you feel that surgery is different because technically speaking, the procedure is different. And Thomas was just saying, or was talking about irrigation. That's a very important point. When you start using this, you feel that fragments or dust do not come out, just like Said or Bhaskar showed in the videos. So what is your preference for irrigation during the fast or this procedure, considering the water movement and the fact that fragments or even dust may come out more easily?
Thomas, do you have some preference about irrigation? Do you use a pump or syringe? Yeah. Pump, sorry.
For the direct in-scope suction, I haven't used it before. I have used direct in-scope suction before, but not with the disposable scope. I just put on the syringe and I suck out whatever I need to suck out. And for that, of course, I turn off my irrigation. For the suction access sheets, I like to have my irrigation a lot higher than I used to with regular flexible ureteroscopy. Regular flexible ureteroscopy, I had my irrigation bags at 40 centimeters gravity above the patient. But with the suction access sheets, you actually need higher pressure to develop your hydronephrosis to be able to work and to suck out the fragment. It's like a Bernoulli effect as well, with comparable to the PCNL, hovering out the fragments. It's quite comparable with the suction access sheets. So I have my irrigation a lot higher at 100 centimeters above the patient, and my negative pressure at minus 100 to minus 150, I think, like Said showed.
What I have a problem with the DI with this, that's we need every surgical procedure, you need inflow, outflow. The discs have one channel, so it will be multiple collapsing of the system. That's why I'm asking the companies why we have inflow channel, outflow channel, like you are doing transurethral resection prostate or inoculation. That will make you more efficient. The problem with the company, they said we have a small space. If we put 2 working channel camera, it will be bigger. That's why they put 1 channel. And this is the challenge again, the outflow, inflow in the DIs.
So I agree that there is a bit of a learning curve. But one thing I will say, I have always used 1 pressure bag without irrigation, 1 with pressure, 1 without pressure. That really works very well. If you are going to use disc or fans, you do need pressure bag because you are collapsing it. Otherwise, you will not maintain it. I like the disc because you are in control. So if you, the suction is in your hand, how much suction you do. So after a while, you get used to how much suction you have to apply. And I think you can avoid the collapse.
Bhaskar, in Southampton, in a case like this, 8 por 8 por 8, 250, 300 milímetros cúbicos.
150, 300 cubic millimeters, 600 units.
What's your first choice, Bhaskar, in a case like this?
So we have a big waiting list problem. So my first choice for this would always be lithotripsy, shockwave lithotripsy. It may not work, but this is the first choice in all cases.
Said?
It looks good for ESWL. The Hounsfield is good, 600. So if it's visibly seen by the X-ray, is WL is the first choice.
Okay, Tom?
I do almost all my shockwaves under ultrasound, so even if you don't see it under X-ray, I would treat it. And 600 Hounsfield units may even mean that this patient has a uric acid stone, so alkalinize the patient as well.
Toño?
Creo que también falta la distancia focal porque ese paciente es muy obeso.
The focal distance is missing. The patient appears to be too fat. My trend would be to use or to go for flexible ureteroscopy. I think it is important. Industry pressure is towards making everything flexible and retrograde procedures, but we have to take into account that the extracorporeal irrigation is still useful and efficient, and there is also an important security issue. But this we have to discuss with the patient, because sometimes depending on what the patient does, what distance he's located, this will change our behavior in terms of treatment. It is a patient to start with extracorporeal, and if not, we'll move to the flexible one. This is very important. We are filled with new tools, new toys, but here you have 5 experts who come to the same conclusions in renal stones with less than 10 millimeters. We have 2911 stones, 911 cubic millimeters, 1340 council units. This is showing that with a suction sheet, you can suction fragments during the procedure, but you sometimes watch these videos. Bhaskar,
for me, the suction sheet always comes at the end of the procedure. Once you have broken everything, the suction allows everything to come out beautifully. So at the end.
Thomas, do you have any comment about that?
If I would be treating a patient with a flexible suction access sheath, this would be intermittent. I would be treating the patient, dusting as much as possible, because I think that's what makes the most difference. And when fragments occur, I would probably try and evacuate them with the suction access sheath as they occur, not necessarily only at the end.
Okay. Said, how do you set the laser to avoid this, to avoid bit fragments?
Well, the beauty of the fans that it's not important the type of your laser. So whether you fragment it, you will take it out. But I think if you make it smaller and smaller as soon as possible, then you do the suction at the end, it would be possible. The fans is more flexible for the options, dusting, fragmentation.
Thomas.
I'm actually wondering, there's already a lot of literature on dusting versus basketing for the past 10, 15 years. I'm wondering whether or not we're going to see randomized studies looking at dusting versus fragment evacuation with the suction access sheath.
Entonces, es interesante este concepto que transmiten, ¿no?
Concept is interesting. What I would do, remove is fragments that can be aspirated within the sheath and the ureteroscope. The gap should be between 2 and 3 French. These large fragments complicate our lives. They are left for the end when I have removed all the small fragments, and at the end, I will remove this. Mariano? Irrigation is important because you watch the video and you say, well, how easy do fragments come out? But that's where you need to have irrigation in order to have to remove the fragments. If I do not have good irrigation, that's what you see there, the syringe irrigating at that moment. If I don't have good irrigation, the fragment will get stuck in the middle of the sheath. So I will have to go back again to come out later. So this is what changes irrigation in the flexible approach. We always say we have to be careful with pressure using the urinary tract. And now we are applying pressure that we would not have applied didn't we have suction. So it changes the concept. All these we will learn as time goes by. And we don't know 100% for sure, but it's important to understand that it is different from what we did in the past with a conventional sheath.
Do you use in a case like this? Do you use a pump or
what type of laser?
Irrigation.
Irrigation. So always 2 giving set, 1 on pressure, 1 without. And that is what I have always used throughout for last 20 years. The only difference now is I have 2 bags on pressure because the pressure irrigation when you're up, because you're sucking out, it goes down, so you connect the 3rd bag effectively. So, but there is no change in my practice except having more irrigation.
Esto que decía Thomas al inicio, ¿no? Este es un
What
procedimiento nuevo
Thomas
que
said at the
requiere
beginning, this
una
new
nueva
procedure calls for a new curve. You will use between 3 and 6 liters in 1 hour, 1 hour and a half procedure. So clearly it is different. As Mariano said, irrigation is key. Without irrigation, there is no suction. This video with the rowboat aspirating, that does not exist in the urinary tract. It's not that I will place something that will perform the suction. If there is no sufficient irrigation, there will be no suction. I have a question. My problem is that I end up having my thumb in pain depending on the procedure. So what about you?
Do you have any comment about ergonomics?
So to be honest, for suction scope, it's like this. It's very ergonomic. So there is no problem. It's like doing this. For the suction sheath, you have to apply the thumb intermittently. And that's why I think if you just do it at the very end, you can do in between once in a while, but if you do it in the end, but you do need one extra assistant, and I'll tell you why. Because the sheath can sometimes move. So Said, if you just hold it for me. So if you have scoop here, and you've got your thumb controlling the suction, sometimes the sheath can move when you're coming in and out. So you need somebody to hold the sheath for you. Usually you have an assistant anyway, so they just hold was trauma. So you do need a sheath or to help with suction.
There's definitely a learning curve. Right now, I've managed to do it with my own 2 hands and only need the leg of the patient to put the scope on when I put it back in. But there is definitely a learning curve. The only downside, I think, in contrast to the suction access sheath versus the direct in-scope suction, is that with the suction access sheath, you continuously have irrigation in, while with the suction scope, you have to suck out, and while you're aspirating, you're not irrigating in.
Tenías una pregunta.
What's your point there?
Dale, por favor.
Muchas gracias por la
That was a
presentación.
question. Thanks for the presentations. I wanted to ask you, we have got used to complications posed by the traditional sheath, and apparently with suction sheaths, we'll have to face new complications now, especially as in Latin America. We make the mistake of re-sterilizing suction sheaths, and my feeling is that the rims or the borders in long or lengthy surgeries may become sharp and may cause cuts. We fear removing the suction sheath. So what I wanted to ask about your recommendations in addition to not re-sterilizing in order to avoid complications.
That's a very good comment. You know, I was once in India and I was doing a talk about standard sheath put over the wire. And they said, oh, it doesn't always go. I said, why? Because they reuse the wire sometimes, okay? So that is a very good point, that although these things are good, but remember, with reuse and using it more often, you will have problems. So the learning curve needs to be even higher. And you have to be very careful that if it doesn't go in easily, don't force it. And sometimes the scope might get stuck or the sheath might get stuck. So be very careful with that. So although it is very good, the question is, do you need it with every case? You don't. You need it for cases with big stone burden. So if you choose that and then use it, you don't reuse it too many times, then I think you're okay. If you use it for every case, then the coating will deteriorate a little bit, then it'll be a problem.
I'm going to make myself very unpopular. If you're treating large stone burdens and don't want to use too many disposables, do a perk.
Bueno, podemos discutirlo, pero es un buen punto. Es un buen punto. Y es un caso como este, miren.
Good point, and it's a case like this. What Thomas is saying is good. When you has large stone mini perk is less costly with less infection rate. Look at this patient, patient who was running at temperature, lumbar pain. It is obstructing the upper calyx, the lower calyx. It's a truly complex case. High volume, high density, and temperature. We all agree that we need to drain. We are not going to discuss drainage because it would take too long. We have changed our practice. Thomas, I don't agree with you. We treat more stones, larger stones with a retrograde approach. And as a result, the pre-procedure is different. If I think that I can treat this patient endoscopically, my recommendation with a double J. If I'm going to definitely treat her percutaneously, my recommendation will be going percutaneous. This we thought we could resolve because we have had experience over the past few years. We used 2 double Js, one in the upper and lower calyces. We were fortunate. We had to go for a nephrostomy otherwise, but we have resolved the infection. We have resolved, we have a double J in the upper and lower calyces and a voluminous stone presence, which we have determined to work with a flexible ureteroscopy using a navigable sheath. There are some tips and tricks, of course. First, what is negative pressure? Bhaskar?
That's our center, that's our second basement, and that are the machines producing the negative pressure. The negative pressure on OR is minus 100, 150. Okay? What's the level recommended, Bhaskar?
I think this is a little bit low. 100 is a little bit low. You probably need 150 to 200 in most cases. Otherwise, what happens is you go in and you suck, and it's not sucking because the pressure is not enough. So this is a very important point. If the pressure is not enough, the suction will not work. So I think 150 probably is the minimum. I would go to 200, sometimes a little bit more for it to work, depending on how big the pelvic ileal system is. But 100 is a little bit low.
Thank you. So next one. Miren el tamaño de la litiasis.
Look at the size of the stones. We place the sheath. Can we activate the video? Doesn't work. Don't worry. May I ask something? How many of you would have performed a mini percutaneous or standard percutaneous? How many of you would have gone for a flexible one with aspiration, this, with whatever you name it? We agree that you know how much I love you.
How many of you, if you are a patient, want a flexible and not a mini PCNR? If you are a patient in good hands.
Si ustedes fuesen los pacientes, ¿cuántos hubiesen hecho una flexible?
How many of you would have undergone a flexible procedure in good hands? Said, Bhaskar, Thomas, Olivier, raise your hands. And how many with a mini percutaneous? If you were the patient. A super mini, okay.
No, lo borré yo el video, lo borré yo.
I know the video is not working. No, I erased it. Well, listen, 90 minutes of the procedure, 90 minutes, we are within the safety limit that Bhaskar mentioned. This is how we started, this is how we ended. Suction has changed paradigms. Clearly, and I agree with everybody, with Thomas, that there are things that are not clear, but there is a before and after. There's no doubt about that. We can treat lithiasis that we would never have even thought about that. We wouldn't have thought to treat this lithiasis 2 years ago through a retrograde approach, and today we do it. So the patient probably is in a position that if we cannot finish the procedure, we use a combined approach or percutaneous, but clearly suction is here to change things. This is very important. It's not important to set a laser for this or set it for fans. When we do this, we want dust, but fans involves small fragments that get into that gap.
For the juniors, it's you who's doing the operation. It's not fans or mini perc. So this case, I would vote for fans for experts. But for the many of people, you're still in the PCNL. It will come to your house, you will accept it, it will come to the juniors, but we have to guide them. For you, I agree with you. This is not because of the fans, because you are an expert. You understand me? So we cannot tell the people that the fans or the this or this doing the operation. It's the training. We have to guide them towards you, Pablo. You understand me?
Perfecto, perfecto. Me parece un buen punto. Mariano, ¿algún comentario?
No, yo creo que el temor a la
I
percutánea.
think that the fear to do percutaneous, I fully agree that aspiration has come here to change the flexible technique, but people are afraid of percutaneous, and I think that we shouldn't, because a percutaneous procedure will yield very good results, comparable sometimes to 2 or 3 flexible procedures. So I think that is also an issue that is important.
The problem is the training. Nobody interesting to do the PCNL. I have been in the United States. They shifted Cabrat in UK, even in France. This is, I think, I don't know what's happened, but nobody wants to teach residents. Maybe in Argentina or Egypt or India, there are more.
Esteban, cortito, por favor.
Un comentario súper corto.
A very short comment. There are some biomarkers that are being studied to make a difference in the patients that can be complicated or not. In this case, I think it would be useful, ultrasensitive with albumin PCR, to distinguish or to know if I can go longer or not in my procedure. Antonio had a very interesting course in Santiago de Chile, and a FANS was done with a ureteroscope and pressure. And it's very interesting to see that even with a syringe, as Mariano showed, the pressure with that suction of minus 200 is always in 40 centimeters. So you're afraid of the syringe, as Mariano said, but with the right suction, it can be okay. Well, a couple of years ago, we were concerned with where we could hang the bag, because intrarenal pressure had become something of a sensation rather than a measurement. Yeah, that's a good point, because sometimes if you don't measure, you suspect what you're doing, but you don't know. Would you do a procedure with retrograde suction in this case? Well, what Mariano said, I think that a mini is a good option, especially now that we have a super mini perk. So suction is also incorporated in miniature tracts. We have done cases of 3.5 with an 18 tract and with suction, and it is reusable. So some fellows are taught how to do flexible, not percutaneous. This is a tool that we need to have, and I don't perform percutaneous surgery either because I'm not comfortable, I don't know how to do it, or I haven't tested it. So in this case, with the destruction of the parenchyma, you can get in very easily, so there is no bleeding. Well, we are going to close. We've seen all lithiasis for lithotripsy, lithiasis for combined access, but this is true, and this is real. This is something that has arrived, and it will stay with us. Thanks to the panel, thanks to the Mariano, Said, and everybody else. Bhaskar, can you stay, please? And we are going to move now to a module that we were happy with, Luis. Now, we want experts to share with us what was the best thing they read this year. So, Jose Antonio, please share with us what was the best you read this year.
Ok. Ok, para atrás. Ok.
Bueno, Pablo, muchas gracias por la invitación. Como
Well,
siempre,
Pablo, thanks for the invitation. This is an excellent course, so I thank you for the invitation. The best papers of these years are related to what we have just seen, and that's why I chose something different. And I'm going to speak of bilateral wrists, do wrists in both kidneys at the same time. And I would like to speak, maybe I remembered some of our heroes, Jose San Martin, Bolivar, etc., but I remember one that is a Chilean hero. Benjamin Vicuña. Benjamin Vicuña is an actor, a Chilean actor that has had great success here in Argentina, not only acting, but also in love. And he had been faced with the difficulty of having to choose. He was married to Pampita, then to China Suarez. So we know that the prevalence of lithiasis is high. There are many papers that speak about it. And what we have been achieving better rates and the complications will depend on the tools we have. But the prevalence of renal lithiasis bilateral is also very important. It goes between 10 and 25%. And then what to do? What are the advantages of an endoscopic surgery bilateral? Well, one anesthesia, we save one, less disposable devices, less time in the operating room, less admission days, less days missed from work, and the cost. It would be cheaper to do this in one session. But if we see the number of publications from 2015 to this day, there is about one publication a year or maybe two. No one has investigated what to do in these bilateral cases. And here we'll see Dr. Somani has published in this on this topic. This speaks of the possibility and the safety of this procedure. In this case, a study with 25 procedures in 21 patients, with that is the average size of the lithiasis, mean age 46, surgical time 70 minutes, 60% of the cases as outpatient, SFR 80%, one procedure, 92.8 after two procedures, and complications were really very few. It seems to be a safe study, a safe procedure. Now, another study, this is a systematic review, 16 studies with over 1,000 patients, again, the same age, and the stone-free rates are very good. But again, how to measure the stone-free? And in this study, only one case was measured with CT. And the complications, well, we shouldn't forget them. There are very serious complications. 2 patients died and some serious complications. So it seems that it is feasible to do it. And finally, this study, multi-center with 1,250 patients, again, the same age, the surgical time 75 minutes, a high rate of double J post the procedure with stone-free rates, this 64%, and reasons to interrupt the procedure, 85, because of anesthesia, very long surgery, the surgeon decides to stop the procedure, or very large lithiasis volumes. So there are papers about this, and this is a procedure that could be done in one single step quite safely. And this is a paper that was published this year with a level of evidence that is higher, many more patients. This is a German study, and it compared unilateral versus bilateral, and the outcome, the primary outcome were sepsis, infarction, failure, kidney failure, and retention of urine, and a secondary outcome, the admission, expenses, mortality, the need for an ICU, etc. And this comes from a database that is called GRAND. It belongs to the German nationwide inpatient data, and it includes the time between 2005 and 2021. It includes all the data and comorbidities. and the entry of data is associated to the payment. So everything had to be recorded, and the test, chi-square, t-test, etc. And if you look at this, it's a huge number of patients, 833,000 patients. The average age is this. We have bilateral 0.8% and unilateral 99.2%, 69% men, 5 of them with severe obesity, and half of them had a previous double J. And how it evolved from 2005 to 2019 to 68,000 cases a year. And here we have the basal characteristics of each. So we have bilateral and unilateral, and in all of them there is a significant difference. If you see the cases that were done bilaterally, patients were older, more obese, with more comorbidities, in general, patients that had a higher risk. Another important data, this is the evolution of ureteroscopy during all this time. And if you look at this during the COVID-19 pandemic, the unilateral cases were reduced, but bilateral increased. It's something that we'll look into more closely shortly. And what were the complications? Sepsis, relatively low, but when it's bilateral, it increases quite significantly. Also, the risk of infarction, kidney failure, transfusion, infection. So bilateral ureteroscopy in all the cases increases the risk differently than in the other studies. If we go to the table and in a logistic regression model, I mean, I removed all the differences and I put them, all the ones that are the same. We see that there is 140% higher risk of sepsis, 100% of infarction, 180% of kidney failure, but the numbers are very small anyhow. But when we look at the percentages, they call our attention. And if we go to the other complications, patients would remain more time in hospital, more money was spent, 614 euros more, 90% higher risk of being admitted to the ICU, and risk of death, 240% in a bilateral procedure. Bilateral means perhaps that you can die in the procedure. Well, it would have worse outcomes. Basically, they were more complex patients, and meta-analysis has shown 17% complication risk with all these complications, fever, pain, etc. What calls our attention is this high percentage, 0.4%, for an endoscopic procedure. But it has been proven in the CROSS, that is a large study that collected much information, that it would have more retreatment rate, higher surgical time, longer admission. So that's the evidence that it seems not to be not so good. And in this study, bilateral, despite the higher comorbidity, that would be explained because urologists try to solve the case in one single step. Why ureteroscopy has increased in the US? It increases 15% a year, and lithotripsy is reduced by 2%. And ureteroscopy, well, there is a lot of pressure from the industry for it to increase. Now, the ureteroscopy was reduced during the COVID. These were elective procedures, but when the patient came, they made the bilateral in order to solve the case because it was a pandemic. And now, what are the weaknesses of the study? It's retrospective, not too much data about the size, the place, the location, or the number of lithiasis in each case. There is no long-term follow-up. There was no information about a second procedure, and maybe the German population doesn't represent the population in the rest of the world. The conclusion is the large-scale data and real-world data, and maybe this is the value of the study, prove that bilateral ureteroscopy in the same step increases mortality and morbidity, extends the admission in hospital, and it's associated to additional perioperative costs and higher admissions to the ICU. Now, maybe this picture will be difficult to obtain, but maybe in the future we can. Who knows? Thank you.
So, thank you. That was excellent. My bilateral presentation, the paper I did was almost 10 years ago. Since then, I've done more than 200 cases. There are two things that are striking about this. One, they shouldn't be doing bilateral if this is the risk of sepsis, ICU admission, death, transfusion 3%, it's too much. So the question is the patient selection a problem? Is it surgeon who is doing it? Are they experienced enough? Because it is national data. We don't know how experienced they are. The third question is, what is the time limit? And the last, how do they counsel or consent the patient? What do they discuss? So when I talk to them about bilateral, I tell them, if the first side, whichever we choose based on the symptom or whatever, goes very well, only then we go to the second side. So the patient needs to know that if the first side is difficult, if the timing is a problem, if it's more complicated, or there is a problem already on the one side, you will not go to the other side, because all you will do is make it worse. So that is about decision making and consent. Second, choosing the right patient. I would rather have fitter patient undergo bilateral than more complex patient undergo bilateral. It doesn't make sense, because the risk of complication may not be double, but it will be more than single side, right? So why choose the more complex patient for this? And lastly, following the principles of operating time limit and understanding the limitation and doing it in experienced hands. So it's a large database, we don't know who operated and so on. So I don't think it is a problem doing it, provided you respect these parameters. So I have done now more than 200. I don't think our results are like this. They are much better. So I think it really depends. But if you have gone to do bilateral and one side has gone really well, fine, do the other side. But if the first side has not gone very well, please don't do the other side.
Hugo. Sí, Pablo, dos cosas importantes. Uno es una serie retrospectiva de un solo centro.
Two important things. This is a retrospective series of one single center. Patients were older, hypertensive, etc., but this will depend on the stone volume and the comorbidities. It's not fit for every patient, it's more customized. And another additional thing, there is no mention of pain and quality of life. What happens if the patient has two double J's at the end? Has this paper changed your practice? Well, it made me think about this, because we have been doing bilateral in the last 8 years, over 100 patients. And my impression was that they had more infectious events. That was my impression. And I think that now I will reflect more upon it, select the patient better. Maybe it's also a very large database. There is evidence, and we have to pay attention to that. Hugo, can we move on now to your paper?
Bueno, muy buenos días para todos. Pablo, muchas gracias por la invitación. Es un honor estar acá.
To you all, Pablo, thanks for the invitation. This is perhaps not the best, but the most seen in the Journal of Urology last year. It is this one which speaks about steerable ureteroscopic renal evacuation, for large renal stones, a multi-institutional center study conducted in Texas with a large database, 43 patients, with lysis volume of 1392 to 5002 cubic millimeters. It is important to remember what do the European guidelines this year say about this. The recommendation for this, the first option, Mariano said at the beginning, is percutaneous nephrolithiectomy. Risk is more used and has more margin in these patients. Stone-free rate in the single procedure, 56.7%. If the urologist tells you that you will need two procedures, would you prefer percutaneous or endoscopic procedure? 89.3% will be stone-free after 1.6 procedures with a significant degree of complication. But there are patients who are not good candidates for percutaneous surgery, anticoagulated, anti-aggregated patients, quadriplegic with spina bifida patients who have the risk of complication. 20 to 30% require transfusion and have complications. That is why we move for endoscopy in these patients. Basically, you see the images here. It's a 42-year patient with spina bifida. You see the CAT scan, the stone mass in the upper calyx. And there are several things to remember. One is that it is an 11.9 diameter device, large, as Bhaskar said. It's large for Latin American ureter. We're using 6 French, 7 French with a 7.5 channel that allows suctioning fragments of after 1.5. And the Journal of Urology recommends this classification: grade A, 100% stone-free with 0 residual fragments. Grade B, a single residual fragment of not more than 2 millimeters. Grade C, a single residual fragment of 2.1 to 4 millimeters, and grade D above that. So Mariano said it before, everyone performs flexible ureteroscopy, but the question is, what is the stone-free rate, the actual one? You may tell the surgeon what is your experience and what your actual stone rate, because you want, as a patient, to know how you will do. Less than 100 cases, I'm doing well. That if it's a case, a 98.3%, 93.8, sorry, of stone-free rate, and 9.5 require the second procedure. What is coming is new. We do not have it available in Latin America, but under industry pressure, it will come. But we need to have clear objectives and say whether this works or not. Thanks very much.
Bhaskar, your thought, please.
Bhaskar?
So I think clearly suction has come on a big way. This is through a stable catheter. I've read the paper. I mean, two things. One, the size of the sheath is 12-14. It's quite a big sheath. You either need to pre-stent most patients, but I can tell you in most of Europe, Asia, you need to pre-stent for the 14 French. It is not easy. The outcomes definitely are very good, but I have to say only half of them had a CT scan. The other half did not have a CT scan. So it is harder to know, but the true stone-free rate of 57 or 60% is actually quite good. I would say, for a large volume stone in a single session, using this, it's quite good. So two things. One, Thomas mentioned this as well, the cost. It is expensive, $3,000 to $3,500 per scope. It's too much, I think. Unless the cost comes down, how can other people adopt? Second is the size. Now, the size of this 12-14, I'm just thinking what if so we have Pearson have now got the 5.1 with a 9.2. What if that scope became 14 French? Can it have a 9 French channel? I don't know. So you see that the size, and we all want to use small size, not large size. So although this is very good, I think unless the size comes down and the cost comes down, I don't know how all of us can adopt that. It's very hard. But the outcomes are very good.
Hugo, en tu realidad colombiana, ¿cuán frecuentemente vos
Hugo,
podés
in your
poner
Colombian reality, how frequently can you use a 12-14 sheath in a naive patient? We do not do pre-stenting, and such a large sheath is too difficult for us, and it will cause ureteral lesions and ureteral stenosis. Thanks very much. Thanks to all three of you.
Vamos a continuar con el programa y Bhaskar, can you stay, please?
Bhaskar, if you can stay. And we were talking about expert-inspiring papers, and we'll talk about education. First, we are going to invite two major educators who have taught us in Latin America for many years now, Dr. Octavio Castillo and Dr. Norberto Bernardo. Both of you, if you can come on stage, if you can moderate the next session.
Bien, Pablo, muchísimas gracias por la oportunidad.
Thanks, Pablo,
Felicitaciones.
for the
Enorme
opportunity.
logro.
Congratulations, huge achievement.
Por el placer de
And
compartir
thanks for the pleasure of allowing us to
abrió en
share with
educación
who
la laparoscopía en todo México,
opened
lo cual,
laparoscopy in
Octavio,
the field of
gracias
education.
por esta
Octavio,
oportunidad
thanks for this
y vamos a dar
opportunity.
lugar a
And
algo que es
we
muy
will
importante y que a veces la industria nos
speak
pasa
about
por arriba.
something important. Industry
Producen
sometimes
alternativas
overwhelms us. They
instrumentales, pero en
offer
realidad no
plenty
podemos
of
olvidarnos de lo
tools,
básico
but we
que es la
cannot
educación.
forget the
Y para eso yo
basics,
creo
which
que
is
los dos
education.
tópicos que vienen
And that is why
en
the
este
two upcoming
momento es
topics
algo que
are
todos nos tenemos que llevar
something
firmemente
that
a
we
casa,
need to
porque en la medida
take
que
home
nos
with us,
atengamos a estos
because
dos
to the
tópicos que
extent
van a
that
desbordar,
we stick to these
creo
two
que la
topics,
cosa va a ir muy bien
things
para las
will be
generaciones
far
jóvenes.
better for
Entonces,
younger
creo
generations.
que, Octavio.
Octavio.
Bueno, la foto que sale ahí, yo creo que soy mejor en
The
persona.
picture there, I'm better in person, but
Después de la presentación del doctor Salvador,
after Dr. Salvador's
me gustaría ser un
presentation,
héroe nacional.
I would love to be a national hero.
Es una forma de educar también.
It's a way of
Bueno, aquí hay
educating
dos
too.
tópicos que son
Well, there are two
tremendamente
topics
importantes
here
desde
which
mi
are
punto de
very
vista.
important
Si
from my
bien yo no hago
standpoint.
limpieza
Even
cerebral,
though I do
este es un
not
tema transversal
perform
a la
stone
urología y a
removal,
cualquier
this
especialidad.
cross-cuts
La
urology and
educación es una
any field.
responsabilidad de cada
Education
uno
is
de
a
nosotros,
responsibility of each and all of us,
hemos hecho una
those of us
carrera
who have
y
had a
tenemos
career path
de alguna
and
forma una
who
experiencia
somehow
previa.
have
Y
a
este es un problema muy
experience. And
importante
this is
para
a
aquellos
very
que hemos
important
trabajado en
problem for
centros que
those
no
of
son
us who have
académicos. Para
worked in
nosotros es
non-academic
fundamental
centers.
escuchar esta
It's
conferencia.
fundamental to
Y
listen
la
to this
segunda, respecto
conference.
a las
The
publicaciones,
second, as to
la verdad es
publications,
que yo
uh,
veo excelentes
I
presentaciones en
see
los
excellent
congresos
presentations
latinoamericanos,
in Latin
tremendas
American
experiencias,
congresses, very
pero
good
no veo ninguna
experiences,
publicación de
but no
Latinoamérica.
publication
Nosotros
from
hacemos
Latin
trabajo de
America.
tremenda calidad en
We
cada
do
una de los
very
tópicos respecto a
top
sus
quality
especialidades de la urología,
work
pero a
in
ustedes no
every
los
field of
conocen.
urology, but you are not
No,
known.
no los
Uh,
conoce el público.
the audience doesn't
Ustedes
know you.
vienen a una conferencia,
So you
comparten con
come
sus
attend the
colegas,
conference, you share with your
aprenden,
colleagues, you
enseñan,
learn,
pero los
teach,
pacientes hoy
but
día van a
patients
Google
today
y
go
ustedes
to
no los
Google
encuentran.
and
De tal
don't
modo que
find
ahí hay
you.
una segunda
So there is a
responsabilidad,
second
la
responsibility
responsabilidad de
there,
ustedes,
your
de que el público los
responsibility
conozca
for
y
the
que ese
audience to know
público
you
se
so
ha
that
beneficiado con la
audience will
experticia de
benefit
ustedes.
from
De
your
tal modo que hay dos
expertise.
temas que son
So there are two
tremendamente
topics which
importantes.
are very, very
Tenemos dos
important.
grandes
And we
profesores
have two
que
huge
espero
teachers
nos abran
here,
los ojos
two
y nos
professors who will
abran la mente.
open our eyes and
Doctor
minds.
Giovanni.
Dr. Shamani.
Thank you again. That was very nicely put. I think education and publication probably somehow go hand in hand. And I will share with you why I think publication is important and how you can be in this journey. Can I have the slide, please? So, as you rightly say, sometimes when you go to other countries for a fellowship, the one line people use is publish or perish. If you don't publish, you perish. So it's all well and good being in a place where we are learning, but actually, how do we publish it? And why do we need to publish it? And how do we make it a reality? So I'll just give you some insight as the editor-in-chief of one of the main official journal of the British Association. So writing a paper is like storytelling. You know, you are trying to pass, if it's a one message, one simple message, that's all it is. But it's like storytelling. So how do you start the story? Before you begin, you need to know what is out there, what is missing, and what is that one thing you have to say about it. So without that, the story will not be complete. So you need to know what is out there. You don't want to repeat the story. And then you need to look at what is the format. Is it a case report? Who is going to be reading it? If it's an oncology paper, I can't send it to Journal of Endourology because it's not going to get accepted. And then which journal you want to target. So these are very fundamental questions before you start. Then you need to do some literature search. And that search could be in PubMed, in a lot of other databases. You can ask your colleague, senior, or you can ask a librarian. Okay, I'm doing a research on this topic. What is out there in this topic? So that's how you begin the literature search. Then you need to think, once you've done the search, you've got a broad idea, okay, what is the title going to be? Who's going to help you with that? Who is going to be the co-authors? What is the responsibility? It's very important because authorship can sometimes cause problems later on. So make sure the responsibility is clear. And then what are the keywords? The keywords are important because once you publish, how do I know that this paper exists by looking at the keywords. If you don't get the keywords right, your paper will not be seen and nobody will know about it. Once you have done all of that, then you think about how do you write, the actual writing bit. So introduction, you introduce a subject, so you draw in the audience, tell a little bit about what the paper needs to be about, the gaps in the knowledge. So what are you going to address? And then finally, at the end of introduction, what is a question or hypothesis that you're going to present? So this is a standard format which draws in the attention, but you are then at the end of the introduction telling what the paper will be about. Then you need the methods. When I review papers for journals, I reject most papers just looking at that. If the methods is not good, I'll reject it. I won't even go to the results. So it's very important to look at ethics and protocol, sample size. If there is about a procedure like ureteroscopy, how was it done? What are the steps? What are the instruments that was used? What about the statistics? And what is the scope of these methods? Is this a right way of doing the methods? Once you do that, then you come to results. Results could be about using figures and tables, statistics. Avoid duplication. If there is everything on the table, don't put everything again in the paper. It's too much. It doesn't add anything. And infographics. Nowadays, if you've got good figures and infographics, that really is loved by the journals because it's easier for people to cite or present in the meetings and for social media. You know, it's very good. Then you come to discussion, and this is how I space my discussion in my mind. What is the meaning of the study? What is the evidence and what is the downside? What is the plus and minus of the evidence? What are the strength and limitation of your study? What is the implication? What is the single most important point? Or what is the future direction? So in future, okay, I've done this, this is the implication, but in future studies should look at that. This is how the discussion should shape. And then how is it relevant and what is the future application? That's what needs to be in the conclusion. So what is the single most important aspect of the whole study and how can future learn? So the references need to be in the correct style, avoid too much self-citation, people don't like it, and it should be proportionate. So some journals will tell you 25 references or whatever, so stick to that, don't put too many or too little. And then this is the shape of the article. You have the title, author's abstract, keywords, you have the text in that format. Make sure everything is accurate and every aspect, introduction, methods, has its own function. And then make sure you have acknowledged, you've done the referencing, and if there is any supplementary material, because there is a length to the article. So if you do too much, then it will be rejected. Be clear, be concise, and be correct. Don't over-exaggerate. People will know that. The reviewers will know that. Be clear and concise with what you're saying. And then when I'm looking at it, I don't like repetition. I don't like ambiguous statement. This is the best in the world. Don't put like that if it's not like that. You know, be factual. Don't exaggerate. And then there are some aspects. What is the layout? Which font have we used? What is the length? Have you used abbreviations without explaining it? You must explain the abbreviations. Then when you do a cover letter, it's interesting, right? You know who the editor is. Don't say, dear editor. Put the name, dear professor, whoever it is. And then write, it just makes it more personal. It's not good to say, dear editor. That means you haven't even taken the time to look who the editor is. So it's very important to make it personal. Put the title and findings, just briefly, if any conflict of interest in funding. So the cover letter, usually, if I put it anywhere, even if they don't ask, I will have these things. Then probably get somebody else to have a critical look. Make sure you know what the authorship style is, the scope, and make sure the authorship is clear. Who is the author? What is the follow-up? What is the contribution of every author in that? This is very important to present the table and figures nicely, make sure the grammar and spelling. It's really not very good having a very good article with poor English, poor grammar, poor spelling. You have got software to check it. It just reflects poorly on the preparation if you don't do it well. Then you probably need somebody to, you know, if it comes back for revision, let's say. Revision is actually as important as the original manuscript. If you don't revise it properly, it's not going to get accepted. So you need to be detailed letter, respond to every single point, which page number, which line number, and mark all the changes clearly to make the referee's life easy. I've only had maybe in the 750 papers I've published, 5 or 6 which have been rejected after going through the process of revision. Most of the time they'll accept it if you do it in a nice way. Then make sure the ethical statement is there. Don't plagiarize it with ChatGPT, etc. Softwares will catch it. Authorship contribution, and don't try and salami slice the paper. Make one paper into 5. Again, it doesn't help. It's very important to then select the right journal, with impact factor if you want. Whether you pay or not, it's up to you, but it's usually not a good idea to pay because these journals don't get cited often. And then which database is it going to be listed? Is it on PubMed? Not all journals are. Is it on Scopus and so on? Now this is really important. How do you present? Which style do you use? And what impression do you create? Make it simple, answer the question, make sure you use past tense if it's in the results. We did this. We are not doing this. You know, it's simple but important. And complement the tables and figures to go hand in hand. So the table should be simple, consistent, complete. If you have symbols, etc., explain it and be clear. And the title should be brief. And then making sure that the figures are really good. And I'll show you some examples now. So what are the figures like? They need to illustrate the manuscript. Each figure should be a single file. And if you've got journals which are strict, then you can make a composite figure with 6 figures or 4 figures or whatever. But generally keep it simple. So, for example, this is a paper on traffic light system for decision making on stent insertion. This is the figure. It's easy to see. Red, amber, green. When do you stent and when do you not stent? Okay? It really is catchy. The next one. Lower pole stone, how do you measure the angle, or does the angle matter? Again, it's very easy to see. So it's visually very appealing. Next one, between the two figures, it's the same thing. Look at the figure 1B, it's so much easier to understand. Figure 1A, same data, it's so clunky. So figure 1B is so much easier to understand. Again, some points, if your data has to be seen, make sure you focus on the data. Share one main point in every chart if you have to. Label the components clearly. Visual highlighting is important. And then you're presenting to your audience, and that needs to come out. It's not just about the data. The presentation style has to be really reflective. So look at this. You've got AI and who takes responsibility, the ethical challenges and legal challenges. In one aspect, you've got everything. Ethics, legality. This summarizes the whole paper, for example. Similarly with this one. Management in pregnancy, evidence-based approach. You've got everything. The whole algorithm is there in one sheet, which is really helpful about how you manage urolithiasis in pregnancy. Same with repair. So this is a systematic review. Again, for systematic review, make sure you've got a good layout, and then you've got at least a forest plot to show that, because it's easier to understand. That's the paper there. The rest is okay. It's important, but this is the paper. For example, this one, you know, you've got your Kaplan-Meier curve about rate of infections with kidney stones or metabolic syndrome. These two figures are the paper. This is just self-explanatory. So it's very important to capture the key messages. For example, for European school, I'm involved in the school about how do you train people. This is education. Boot camp, basic, intermediate, advanced. In a one picture, you've got the whole message. Similarly, for guidelines, me and Thomas are both a part of the guidelines. This is on follow-up. How do you follow up? One picture says the whole thing. How do you follow up patients? And this is about advances in ureteroscopy and features of ureteroscopy. Two pictures conveys the whole message. So the power of figures and infographics about how you present can't be underestimated. So keep publishing and make it simple. Make sure you follow the rules. Thank you.
¿Alguna pregunta?
Any question?
Doctor, le quería preguntar porque habitualmente
I have a question. Usually in developed countries, in order to be in certain hospitals, you have to have a certain degree of production, of publications, etc. In Latin America, that's not the case. Sometimes it's difficult to motivate the residents or the urologists to publish. What do you think we could do? For instance, people who doesn't come out in them to publish, how could we push them if they don't need it for their work?
It is not easy to motivate. I agree with you. We have the same. In the UK, there is no incentive to publish. Most people don't want to publish. So how I do it, I've got fellows. One of them is from Buenos Aires, Florencia, who used to work here. And by the end of next year, she'll have at least 10 papers. So motivation is one thing, but you have to sometimes nudge and push them a little bit. I'm not saying push them, but you have to motivate them, and they need to believe that your vision will be published. So when they come to me and I give them an idea, they know usually that I will make sure it gets published. So I need to then, as a supervisor, you need to understand the gaps in the knowledge. You need to give them a project which you think will get published. Because sometimes I've also known the flip side, people give them projects, they do a lot of work and it doesn't get anywhere. So there are two sides to it. On the one hand, I agree motivating is difficult, but if they really believe and they can see that, okay, this will get them, or this will help them in the progression or in the next job, I think they'll be motivated. Equally, if you're giving a task, make sure that you also work hard with them, because I have to work hard with them also to try and give them that.
I think, if I may, I think one thing that you said right there is really important. Make them believe it's important.
Yeah.
And that's what motivates them, and it motivates themselves. I find quite often if I motivate somebody to learn about a certain project, they start reading about it, and they see the knowledge gaps, and they get interested themselves, and they get passionate about their own publication. It's it helps, for sure.
Thank you.
Excuse me. I have two questions. La primera,
I have two questions. The first one, the peer review process is extremely long. So when you send a paper for revision, that paper will be published after 8 or 12 months. How can you improve that, especially you who are the editor of a journal? Second, what's your opinion about open access? The open access offers fast peer review, but you have to pay for the publication. What do you think about that? And what do you think about the ethics of paying for a publication? And my third question is, why, if I am invited by a prestigious journal to make a review, why am I not paid?
Oh, God. I agree with everything. I don't disagree with any of what you've said. So I'll start the third question. I think journals and publishers make a lot of money. And I think the review process is not correct. You spend your time reviewing it, and really there is not much acknowledgement. I review for a lot of journals. I review probably 4 or 5 papers, and not just for my journal, for every week. There is no, okay, sometimes they'll say you are the reviewer of the month for Journal of Endourology, I have been one, BJU, I have been one. But there is no real acknowledgement, and I agree with that completely. Journals make money, so how can they reward the reviewers? Second thing about peer review timeline, it is very variable. So some journals take longer, some shorter. Sometimes for some topics, they can't find reviewers. So I can tell you for some of the papers submitted to mine for gender reassignment or something, I don't have it and I can't find somebody. So that is also a problem. But by and large, most journals should do a review within about 2 to 3 months so that you can revise in the next 2 or 3 months, and by 6 or 7 months, it's in print, by and large. The third about paying for it. So there are 2 types of journals. One are big journals that ask for money for just making it open access. So it could be non-open access, but open access, like European Urology or Journal of Urology. They all have, you can pay a fee to make open access so everybody can access it. That is different than paying for a predatory journal, which takes money for effectively to publish. So you have to differentiate between the two. So why would you pay to big journals, which is for open access? Because open access make your article seen, highly cited, and people will talk about it a lot more. That always happens. And then you have predatory journals, which take money for you to publish. That really depends on what topic you are. Some people do it for promotion. They need so many papers. I'm not saying it's right. I'm not saying it's wrong. It's very prevalent, and it's only increasing since pandemic. I mean, there's so many journals now. I personally don't pay for publication, but it's a very individual choice, and I don't want to say this is completely wrong or completely right. So the reality is somewhere in between. So if you're doing a PhD and you need to have a promotion in a year, and you know the peer review will take 12 months, what do? You are stuck. So, and that's why some people then say, fine, I'll at least pay. And I'm not saying it's right, but that's the reality of it.
Bhaskar, una pregunta. Así como
A question. Just as you see in the young generations, the resistance to publish and to continue insisting, also from the point of view of reviewers, it is also, the interest is also being reduced. I mean, in dedicating time to that, how can we or how should we negotiate with this in order to have a high revision standard and so that the level of the publications will not be reduced? And they will be reduced if we don't have a very good group of reviewers. Could you please speak a bit closer to the mic? Thank you.
So I think that's a good point. You know, when I review a paper, I actually learn about the subject. So when I reviewed these two papers we discussed earlier, I learned about both of these things. So when you review as juniors, if you want to find the knowledge gap, reviewing is the best way to do it. And I still am, but I used to be proud as a junior when I got a reviewer invite. I'm like, okay, I've done something so that the journal have asked me to review. And you learn a lot. So it goes hand in hand. If you're interested in publishing, if you're academically inclined, you should review. That will give you ideas automatically. And then it's a question of working on your own paper. If you don't review, you don't get the ideas, then you can't publish. And actually in this world, if you just did clinical work, most of us at some point in life will get a bit tired and it gets a bit boring. Having some interest in academia helps you keep up to date and actually is not a bad thing. And reviewing is the start of that. Thank you.
Adelante.
Hi, good morning again. I'll talk to you about education and urology. This is a very, very interesting and educational talk that we just had from Bhaskar about how to publish, and I think it's a really important topic. But now we're going to talk about education and urology and why it matters and how we should go about it. Once again, these are my disclosures. So what is urology? It's a very broad topic. It's like a Swiss Army knife by now. We're talking about stones, shockwave, ureteroscopy. We have suction access sheets that have entered the market that we need to learn how to use. BPH have different ways of treating that. Non-muscle invasive bladder cancer, do you do a TUR or do you do an en-bloc laser resection? How do you do upper tract urothelial cancer, and so on? And all of these procedures are urology. And all of these have their own learning curve. So if you have to master urology, you have a lot of work ahead of you to become proficient in each and every one of these before you can call yourself an excellent urologist. So let's look at the learning curves of some of these procedures. For instance, for flexible ureteroscopy, I've highlighted a few. This is one surgeon experienced in semi-rigid PCNL, and he was video trained and did dry lap and sim trainer sessions. And he says, okay, I reached success after 20 procedures and was proficient after 40. However, if you look at the data, he was still improving after 80 cases. So how long is the learning curve? Is it 20? Is it 40? Is it 80? Or is it more? And if this is another study, once again, a surgeon with some experience that attended some courses, looked at his first 60 cases and compared the first 30 to the second 30, and surprise, surprise, the first 30 were worse than the second 30, but probably the 30 after that will be even better, and so on and so on. This is a systematic review that was published about 6 years ago, and it shows that to be really good, you probably need about 100 to 115 cases to be good on all accounts, not only time, but also fluoroscopy time, fragmentation efficiency, and so on. So you'll have to look at the highest number, not at the lowest number, to be proficient and excellent at a flexible ureteroscopy. Same thing for PCNL, same systematic review. A lot more papers on PCNL. You need about 105 to 120 cases to be good at PCNL. And the difficulty there is getting the volume. Getting 120 cases of PCNL is a lot harder than getting 120 cases of flexible ureteroscopy. What about ultrasound access, which is a hot topic right now? This was a skilled surgeon, once again. He was used to doing ultrasound-guided nephrostomies, looked at 72 patients. The first 36 were better than the last 36. Big surprise there. How about HOLEP? HOLEP, very known to be difficult and to have a certain learning curve. And this was an experienced urologist. He was novice in HOLEP, but he was mentored for 20 cases. And the flip side here, or the flip point, is about 100 cases. Oh, I have to go back one. About 100 cases in, he was starting to get better. He's starting to get excellent. So he needs 100 cases for HOLEP. And this is a very honest report about HOLEP. This is one surgeon who was experienced in TURP and thulium laser enucleation. And he looked at his first 500 consecutive cases. He had no separate training for HOLEP or en bloc, but he was experienced in thulium laser enucleation. There's still no plateau after 500 cases. So what's the learning curve? Is the learning curve 500 cases? And should we be going through this learning curves all by ourselves? Like I've shown, there's a broad range of reported learning curves for different aspects of different procedures. And there's different definitions of success, excellence, proficiency, and so on. So it may be difficult to compare these papers each one by one. But very importantly, almost all papers report that the novice surgeon had some experience in other fields, was already proficient in semi-rigid radiography or PCNL, or is used to using ultrasound for nephrostomies, or they had course training, animal lab training, and dry lab training. So what's important here? Get training first and get mentored during their learning curve. You don't have to do this all by yourself. I think it's even dangerous to start doing it all by yourself without being trained sufficiently or having at least some experience by watching videos and so on. But where do we get training? Where do we get training? Where do we get trained outside of the OR? You can get trained on models, low fidelity models, high fidelity models, benchtop models, dry lab, wet lab, cadaver lab, VR. There's so much that there's available. You can also have instructional videos. You have MedTube, SurgeQuest, YouTube. There's a lot of online resources on the EAU website, AOA website, the COW website, Endourology Society website. There's a lot of resources out there that are free to reach. You can go to hands-on courses, follow webinars, which are usually free. And you can go to conferences like this one, EAU, AUA, the COW conference, and so on. And please, I would advise you, go to workshops, get some hands-on experience. How about those training models? Because there's low-fi, high-fi, there's a lot of different models out there. And if we look at the models, oops, one back, there's a lot of them that have actually demonstrated that when you train on these models, you increase your skill. Actively mentored training on these models improves your skill. So if you have the opportunity to be trained on these models, please do. And there's a lot of them available for PCNL. You have a few virtual reality things. You have some 3D printed models. You have animal models where you just go to the butcher shop, get a kidney, get a slab of pig, and then put them together, put an ultrasound on it, and puncture it. So you can do that. You can also have a lot of different things for retrograde renal surgery. You can have 3D printed models, you can have animal models, and so on. You have HOLEP models as well, inanimate, and they're really, really good. The downside is you can only use them once. And like a lot of training models, and unlike Thomas Shelby, these training models do have limitations. And some of the limitations are the availability of not only the models, but also tutors. Because you can have a model, but if you don't have a mentor to help you train, it reduces the availability and the added value of the model. Most of them are not cheap. The reusability is limited. For instance, the 3D printed HOLEP model one, you can only use it once. There's a lack of complete surgical procedures for most of these models, and they're not always suitable for every aspect of every approach of every procedure. And for the VR ones, most have a lack of haptic feedback. And if you're using pig models, you need an animal lab, and you have biohazardous model. So the best opportunity in my mind is a fellowship. Whether or not it's accredited or not accredited, it really doesn't matter. But a fellowship really, really helps, I think. And there's the Endourological Society that offers a broad range of fellowships. And if you look on the website, you can search them. Unfortunately, there's only 3 accredited fellowships available in South America, but I'm confident that if you contact some key opinion leaders here in the room, that you will be able to find a fellowship, even if it's for 3 months or 6 months or 1 year. Just get in touch with key opinion leaders and ask to be trained. And with the EU section of Endourology, we're in process of developing fellowships as well. not only through the Endo Society, but also through Europe. The EBU certified programs are useful to browse to see whether you can follow any fellowship training abroad in Europe. Of course, Europe is not that close by to you, and you may need some funding, but scholarships are available. For instance, through the CAO website, you can find scholarships to help you pay for your fellowship, because fellowships are not always paid positions. We also have scholarships in Europe. We have the EUSP scholarship programs that can help you fund your project and fund your one-year fellowship, or 6 months or 3 months or whatever. Oops, I don't know what happened there. There you go. But is fellowship worth it? Why should I do fellowship? Why should I publish a paper? Why should I even bother putting the time in? Well, fellowship does help. And this is a very nice paper by Mika Levi. And there are over 1,000 cases in 23 surgeons, and some were fellowship trained and some were not. And they did multivariate regression analysis, and being fellowship trained helped you reach a better stone-free rate, reduce complication rate, reduce emergency department visits, and increase the likelihood of your patient having some post-op imaging. So yes, being fellowship trained is better for your patients. How about the impact on PCNL access patterns? And this is a very nice study from the States. They looked at fellowship training, whether or not it influenced getting your own access. And of course, it does. If you're fellowship trained, you're able to get your own access. Who gets their own access here in PCNL? Okay. Who gets interventional radiology to do it? Interventional radiology can be very helpful, but how often does it happen that they get you access and you're not 100% happy with it? Or they need to come back because you need another access, and so on. So being reliable on interventional radiology is not always ideal. I'll go fast. There's definitely other benefits of fellowship. You can experience another surgical and training environment. That's really educational, because I've learned so much from my fellowship abroad to how I should be teaching others. You can experience another country, but most importantly, you're a trainee and you get a mentor, just like Deadpool here with the X-Men. These will be your mentors for life. You can build a long-lasting relationship with the KOL and get you started on publishing. If you're a fellow with Bhaskar Samani, you're going to publish 10, 20, 30 papers, I'm sure. But not only a mentor, you also get a promoter. It's not the same as a mentor. Promoter promotes you from going to meetings, opens doors, and offers opportunities. And last but not least, if you're into teaching, you will be training the future endourologists, because seeing residents and fellows become proficient, it makes me tear up. It makes me proud of my residents and fellows. I'm really proud when I teach them something and I see them evolve. So if you like that, if you want to be a mentor, if you want to be Darth Vader, if you want to have a Padawan, become a fellowship trainee, because at some point you may become a fellowship trainer. So in short, some take-home messages. To become good at something, you need to go through the learning curve, for sure. You get mentor training before you get started in EOR. Training models are useful for skill acquisition, but have their limitations. Training comes in many different ways, webinars, courses, you name it. And apply for a fellowship. It will change your life and launch your career. Thank you.
Si hay alguna breve pregunta desde el auditorio, estamos en tiempo. Adelante, por favor.
We have some time for questions. If we start from the hypothesis that every good publication or good education starts with a good analysis of what is published to date. Oftentimes, you enter large libraries like PubMed and you are overwhelmed by the amount of information, how you access quality information. And here is part of my question. What AI are you using to do that job for you? Because there is AI tools.
Of course, there is AI tools, but AI tools for this only exist for last 12 to 18 months. Before that, there wasn't. So the problem with AI tools, and you can use it, sometimes the AI will hallucinate. There is something called hallucination, and it will take you in a completely wrong track, give you wrong references, even create some references of its own. You have to be really careful. So my suggestion would be, if you really want to look at, okay, what is out there, I sometimes would start with a review or systematic review. Not that it's the best, but you can then select because that will give you the synopsis of what is out there. And then if you want to look at some of these papers in more detail, the chances are that review or systematic review mostly will have that important paper. So if you look at that first, look at the papers and then you can cross-reference. Of course, if you want to do a proper job, then you can look at the whole list, but sometimes it's almost difficult or impossible. So that is another good way of doing it. So take the review or systematic review, see what is out there, and then you can make up your mind. But AI tools, I would say to write, don't use it because the journals will catch it and you shouldn't be using it. But to give you some idea about a topic, then it's not bad, but don't use it for academic work per se because it is not acceptable. So we have also had medical students who have used AI and they have been failed in the exam because they can't use it for that purpose. So there is a role for it, but there is in academia, the role is very small.
Ok, estamos en la hora. Cumplimos, Pablo. Estoy contento. Estamos
It's
contentos.
time. I'm happy. We've met the schedule. No one moved. It's a very interesting topic. Now you can check the page of the website of the MUSEO. There are many centers in Latin America for finance training. One is our centers in Santiago de Chile. They are fellows who are funded for 6 months to conduct training in endourology and minimally invasive surgery. So there's yet another place where you can get training. We had great speakers. Thanks very much. And as I said at the beginning, you have opened up our eyes and minds. Thanks very much.
Bueno, vamos a continuar entonces con...
We are going to continue with the first semi-taped surgery by Professor Somani. We are going to invite Thomas Taylor, James Boring, and Felipe Pochard to moderate this surgery.
Thank you once again. It's a pleasure to be talking about the disc, and this time I'm going to show you some semi-life surgery cases using the suction scope. I would not talk about the suction sheet, but the suction scope. I'm also in the guideline panel and the EAU Endourology Research Chair. These are my relevant conflicts. I have to say that most of the videos you will see was edited by Florencia, so I'm very thankful. And what a pleasure. If you train all your trainees very well, you should be very proud here because she is incredible. So this was when Pablo and Luis had visited Southampton and we really had a very good time. So thank you again for that. So going on, let's look at how easy the in-scope suction is. So if you think, this is the suction button, it's just very intuitive. It is at the end of your fingertip. So that's a fingertip ergonomic handle and you've got the suction there. You can do the movement. So like your standard ureteroscope. And this is me just doing the suction there. You can see that you're just sucking and the suction of the fluid is happening. So it's very intuitive. There is no other science behind it. It's really as simple as that. And it does help with the negative pressure. You do need a suction on the wall or a suction which is enough to do the job. Now, rather than showing a long video and me showing suction, I've divided into a few smaller videos of simple cases where I can tell you how the suction is useful in each of these cases. So this was a stone of 2.1 centimeter, recurrent UTIs, 48-year-old female. And what was the idea for me? The idea was to fragment the stone and suck the debris to give a better vision, to reduce the operative time and to keep the intrarenal pressure low because there's a high risk of sepsis. So this was the objective in this particular video. So here you can see the stone. I'm starting to fragment now. As I'm fragmenting, I'm controlling the fluid and intermittently sucking. Because the suction device is at the end of your finger, it is very easy to do. And you can see I'm not collapsing it fully. So when people say it completely collapses, it's not happening. So I'm doing the intermittent suction to suck the debris out, closing the inflow outflow intermittently and keeping on going. Is it easy? It's not very difficult, but there is a little bit of learning curve to it about how you control it and how you do the suction. But it can still be done through your two hands. You don't need an assistant for this. So you are doing the suction, you are doing this controlling, and you're carrying on. Now, what is the advantage in this case? This is a 2.1 centimeter stone. Our operative time was 32 minutes. We could carry on without worrying about pressure and temperature. The procedure was done as a day case. The patient went home the same day. Of course, I left a short indwelling stent. Here, once I've broken, I've gone into pop dusting. So I'll talk about laser setting as well. So here, for pop dusting, this is a Homium laser I'm using, and I'm using a setting of about 0.8, 20 to 30 hertz. So with that, the stones come to the laser. You're not chasing the stones. So you're keeping it stable, and the stones are coming to the laser. So that is your pop dusting setting that you're using for this particular case. And it works really well. Now at the end, when you're coming out, remember that scope suction will not suck out fragments. It will suck out the dust. So that is much more helpful during the procedure. But afterwards, as I come out, you will see that I'm trying to suck some of the debris, and it gets sucked, but not the stones, because that's not the idea. So that was your first case, done as a day case, large stone, short operating time, and you can see here how the dust is getting sucked out, from the mucosa here. So again, it's how you use the kit. Next case is a male patient with iatrogenic ureteric injury referred to me from another center with a small lower pole stone. And the idea was to overcome the stricture and then get to the stone, keeping the pressure low. Now, you can see here, there are 3 short video clips. This is the stricture. It's only just about allowed the wire to go. So I'm using a 7.5, again, suction scope. And I'm doing an endopilotomy. What settings do I use for this? 1 joule. The frequency should be low to give you a contained cut. So I'm using about 0.6 to 6 to 8 hertz, something like that. So I'm making a contained cut so I can get in and I can start doing the job. So that's the first one. Now when I go in, the whole kidney is very dilated pelvic system. So I'm using the suction button to suck out the fragment, to suck out the debris, and to basically collapse the system. So that's the second thing I'm doing. Once that happens, I go to the lower pole, which is where the stone is, and I try and get the stone to me, because remember, it's not always easy in a dilated system with a lower pole. So now you can see I am sucking intermittently, so the stone is coming to you. So I'm using the suction to my advantage to get the stone close to the laser, because otherwise sometimes you have to chase the stone, which is not easy. So with suction, I'm getting the stone fragments to come towards me so I can do the job as best as I can. So suction has got a lot of rules. One of them is the pressure, temperature, without worrying, carrying on, sucking out the debris. And here I'm also moving the fragment. You can see I'm moving the fragment just at the tip of the scope from somewhere to somewhere. Now that doesn't always happen for large fragments, but here, this is the third case, very difficult lower pole, again, 1 centimeter stone. And the idea was to overcome the lower pole and reposition the stone. So this was not me doing it. This is one of our other fellows who is from Switzerland. He's doing this case. So you can see there was a ureteric stone which we dealt with, and then there is a lower pole stone in a very difficult angle in the lower pole. We can forward the video a little bit, halfway, if possible. The AV team, we can forward the video halfway. So here we are just opening the package, etc. But when we look at the stone, it is in a very steep lower pole. And then we try and use a TFL laser. We use the settings with dusting. And for this, I use somewhere between 0.5, 0.6 and 20 hertz. So we'll let it, anyway, it's just the packaging being opened up. So once the packaging is open, for this particular case, because the urethra was quite tight, we railroad the scope up to the kidney rather than putting a sheath. And that's the other advantage, because suction sheath will not always go unless they are pre-stented or the urethra is wide enough. And suction scope is, you can railroad pretty much in most cases, because it's 7.5, you can railroad it up. So here we are, Nico is railroading it up to the kidney. So the idea is to railroad the whole scope up to the kidney, and then we start lasering. And because it is in the lower pole, we obviously try and fragment, but we try and reposition. Again, in this case, the suction helped because with suction, I'm getting the stone closer to the basket. And you'll see that in a minute. So this is just us going up all the way to the kidney. We reach the kidney, then we go to, so as I said, this is the fellow who is doing this currently. So we go up all the way. So the idea about suction, does it really collapse the lower pole? Well, in this case, you want it to collapse. Why? Because you want the stone to come closer to you, so it's easier to grasp. So although people talk about suction in the context of removal of fragment and dust, actually there are other things that it can allow you to do. Especially in a dilated system in a lower pole, it allows you to get closer to the stone and it allows you to manipulate the stone the way you want to. So here we are still trying to find our way. The uretris, as you can see, it's not very easy, but the scope allows you to go up. And there's a little bit of debris again, and you will see once we suck out the debris, the vision gets better, and then we go to the lower pole. So here we are, navigating it. And again, it's a dilated system. We are trying to then suck out the debris. Now the question is, should we suck out or should we let it fill? It depends. If it's a very dilated system, sometimes you have to suck out to make the system collapse enough so you can get to the stone. If there's any questions, please feel free to interrupt me. Yeah, Thomas.
If you have a dilated system, I don't know the mic. I think this one.
Yeah, there you go.
Just for translation. If you have a system that is this dilated and you collapse it completely, you actually create negative pressure.
Yeah, sometimes you can get a bit of oozing.
Exactly.
So you don't collapse it fully. So you are only doing intermittent, and this is the beauty about suction on the scope. You are only doing it intermittently. So here you can see, we are sucking it a little bit to get the stone closer to you because it is sometimes not easy in the lower pole otherwise to manipulate. Once you do it, so you're right, if you try and overdo it, you get a bit of ooze because that pressure is lost, and so you don't try and do that. You just do intermittently a little bit, and you are in control. And now now we have repositioned it in the upper pole. So I just wanted to show that although we talk about suction in the context of fragment and dust, there are other uses, and this one in particular is about sucking the lower pole, collapsing it a little to help you reposition the stone to the upper pole, and then you can start doing your lasering as you would normally do. So there are some other advantages of suction that we sometimes forget. In the interest of time, I'm going to move on, but this is then a standard stone fragmentation. We fragment, but the dust you can see is small. At the end, we had a tiny little fragment that we removed, but the rest of it was completely dusted. The question is, do you then need a suction sheath to remove that dust? Would you stent them? We didn't do either. We couldn't put a access sheet because the urethra was a little bit narrow, but we did not then leave a stent either because it was completely dusted. And that is another advantage when you're using the right tool. This is not the scope, I'm talking about the laser now. If you use the right tool for the right job, then if you get very fine dust, then you don't need to have a stent. And historically, all of us have over-stented, I think, all of us. And now with the newer tools, with the suction sheath also, sometimes we end up stenting because we feel we have used an access sheath. I don't think we need to, because if you completely take the stones out, then you can leave them without a stent. Okay, they might have, some patients might end up with a bit of colic, but that's okay. Now look at the view. For me, the one thing that the single-use scopes have really revolutionized is the view. The view is maintained right throughout, and it's really very good. You get the best digital view that you can. And as we continue to fragment, in the end, we've got a small fragment that we retrieve. So the combination of having the right scope, so here we had the suction scope. Normally, if you wanted to use a sheath, I would have had to pre-stent and abandon. We didn't need to do that. We went up, we did the stone, we removed the stone fragment, it's only dust remaining. So this is the right tool for the right case. I'll move on. So we have already looked at that, so I'm not going to go through this again. But as I said, the suction has got lots of other advantages. Again, we have gone through this. Most people, experts, felt that it was helpful. So what I found useful was that actually the suction helps in all of these areas, but perhaps larger channel scopes are needed. And I think that is probably true. Now, how does a larger channel scope help? For two reasons. One, I think it gets you better suction quality, so the dust that you suck out is a little bit more bigger, let's say, or smaller fragments. And it also helps you with the procedure in terms of the timing. So this is the new piece, and I'm just going to let the video play. The 9.2 French that I've used in a couple of cases, but it was only done 10 days ago, so it's still very fresh. I don't have the follow-up pictures, but I'll show you the 2 clinical cases where we have used it. So this is your the suction, and you've got the bigger suction control. So this is the first one, previous nephrectomy, obese patient with previous, slightly high fever, white cell count slightly high. And here we see left-sided stones in extrarenal pelvis, and then quite a few stones in the lower pole with a large cyst in the ovary. So anyway, the ovarian cyst was first treated. Oh, sorry, can we go back? It's my fault. Can we go back to this? Team, can we go back to the previous slide? The red one? Okay, sorry. It's not working. Let me show you this case. Can you play this video, please? So next slide. Slide after. Yeah, okay, can we play this? Okay, I'll let it play. It is my fault. So here we have, so I'll tell you how it helped. So this, we are using the 9.2 Pearson suction scope. In this, the idea of using the suction scope, the bigger one, was the urethra was a little bit narrow, so we did not want to use a sheath, but we went up with the suction scope. The lower pole was really quite tricky, very, very difficult lower pole. We did manage to get to the lower pole, and again, using the suction, I was getting the stones to come towards me. The lady did not want a PCNL, otherwise that would have been another option. You could do a PCNL, but single kidney, obese patient, lots of stones in the lower pole. She wasn't keen, and I thought, well, the worst is we do 2 sessions, and she was happier to do that than to have a session, because even with PCNL, I wasn't sure we can clear it. So here we are in the lower pole. I'm using a TFL laser. I'm using intermittent suction. But see that it's not collapsing. And again, this is a slightly distended lower pole, you can see, but there are lots of stones, lots of debris. And we are carrying on. And by the way, the video has been completely edited by Florencia. She's amazing in video editing. So then now I'm going to do with pop dusting. So pop dusting, I'm using similar setting with the TFL. I use somewhere between 0.8 to 1 joule, 20 to 30 hertz. And you're doing there, but when you're doing pop dusting, a lot of dust is created. So what do? Again, you do intermittent suction. With intermittent suction, bigger dust particles using the scope is cleared, and I'm going much faster. So this particular case had a lot of stones, and I think we still finished the case in about 57 minutes, something like that, for a really hard lower pole calyx. Now, you can argue and say, well, would you need to do another look? I did do another look for this patient because it was a single kidney, and I didn't want, and I found some more dust that I had to remove on the second session, but this time I could use the suction sheath to do that because it was pre-stented effectively. So you can use the tools you have. So first time we couldn't use that, and this is the last view. You can see that there's a lot of dust, but because of the nature of dust, quite a dilated kidney, single kidney, I didn't want to just assume that she'll pass it. So next time use a suction sheath, and you can see I'm just trying to clear up. So there is a definite use for large channel suction scopes because of the bigger channel size it operates. Sorry, that operative time was 65 minutes for this one. Now, the next one is a male patient. Can we play this? I'm not sure it'll play on its own. Thank you. So again, single kidney because the left side was atrophic. Previous history of Enterococcus fecalis, previous history of infection, low renal function, and you will see big upper pole, almost 2.93 centimeter upper pole stone, completely occupying the upper pole calyx. So again, in this one, did the same thing, suction through the scope using the large channel, went all the way up, and then we are using, this was really incredible. The stone was much softer in this case, but the procedure, because the quality of dust was finer, because it was a softer stone, I could suck out a lot more dust, and we just kept going. And this was within an hour, we did almost what was a 3 centimeter stone with a smaller additional stone. So if you ask me what is better, is it better? So this patient did have a stent because they had sepsis before, so they were pre-stented. But even then, there was a lot of perinephric stranding, and it wasn't a happy. So my aim for this case was to keep the operative time low and to have suction to decrease the intrarenal pressure all the time. And that's what we ended up doing. So we use suction throughout the case intermittently to keep the pressure low. So here you will see once we start, the stone is almost like an infection stone. You can see the stone there in the upper pole, and we start fragmenting. And again, the question is, would I use a suction sheath? Suction sheath is fine for at the end if you want to remove the debris. But during the procedure, you will see I'm going on with this, big scope, and that you can see that fluff, the debris is continuously getting sucked, and bigger debris. So the amount of times you have to stop and start is minimized. And again, you're not worrying about the pressure, you're not worrying about the temperature, you are going on a bit more faster than you would normally do, with a slightly higher setting than you would normally do. And I'm trying to just get the stone. And again, for this particular case, we finished it in less than an hour without worrying about temperature, pressure, as a day case procedure. So you can argue and say, why not a PCNL? Well, I think ultimately, it's patient choice. This was upper pole, single kidney. Again, I think this probably gave a better result. But I don't think anyone can say which is better. I think it depends on your experience and what tools you are happy with. But clearly, if you're a patient with single kidney, then doing a PCNL for me is a bit more traumatic or a bit more invasive than otherwise. You can see at the end, because of the amount of dust you generate, an access sheath with suction would be really helpful here, because that will help you suck out all this. And I didn't have it on the day for this particular case, so I couldn't use it. But otherwise, that will be great. I think my time is up. I'm just going to finish it now. So I've already talked about the advantage, disadvantage, so I'm not going to go into this again. And this is our stone team. This is the pre-Christmas party we always do at my place. So this is all the members of our stone team, including nurses, all the trainees, and myself. Thank you.
There's a question from Norbert.
Bhaskar, one question regarding the suction and the endopylotomy. Do you have any recommendations in order to avoid the stone granuloma?
In order to avoid the stone?
You show endopylotomy.
Yeah.
And the use of suction in order to avoid a stone granuloma.
Okay, so the suction in that, when I showed the endopylotomy, I wasn't using suction. That was just a standard endopylotomy with a standard scope. Once you enter in, then I use suction to get the stone close to me. Because the stone in the difficult calyx, we know is sometimes always difficult. When you do the suction, it collapses the system, which you want, and then the stone comes closer to you. And then you can intermittently fragment as it comes close to you, or you can take and reposition it. And I've shown you one case of each. So although we think suction is only for fragment or dust removal, I think there are other aspects of suction which we can use to help us.
Have you had any issues with the scope getting it clogged? So I've been using the CVAC scope, and it has a 7 French channel, and that does get clogged sometimes. I've also done manual aspiration from a standard scope, and sometimes you get clogged. So how about these? How often are you getting clogged? Are you having to put a wire through to unclog them?
I think that can happen. Fortunately, if you are not trying to extract fragments. So when I'm operating, I always try and just extract the dust. I'm not going too close to it where I'm trying to extract the fragments. If you're going too close to it, or at the end, if you're trying to extract fragments, that will happen. So when I'm pop dusting, the laser is at a distance anyway. And when I'm fragmenting in the beginning, again, the scope is at a slight distance. I'm not too close to it. But that can happen. If it happens, then you have to do it. But with a 7.5, pretty much it doesn't happen. With the 9.2, you have to be a bit more careful, because it will have a tendency to suck out slightly bigger fragments or bigger dust particles.
Did these scopes change your laser choice or the laser settings that you use in your daily practice?
No, but I think I was a bit more bold with the laser, as in, I'm not saying you shouldn't worry about pressure or temperature, but because you're using suction intermittently, you are less worried about the effect of temperature, let's say. But I think all the lasers will do the same job. I don't think it should matter at all.
But did you move towards dusting more than fragmenting and pop dusting, or is that still the same approach that you have to stones that you had before using direct in-scope suction or the suction access sheets?
So I think personally, actually, because the suction sheets will suck out dust and fragments, the laser becomes less material. It's immaterial because even if you have fragments with the right, of course not very big fragments, but if the fragments are small enough, they will still get sucked out as we have seen. So actually the choice of laser is less relevant with the suction sheet. It was more relevant with TFL laser, fine dust. Now it's less relevant in my view because you can still suck out fragments quite easily.
Doctor, ¿algún truco cuando
Any trick when a certain fragment clogs the working channel? What do you do in order to go on working?
So that's a good question. Again, same thing. You know, when you're using intermittent suction, you're also carrying intermittent irrigation. That doesn't allow the channel to clog that easily. And if, let's say, you are going on sucking and you have accidentally blocked it, then you just put a wire and it'll unclog it. But because you're using it intermittently, that means intermittently flow is going in as well. So the chances of clogging is not that high. In theory, it can happen, but it's not that high.
Hello, everyone. You're working with a suction sheet, but what's your opinion on one of those new scopes with the suction channel in it? Have you tried one of those?
That was the suction channel I was showing. So this video was about the suction through the scope. Okay. Yeah. So it works nicely.
And which one do you like more?
I've only used one and I don't want to be biased. I know there are at least 3 or 4 scopes that offer suction through the scope. I have only used one, so I can only tell that is good, but I haven't used the others. So it's probably not correct for me to say that this is the best. But I've used only the piston suction and it works very well.
Thank you.
Bhaskar, one last question. How many of your cases are you using this kind of scopes or for every?
That's a good question. So, you know, when I started off, it was about 15%. Now, probably a third of the cases, we use suction scope. And I don't always use suction for every case, but we just have the suction scope, so it's easy. So when we have to use it, you don't have to change or do anything different. And we don't have to use it for throughout the case. That is also not true. But in most cases, you go in, and even if you use periodically, that adds a lot of benefit. Like the lower pole, sucking the stone comes to you, the procedure becomes a lot quicker. But I would say probably in our hands now, about a third of cases we're using single-use scopes.
So the other 2/3 you don't?
We use standard reusable scopes.
Could you help when you choose which?
Yeah. So if the stones are big, like the ones I've shown, bigger than 2 centimeter, low pole stone bigger than 1.5 centimeter, previous history of sepsis, and sometimes when the trainees are doing it and I'm a little bit worried, then I'll say, well, why don't we use a single use? But yeah, otherwise for difficult cases.
Any final questions or comments? James, any comment? Okay. So, Bhaskar se vuelve ahora. Ha estado más tiempo en el avión que lo que ha estado en Buenos Aires.
Bhaskar has been more time on the plane than here in Buenos Aires, so thank you very much.
Thank you so much.
Thank you. This was a wonderful trip, and I'll pass all your regards to Flor.
Your driver is downstairs.
Vamos a continuar. Vamos a
We will continue. We will close the section on suction, and we will invite now Thomas with us and Saib. Thomas, would you please speak close to the mic and a bit louder because we cannot hear you. We are going to speak of pressure and temperature.
Hola, thank you very much for having me. It's a big subject. I will expose it because you will be surprised how much heat you are exposing during the flexible ureteroscopy. These are my declaration, these are disclosures. So we need to know 3 things. How much heat you apply during flexible ureteroscope? What about my irrigation, the flow, the type of irrigation, chilled, cold, room temperature, and the use of the access sheath and the suction with it. Let's go for the laser. Laser is light, so it's a heat. Remember that using a higher than 20 watt, you're increasing the temperature and the risk of tissue and damages. And this, our publication showed that we have to know how much we apply. That's why one of the fine publication by Pantier, when he published that you have to know the ratio, how much you apply to treat the stone by joules. This is a very nice study, showed that if you apply 80 hertz, you might only 4% hit the stone. So what about 20? You have 50% hit the stone. This is surprising because most of the people, they said put high frequency, and they don't know that increasing the intrarenal pressure, because the target is not the stone, it will be outside. This is a beautiful study by Ali Addouki. He is from Saudi Arabia with the Khurshid Ghani, Michigan. When they applied 40 watts, you can have a tissue damage at a 50 degree. And the tissue damage depends on the time and the temperature. It's a non-linear function. 15 seconds, if you stop and have had that heat, it will cause damage. This is a study by Wilson Molina when he showed that compared holmium and TFL in two modes, 20 watt and 6.4 watts for both of them. And he showed there is no rise in temperature, no issue in salt, and both lasers had the same safety profile. So it's about 20 watt and below. These again, literatures generated temperature in the vitro, both lasers increasing in power, increasing in temperature. So put in mind, high power means high temperature. A study for the TFL showed that above 40 watt is dangerous despite the high flow. Do not say that I will have more irrigation, but I can hit 40 watts. You don't need the 40 watt. You will see. That's why some companies, they have some limited to you. They said, do not invest in frequency. Stay between 10 to 20 watt. You can see this. You cannot go in the ureter between above 12 watt. This is a study that showed that if you can stop the activation of the laser for 5 seconds, it would be much better for you to avoid the heat. Now, what about the irrigation? We agreed about that we need irrigation, otherwise you will have a heat and temperature. This is a study showed that there is no irrigation, there is a heat. And this is a beautiful study when they compare both 5 watt, 10 watt, 20 watt, and 40 watt, where they showed that you need a 40 ml per minute in a 40 watt to avoid renal temperature. So why do you go to 40 watt? And this comes to the first point that we don't need that high much of watt. Another study by the group, American group, where they showed that even 5 watt could result in a tissue damage if there is no irrigation. And this is another point. It doesn't mean that you go from 40 watt, you put 20 watt, that I'm safe. No, you need an irrigation. And this is the problem here. Look, this is occupying a channel 3.6 by a laser fiber, a basket, access sheath, impacted stone. So he works with a 16 watt, but eventually ended by this. Because there is no irrigation helps you. Do not deceive, but there is low power that you are safe. You have to maintain the irrigation. These results of not understanding how does it work. You don't need much of heat. Laser is a heat, so you need to cool it down. Otherwise, you will end with catastrophic results. This is a picture of a patient came to us after 3 weeks. Looks how much heat you apply in the kidney, whitish burning inside the kidney. It's a 30 watt. When I asked the surgeon, he said, I was concerned about the intrarenal pressure, so he did not put a flow. So 30 watt without a flow, he will be in trouble. This is the double structure in the lower ureter, applied by small watt. Look at this, burning all the ureter down. Why? Because the surgeon closed the irrigation. He was afraid of that fragments goes inside the kidney. So he applied 10 watt, but there is no irrigation because he was saying that I don't want the fragment goes out, I don't want to take the flexible. So maintain the irrigation. Do not compromise things for things. This is a patient Why was consultant for it? A patient with the renal pelvis obliteration burning out because the surgeon used a high power with a big scope, no access sheet, so compromising the irrigation with the high power. So patient is 26 years old, completely no renal pelvis, as you can see here. So we are not treating patients, so do not insult more. You have to understand that the laser, you need irrigation. And if you go high power, you have to have a chilled water. Beautiful study by Salvatore and a group of Traxel and Tono. When they showed whether I put warm or cold water, they proved that if you use a low power machine, you don't need to have a cold water. In fact, you need a cold water with a high power. What about the access sheet? This is a study from a group of Liastikos evangelists in Greece, where they show that ureteral access sheet is very helpful, but you have to understand that return fluid is important. Then again, pump of gravity access sheet proved that it decreased the temperature. High power is dangerous even with the large access sheath. So do not be deceived that you have an access sheath. You don't need more than 40 watts, so you need a very high flow. A study by Felipe, when he just say that if you increase the flow, you want to cool that water, you might increase the pressure. That's why you need a neutral access sheet. So the question here, look at the middle. You don't need more than 20 watts. You'll be safe with a 50 ml per minute with a gravity of 100 centimeter. So stay 20 watt, keep the flow, and be cautious with this kind. You will have a fantastic results. This is impacted stone, maintain the irrigation. You don't need more than 12 watt inside the ureter. Again, impacted the stone, maintain the irrigation, hit the stone gently in the center. This is a 6 watt rule in the TFL. Uteral access sheet with suction helps you to take this heated fluid. If you work with a high power, and you will heat the fluid. That's why you need a suction in sometimes. Again, to the beginning of my lecture, that you don't need a 40 watt, you need a 20 watt only. Dusting, direct scope, as explained by Professor Soumani a while ago, that direct scope suction keep the dust away and helps you to take the heated fluid from the kidney outside. So it helps you to remove that hot fluid inside the kidney. My take-home messages here: stay below 25 watts in the kidney. Stay below 10, 12 watts in the ureter. Do not invest in frequency. You know that you will lose some outside. 40 watts, you have to apply 40 ml per minute, which is impossible with occupying a channel, or use a cold water if possible. 20 watts is for 15 ml per minute is the safe intrarenal temperature. Ureteral access sheet is important to reduce the temperature. Interval pause might be required. Drainage hot water is essential, and suction is an add for sure to reduce the temperature. Thank you very much.
Bueno, buenos días. Gracias, Pablo, por la invitación. Gracias, Luis. Primero, una pregunta quería hacerle con respecto al tema de que pareciera que la presión intrarrenal ahora es Perdón, la traducción.
It seems that intrarenal pressure.
Ok, va de nuevo.
So we go again here. Nowadays, intrarenal pressure seems to be a solved topic, and this with the suction devices, it's better. Do pumps play a role, fluid pumps play a role, because we know lots of irrigation to manage the temperature and to manage this type of devices?
Yes, of course. The pressure you need to be measured, but because most of the company, they invest in the pressure rather than the temperature, because temperature is solvable. You can solve it. It's a 20 watt, you don't need more than that. So they are not interested in measuring the temperature as the pressure. But the pressure, yes, we need to measure it. They want to invest more in it. But the temperature is easy. Keep 20 watt and keep the maintain irrigation. Be logic, seeing the return fluid coming out, and that's it.
¿Alguna pregunta del público?
Question from the floor.
Thomas.
Thomas.
Okay, good morning again. I'll put on another hat now. Before I had the hat on of showing you the disadvantages of suction. Now I'm going to talk to you about the advantages of suction. Thank you, Pablo, once again for giving me these two talks. So let's talk about pressure in the suction era. Am I talking loud enough? It's fine. Closer. Okay. It's good? All right. Translation can hear me as well? Okay, great. So pressure in the suction era, once again, these are my disclosures. But what is the problem with pressure? And there's a few companies now that can help us measure pressure, and Said told us that it's really important. But what's the problem with pressure? Well, we have fluid backflow, pilotubular, pilolymphatic, pilovenous backflow, and we are worried that we can also have a fornix rupture. And if we have vascular resorption of fluid extravasation, and if that fluid contains bacteria, we can put bacteria into the system. And this can cause infection, this can cause urinoma, and this can cause, for instance, an absorption syndrome. We don't know that yet. So what do urologists think about pressure? What are the consequences of an increased intrarenal pressure? And if you look at the results of this survey, most urologists think that an increased pressure will cause bleeding, will cause renal damage, will cause infection, postoperative pain, and so on. And they think we need irrigation. So yes, but how much irrigation do we need? And if you look at it, what do we need it for? We need it to create space. We need it to reposition stones, maybe. We need it to clear the view of dust if we don't have suction yet. And we need to clear the view of hematuria. We need to reduce temperature, so that's another thing we need irrigation for. But if you have sufficient inflow, if you need sufficient inflow, you also need to have sufficient outflow. Plus and minus has to be about 0. So how much do we get? And these are a bunch of studies that have been published so far. And if you look at the data, we get about 5 to 25 millimeters per minute just by gravity irrigation at about 100 milliliters, about 100 centimeters above the patient. This is about 5 to 25, and we've seen that this is what we need. But irrigation also increases pressure. We need it to decrease temperature and so on, but it increases pressure. And this is in an in vitro study with an URFV2 and a 1012 access sheet with different irrigation studies. This is by Traxler's group, and it's a very famous paper. We see that we get a very, very high pressure if we use irrigation, a lot more than 100 centimeters water above the patient. 136 actually, that's 100 millimeters of mercury. So to reduce pressure, use access sheets. And yes, in vitro and ex vivo and vivo, we know that placing an access sheet decreases the intrarenal pressure. And an occupied working channel decreases the intrarenal pressure less, but we need in-human measured data. Luckily, by now, we have that in-human measured data, and we can measure it different ways. We can use a pressure wire from different companies, or we can use a pressure sensing scope like this one from LithoView, from Boston Scientific. But if you look at all of them, I'm going to go a little bit faster. These are a small series between 20 and 120 patients. All of them are observational studies, and it has a variety of stented or not stented patients. And interestingly, the intrarenal pressure was not significantly different in pre-stented patients or in patients treated with an access sheath. The only study where it did make a difference was with the LithoView Elite. So we may be thinking that the pressure wire and the pressure sensing scope are sensing the pressure differently. But how can we optimize our working environment? Because we need to increase the visibility, increase stone free rates, increase safety, so we want to have an increased inflow, because we want to have that high power laser and so on, and we want to reduce pressure at the same time. So what is the response? We can do PERC, but we want to be less invasive, so no PERC for this patient. So we add suction to a straight access sheath or to flexible tip access sheath. And there's a bunch of them on the market right now. I don't know which ones are available to you, but there's many of them available on the market right now. And when we add suction to an access sheath, we do see that it reduces your operative time, The stone-free rate is quite the same, but it reduces the infection rate. So this is where suction maybe makes a difference. How about the flexible suction access sheets? And I've shown this study before. They show really, really good results for fairly large stones. Not ideal for really large stones or stones in the lower pole, but the data is still young, and we may learn something or two before that. And only 2 people have developed fever in this study. And this is an interesting matched pair analysis comparing a flexible access sheath to a traditional access sheath. This is a matched pair analysis. This is not a randomized study. And I saw that the stone clearance rate with the suction access sheath is a lot better. And most importantly, because we think pressure causes fever, these patients had less fever and less febrile complications. But what is the pressure? We've not sensed the pressure in these patients in these studies yet. What is the pressure? And this is an ex vivo porcine study that's published about 2 years ago. It was quite interesting. They had a pressure wire outside of the kidney, or from outside inside, and they measured the pressure with and without suction. And they had these very, very nice curves that you can see behind Dr. Ramirez's face. We see the red curves of pressure going up, and when you apply the suction, the pressure goes down. But have you measured it in humans? Yes, we are getting measurements in humans. This is a study that is not published yet, but it's under review in the World Journal of Urology. We've talked about open access, and this is a study that's already available before having been reviewed, so some caution is required. This is for 25 patients, an observational study with a retrograde intrarenal procedure using fans 11-13 or 12-14, and they saw that with the 12-14 and the 11-13, they had pressures below 40 centimeters of water every single time. And with the access sheath, on or off, it made a huge difference. But this is a measurement with the LithoVue leads. We measured at the tip, and the tip of the scope is almost always at or inside of the suction access sheath. And the pressure in the renal pelvis, we don't really know yet. I've shown you that there's a difference between sensing pressure with a wire and the scope, so we need to have this data with the pressure sensing wire inside of the kidney as well. And we don't know whether or not this benefit of the suction and the pressure reducement also benefits infectious complications from a randomized study yet. So suction is great, but is it better? And we've seen this study before. There is no statistically significant difference for stone-free rate, auxiliary treatments, and so on, or sepsis, but there's 5 studies, 5 randomized trials that show that there's lower overall complications, lower infections, and lower fever rate. No sepsis, but yes, lower fever rate. And this is an intelligent pressure control system that may make a difference in the future that will tell us when we go over a certain pressure, or it will increase the negative pressure when we go over. And interestingly, the number of cases with post-op fever was a lot lower with the intelligent pressure control system. Once again, very limited data so far, but this study started 10 years ago. We've had this technology 10 years ago, intelligent pressure control. So I think we should be doing more with this than we're doing right now. This is the first RCT coming out, comparing a regular access sheath to a flexible suction access sheath. 8 centers, 320 patients. Finally, this has come out just recently, and it shows better stone-free rates, short-term and intermediate term, and less basket use, but most importantly, a lot less fever. So yes, pressure may be making a difference in these patients. What about the future developments? We've seen that we've been using an intelligent pressure control system for 10 years in straight access sheets, non-flexible bendable tip, but this is coming as well. Flexible tip suction access sheets with an intelligent control pressure system. And I think this may be the next step that we need to use to be more safer for our patients. So as take-home messages, intrarenal pressures can get really, really high in patients during endoscopic procedures. A regular access sheath reduces the pressure and increases flow, but that's about it. Adding suction to a straight or a flexible tip access sheath reduces pressure even more, which we believe is important because it can reduce post-op infections. We've seen that from 1 RCT so far. And intelligent pressure control may help us improve safety and efficacy for retrograde intrarenal surgery. And don't forget, if the pressure is too much, add suction. Oh, there you go.
¿Alguna pregunta? Creo que es un tema bastante interesante.
Any questions? It's a quite interesting topic.
Intrarenal pressure during your flexible ureteroscopies? Do you routinely?
Could you repeat the question?
Yes. If you do you measure the intrarenal pressure during your flexible ureteroscopies?
It's a good question. Honestly, I don't have a pressure sensing wire. I'm in the process. I'm working with a company right now to get the machine and to get the wires because I think it's an important topic of research. The way I measure intrarenal pressure is by looking at the inside of the patient and sometimes by opening a tap on my scope. I usually have my irrigation bags at 40 centimeters above the patient. And if I'm working in the patient, and if I see that if I'm not doing anything, if I'm not manually irrigating, I still see flow coming in the patient, the pressure inside of the patient is lower than the pressure in the bags. What I sometimes do if I don't have spontaneous irrigation, I open a tap, I take off my valve, and I see if the water is coming back out of my scope. I hold my scope up. It's simple physics. Hold my scope up and down, and that way you can measure the pressure inside of the kidney. It's how blood pressures were measured in the past. It's easy. To reduce pressure, if I don't have an access sheath or don't have a suction access sheath or a pressure or a suction scope, I sometimes honestly just pop in a needle. I use my ultrasound, I pop in a needle, and I have an exit for all the irrigation that I need to reduce temperature, and I reduce pressure with the needle.
It's true that the pressure in the flexible or retrograde intrarenal surgery, because it's a closed system. That's why we think about pressure, because we didn't think it in the PCNL. Even with the miniaturization of PCNL, because it's out system. I was in China 2 weeks ago, and they work with a 300 pressure, but it was good because they need suction outside. But in the flexible, because most of people, they start to doing it without realizing, so the problem came back to the companies and for us. That's why now they are looking for safety, not looking for the results.
Yo particularmente, a ver, me hago una pregunta para todos. Creo que
I ask a question to myself and the rest of us for us to think about. I have something special with pressure. We are all in agreement that having high pressure is our biggest fear. It will be the most important reason for complication. Now, some of you, all of you, do you measure pressure as you are performing this type of surgery? So my question is, Thomas showed that we know the lithoVIO lead is available and some other things are coming up, but we are in 2024 with so many developments. How come we are still performing ureteroscopies without measuring the most important complication factor? This is something we should discuss with companies. We work together. They need us and we need them. And this is something that I believe is of the essence. I don't know what you think, not just Thomas, Norberto as well. Very good point, and I thank you for bringing it because the industry is not providing answers. We have a Ferrari, a Lamborghini that are working better with greater horsepower, but we are still using a blind dashboard. We don't know the speed, the revolutions, and industry should provide a response to this. With suction, the big advantage shown by suction is that intrarenal pressure drops, so volumes will start to be measured. And with this, which is innovative, we may have this tool at hand. I cannot find a response. It's just what you said, Norberto. We have stuck to measuring time. We get stuck with measuring fragmentation time, but we are limited when it comes to measuring pressure. Thomas, Said, what do you think?
I think we went far with the flexible ureteroscope. We start treating big stones. That's why we spend time on it. I think it's time to go back to the mini PERC a little bit until we figure it out. Because who's pushing us is lack of training for the juniors about the PERC. And second point is the company who's pushing for flexible ureteroscope because it's the most profitable for them. PCNL is not giving money for them. It's something they cancel the disposable. So we have to make it clear for the pressure that we have to talk to the QOL, talk to each other about the problem, and talk to the companies. That's it.
Yeah, I fully agree, and thank you for emphasizing the fact that PCNL is not dead. Quite on the contrary. And I think that the downside of PCNL is, and it's somewhat losing popularity, I'm afraid, because of industry and because of flexible ureteroscopes being pushed. Putting a flexible ureteroscope in a kidney is not hard. Gaining access into a kidney with fluoroscopy or ultrasound-guided access is hard. So the step of going to flexible ureteroscopy, if you haven't done it yet, is a lot lower than going towards PCNL. But I think, honestly, for thinking about pressure, PCNL gets you the lowest pressure every single time, especially for larger stones. And I like the fact that you say that you're going back to PCNL, and I feel the same way. I'm not 100% sure that pushing the limits for larger stones with flexible scopes is better. And coming back to the point of Norberto and yours, we think that pressure is the most important aspect. But until recently, we didn't know. We thought it was that way, but we didn't know. We only had circumstantial evidence that pressure causes infection. Right now that we can measure it, we'll have the evidence. But until recently, we didn't know, so you can't blame industry for not having anything to help us there because it was just circumstantial evidence. But research is going so fast, and a new scope is coming out every time I blink. So I think that research will really help us evolve fast in the next few years.
Esteban, en la última.
¿Hay algún estudio?
Esteban, there are some studies. Is there any study showing the damage caused to mucosa and calyxes because of suction? I personally fear increasing irrigation too much. Even though in the case of percutaneous surgery, we have a larger vision and we're working towards the pelvis, not towards the calyx, we have a wider space to dilate. And the damage caused because of hyperpressure may be for a couple of seconds, and then there will be major complications. So are we measuring damage, or will it be measured when increased suction, irrigation suction fails, pressure boosts, and then we are faced with every complication? That's a source of fear, but I know if it's being measured or it will be measured in future.
I think that how do you know that the pressure causing a problem? We don't know. That's the problem. At the beginning of the procedure, or at the end of the procedure, or mid the procedure. That's why the pressure measurement is important, not only for the experts, it's for the young who's trying to start to avoid their problem, because if they have this kind of complication, they will go back, they will be afraid, and the victim by the end is the patient, because we pushing towards not. That's why measurement of pressure is very important, especially for big stones or operative time longer than usual.
Bueno, muchas gracias. Vamos a ir al coffee break.
Perdón, no vamos al coffee break.
No, we are not breaking for coffee. Daniel, can you sit down, please? We are not breaking for coffee. We will speak of HPV tomorrow. Thank you.
Hemos hecho una pequeña modificación. Profesor Bernardo, doctor González, doctor Barea.
We have changed.
Nos acompañan un momento, por favor.
Could you please come up? This picture is several years old. This is 2017, and this is how the novel started. This is 2017, and this is how our courses started. My Professor Josie, Gabriela, my wife, Dina, Christian's wife. This was in 2018. Sorry, the 2017. This is 2018. The course started to grow. We started here in the hospital, and then we had to move to a hotel because it was too small. And we were just a few. Then we had tables in the hotel, and so we had to put up chairs too. And then the coming years arrived, and in all these years, there have been many people who have helped us. And today, my first slide was a thank you. And now, with Professor Ameri and Gonzalo, we decided that it's important to thank. And we want to thank two persons who have been with us always. Norberto, Mariano. Today we spoke of education. Every year, you travel throughout Latin America sharing your knowledge, sharing your tips, sharing your mistakes, being totally honest and transparent. And that's why in Latin America, you are leaders. You are leaders because you are honest people, you are generous people. And with us, you have been very generous. So there is a witness here, Dr. Sandro Barea, who has been with us since then. And we have asked Sandro to share with us several words for you. The urology, I am very thankful for the specialty and the urology, not always because this is how I earn my money, but along 30 years, I've met many people, colleagues, each of them offers something. Each of those persons has different qualities, surgical skill, they are good teacher, others are exceptional people that become your friends, but just a few have all these qualities together. And look, Gonzalez is blushing, but this is true. And thanks to these different people, urology and endourology here in Argentina is today where it is. So we have learned, I've seen Mariano grow since he was a resident. Now, one day you'll be here, but thanks to you, to them, we are very thankful, and I am speaking on behalf of all of you and the Urology Society of Argentina. So I ask you please to give a big hand to my friends.
When we talk with the friends about this award, we talk with the common friend. John, are you hearing us?
I do. I am here.
Good morning.
Good morning.
We can hear you. Just a moment, please. John Denset es el presidente de la Sociedad de Endurología.
He's the president of the Endourology Society, and he's a good friend of us. And when we told him that Mariano and Norberto would be honored today, he said, I want to be there and I want to be live. So.
Just a moment, please, John.
Okay. Well, thank you, Pablo, and good morning to all of my great friends in Argentina.
Mientras tanto, Sandra, ¿te podés parar, por favor?
Sandra, could you please stand up? Sandra is Mariano's wife. Please stand up. Gabriela is my wife. You know her already. Mariano is here, as Carlos said. When you are on the stage, it's because someone supports him. And Vanessa is not here, but she is with us. And if we are here, it's because someone supports us. Someone gives us advice, listens to what we say, establishes certain limits. So that's the case. So thanks, Sandra. Thanks, Vanessa. Because without you, thanks, Gabriela, too. Without you, there's no way for any of us can be here. So also a big hand to them.
So I don't know if you can hear us. I think that we have a problem.
I can hear you, Pablo. Can you hear me?
Hear you. Okay, we can hear you very well. Please.
Okay. Well, good morning, all of my good friends in Argentina. Thank you, Pablo, for asking me to say a few words here at the opening of your meeting. And my congratulations to you. I know you've been doing this meeting since 2017. We just heard the history a moment ago. It's been a very successful program. And I do want to give a special greeting to my great friends. I know they've been supporters of your meeting, Roberto Bernardo and Mariano Gonzalez. When I think of Argentina, I think of three people, Pablo, Mariano, and Roberto. We've had great times there. We've done many programs together and had wonderful experiences. So my congratulations, my friends. You've got another great meeting this year, Pablo. Looks like a great faculty, and I'm sure it will be excellent. My final comment, the World Endourology Congress is coming to Buenos Aires in 2 years from now. And I know you guys will put on a fantastic meeting. I think it will be one of the best World Congresses there have been. You've had a lot of experience, and you're just great people to be putting on the meeting. I look forward to seeing you then. Thank you again.
Thank you. Bueno, y finalmente, antes de irnos al...
And finally, before the coffee break, you saw the video at the beginning. We Argentines have a pilgrim in Rome that guides us, and we've asked him to be with us. He couldn't come, he couldn't be with us live, but he has sent a prayer that we will give Dr. Gonzalez and Dr. Norberto together with the diploma. Just words of thanks for the surprise. Pablo, the role, your role is very important, but from here and remembering what happened a long time ago, I have two messages, especially for the young people, besides the thanks. You should know that the best in this area is yet to come. So the best is yet to come. This is my message. So take the opportunity. And the role that we play has to do mainly with learning something that we were taught. And it is also a matter of offering opportunities and to take the opportunities. We're here because we have been given opportunities and we were smart enough to make advantage of them. And how does the story go on? Well, it's exactly the same, to continue to offer opportunities. So thank you for this surprise, and it's really very, very touching. Thank you.
Bueno, la verdad que sorprendido.
Well, I am surprised and also very touched. A couple of weeks ago, I was thinking that in 2 years I'll turn 50, and you think I'm old, but Pablo is older than me. Just to make it clear, although I wear glasses, he's older. And you analyze that in life you have to be lucky, and I am a lucky person, and I am not just saying it, I'm a lucky person, but I was born in Quilmes. My parents always supported me. Then I met Sandra. She also supported me, and she always pushes me, and she is the one who allows me to grow. I was lucky to get into the Italian hospital with great doctors, and Peter Dials, also a very generous guy.
Un tipo que la verdad que nos dio
Who
todo.
gave us everything, because he lets you grow, he lets you move forward, he pushes you. And then I was lucky to have people with me, Cristian, Diego, Fede, Denguille, and all my mates at work, but also a guy who is my mate in endourology, Pablo, who is very generous, and he has allowed me to walk with him and be with him. And although my wife supports me in everything, I appear in more pictures with Pablo than with my wife. And I am also lucky to share with big guys, many people who support us. That's why I say I'm lucky. Probably because you are in the right place at the right time. And this is what one should not forget. Not forget to thank, not forget to acknowledge beyond you can do and how much effort you make. What is important is who is beside you. And as Norberto said, pushing this forward and supporting this so that the young people will grow. And the opportunities, you have to take them. The opportunities are there. You have to take them and grow. So to the German hospital and Pablo, thank you so much, and thank you for this beautiful surprise.
Vamos al café. Gracias.
And now our coffee break. continue with our programs. Now we'll have the second surgery pre-recorded. We'll ask Dr. María Jesús Iglesia, Cristian Cristalo, and José Ignacio Acuña, our moderators. We are going to run the video, and the idea is that it will be interactive, everybody will participate, so that we will stop the video and discuss certain aspects of this surgery. Beyond showing how flexible ureteroscopy is performed, because that's what we are going to do using a suction sheath. And the idea is to share some tricks and tips. As we saw this morning, it's a surgery, and I agree that it's a surgery that we knew how to perform a flexible ureteroscopy, but we had to change it. So I agree with what was said this morning when they discussed suction, that there is a learning curve, and we have already performed several cases this year, and we want to share them with you and with all our audience. So let's play the video.
Vamos a pasar a presentar el caso. Bueno, primero agradecerle.
We'll present the case. Well, first we want to thank for the addition of the video. This is a female, 65-year-old. She came to the hospital because of a left renal colic. Now we are going to see the CT scan, but she had a left urethral stone, 12 by 8 millimeters. We generally try to do the volumetry of the lithiasis, not only because of a matter of trying to record the results, but to understand the treatment that we're going to choose. It's a soft lithiasis, 550 UH, and in the context of the acute situation, it was treated with a double J, and we could confirm the push-up of the lithiasis in the kidney. And here I want to ask our moderators, what is your plan with this patient, María Jesús? Or any of you. If you want to pass the mic, please. I have no plan. The patient has lithiasis in the proximal ureter, and she has a double J, and now the question is, where is the stone? After placing the double J, do you request to see an image before planning ureteroscopy, or in this case, it can be an extracorporeal lithotripsy? Do you plan with an image taken after the placement of the double J, or you plan directly and you say, okay, since there is a push-up, then we go to ureteroscopy or whatever? Well, in our case, we get a CT, a low-dose CT scan to plan. Well, we too. No, I wouldn't have obtained an image after the placement of the double J, because it won't change too much the indication of the treatment beyond the location of the stone. It's soft, it's not that big. There's a pre-stenting. It's ideal for an endoscopic, a flexible approach, probably with aspiration sheath. Yes, the pre-stenting is key data, because in this case, not because we planned, but this is because of the renal colic. She got to the hospital like that. The double J was placed. We had a pre-stented patient and lithiasis, and we had seen the push-up. We get an image prior to the procedure because of our protocol, but we plan on the basis of this data. So let's go on with the video. so you can see the CT. This is a 12 by 8 stone. In some views, it measures 5 millimeters. So we take the volume, but you saw in the CT, do you use that method prior to a flexible ureteroscopy in this case? I mean, measuring the volume of the stone to know, for instance, how long it'll take. Well, to measure or to define your strategy and to go to the procedure ready to treat a different stone. In this case, it was a bit larger than 1 centimeter, when the volume was a bit smaller. Well, as Christian said, this is a pre-stented patient. We indicated a flexible ureteroscopy. In this case, we used a single-use ureteroscope. It is 7.5 French. It's red pine, that's the brand. The diameter is important because, as Christian said, we are going to have a flexible ureteroscopy with suction sheath, and we discussed this today. This issue of the diameter between the sheath and the flexible ureteroscope. The recommendation is at least 1.5 French. If larger, the better. And my question is, in this case, a patient that was pre-stented and you're going to use a sheath, the question is whether you use or not, but let's say you use a sheath. What diameter would you choose? Well, I think this is an ideal case for a sheath. I would try and use 10, 12 French to have that difference in the diameter. At least in Argentina, we find some difficulty in order to get the authorization for the sheath, and in many cases we have to re-sterilize. So I wanted to ask you, what do you do, and what has your experience been with reused sheath, because it loses its hydrophilicity and many times it just doesn't pass through. So in that case, I can not use a sheath and it will work well. Well, that's a good message. We have to plan the surgery. And it's not just using a suction sheath for all patients. In this case, we had a large stone. And I think that suction in this case, and we'll see it in the video, will help us quite a bit, especially with regarding to the duration. But what you are saying is the truth. I mean, we re-sterilize the sheath. And you have to be cautious with them because the flexible portion of it loses. Well, it's not the same as when you use it in the first surgery. If you compare to the fifth, it's different. It's true that they last quite a few, and we re-sterilize, and we re-sterilize maybe even up to 3 times. So one should bear that in mind, but it's a good message. And especially because of the cost and the use, you have to choose the case very carefully, not to use a sheath in every patient. I'm sorry, we cannot hear. We always try to maintain it wet, but we don't use gel or some other substance for the push-up. I don't like it too much. This is absolutely personal. I have no explanation to say no, that we don't use a gel or something. I'm sorry, we cannot hear what the person is saying.
Bueno, nosotros en este caso elegimos
In
utilizar
this case, we decided to use a sheath. You'll see it, an 1113 sheath. And why? 1113 because it was a pre-stented patient, and the truth is that the notion of trying to increase the diameter or the radius between the urethroscope and the sheath is the message or the most important recommendation. Here you see it, it's a sheath, a suction sheath, flexible. Crear Petra is the name, the brand, and as you see there, it can do active suction because it covers that hole, and it maintains the deflection of the ureteroscope despite it is being put in. And this is something I want to show you. This is interesting information. There's a recent paper commented by Thomas earlier today, and about what is the best way to getting with a sheath where I want to get. And this is the same sheath with a different ureteroscope, and you have to take the sheath. You have to take the sheath to the calyx where you want to work. There's a study, an in vitro study that's quite recent, and we lack information, but we discover this technique every day a little. So we should take the recommendations. So we used an 1113 sheath.
Montamos todo lo que es
and we mounted the suction. Here the question is basically, what diameter would you choose? Diameter, well, I mean the length. How long should the sheath be in order to work better or more comfortably with the suction? You see here the sheath was too long, and if the suction sheath is too long, is a problem. In that phase, you did the same as with any sheath, ureteral access sheath. No, I just went in directly. We had the CT post double J, the ureter was clean, and we just pushed the sheath to the renal pelvis. And then now you'll see how we took it there. This information about the length is not a minor information. You have to choose the length well in order to try and prevent going in and out so many times. Do you know where you are going to leave the sheath? Well, we also had the CT scan. The lithiasis was in the lower calyx.
Por arriba.
He's not using the mic.
Sí, bueno, esta paciente tenía un pre-stenting, por lo tanto, imagínate que
This
la vaina
patient had a pre-stenting, so the sheath just passed smoothly. We reached the kidney. It was because of that there was no doubt or anything of the sort. This is the setting. Notice that the reservoir is below the suction valve, but as a criticism, I would say that clearly the sheath was too long, and today I always try to choose the adequate length because of what I told you earlier. It's torturous. Those who are starting with suction will know, they know it means coming in and out all the time is cumbersome, so we need to come out as soon as possible. The further back the sheath is, the better, because you will go faster. And what parameters do you use to measure length? Because this you must have beforehand. We perform a measurement with a prior CAT scan with a bilateral joint with to the meatus. It's manual. We have presented an abstract for the European Congress that speaks of that. When we started with this is that we were always too long. Why? We use 35 in men, in women, 45 in men. There was a gap. The key to suction is that it reaches every location. If you are short, you have to think of a longer sheath. It's important to plan and say, well, I need a sheet that will reach the upper calyx because of debris or fragments going up there. And it's good to set up the surgery before starting. Let's continue. This is what we said before, how we arrange everything. What they said today in the suction section, irrigation plays a fundamental role, a key role. If there's no irrigation, there won't be suction. So we perform irrigation manually, as you saw there, and we found the stone inside the lower calyx. Stop the video, please. We knew because of the CAT scan that we would find the stone in the lower calyx. So the question I want to ask you is whether you would replace the stone, not to work in deflection for the sheath, not to bring it to lower calyx. I don't know if you would do that. I would so in the case of a pants, because there may be some limitation depending on the sheath to work in the lower calyx. If it weren't fans, I think that it was easy at the beginning. It makes no sense. You don't have to open a basket, and you spare using a disposable item just for nothing. One of the advantages of suction is not needing any kind of grasper or basket, and this is something that I mean, as part of the advantages, you do not use baskets, and you might reduce the cost, if I may say so, of the procedure, which we know is costly. Let's continue. Well, we do not replace, as Christian said. We start with the stone removal and stone destruction. We use the thulium fiber laser with a setting that has changed as months went by. We have changed, and the reality is that the settings used for flexible uteroscopy have changed. Also, we have changed, I don't know if you remember the video, how we, when we perform these changes using the suction valve, we thought it was just going in, breaking and aspirating fragments, suctioning fragments, and then, I mean, it was a mistake at the beginning, and it's good that we share this with you. Actually, the objective of this type of surgery is not stopping the stone destruction. There is dust around, you improve vision, but notice that you don't have to stop to bring in the fragments. You are constantly aspirating. If there are small fragments, you will have to remove them. But the purpose of surgery is not to come in and out all the time. And that will help make the surgery more advantageous. We will like it best to do it and not having any hindrances. Say, well, this does not work, or discontinuing it. As you can see on the video, we are constantly conducting passive surgery, and when we aspire, when we suction, we press the sheath, and then we suction the fragments. We went fast. There you can see the small fragments removed and even the dust that we have aspired. we suctioned during the surgery. And in the case of stones with over a centimeter in diameter, it was 650 cubic millimeters. It's 12 times 8 times 5 lithiasis. So it was a 1-hour surgery. Times have changed clearly. We are going faster. We are using less laser time, and all shots are addressed to the stone. We do not have to stop and shoot at other locations. And the question from me to you is, we left the patient without the J. This is a question I had. We conducted a control ultrasound a week later. A question for all of you is whether you think this will change. Until this year, we left a double J. It meant leaving these fragments, the dust inside the kidney for the patient itself, the drain. We would leave it for 4 weeks. So the definition we use today, which we still use, which is lithiasis-free 4 weeks post-op with an ultrasound or whatever definition method you use. Do you think this will change if you leave the patient knowing that nothing remains? Can you perform an ultrasound that same day? Probably you may shorten the time and reduce the use of the stent post-op. Jose, Christian? I think it will change as we become more assured, just like when you perform a percutaneous surgery. The possibility of leaving the patient stone-free will change with a traditional flexible ureteroscope. There are patients, for example, in Chile, who stay longer for non-medical reasons, and we advance the scanner for practical reasons. This is where this is heading to. He's not using the mic, we're sorry. Those fragments remaining after flexible ureteroscopy, with this improvement in vision, I mean, they won't appear so frequently, clearly. The stone-free rate that we are trying to establish in order to standardize so that there will be 0 fragments, it was 4 weeks until now. Reality is that with suction, it's gone up a lot, 90-something, 97%. So these fragments that you were commenting on that were left at 4 weeks are no longer there. And this is one of the advantages of continuously looking. And those fragments will surely be suctioned. We are sorry, but the person who is making the comment is not using the mic. This is a very good comment and the reason for discussion. We have made significant progress in that I would leave the patient 4 weeks on a catheter, plus minus in other centers, and this patient left without the double J. And if he had, I mean, I have a CAT scan after a week, and I share what Maria Jesus said. Maybe that same day, I can perform a CAT scan and say that the patient is stone-free, and maybe that double J, which I left for 4 weeks, I will remove it far earlier. That's why. If you speak off mic, those who are offline cannot hear you. To us, suction changed the double J catheter timing. Many patients don't like it, and stone-free is far more predictable. But we have questioned the CAT scan because in our case, in addition, whether to check whether there's fragments or not, Well, in addition, we can see whether there's stenosis in the ureter. So, well, this is food for thought and discussion. And maybe we have another definition. Because of the sake of time, we will move on with the agenda. Thanks very much. We'll continue with the agenda. We're going to invite Dr. Said to talk about a very interesting topic. What will the next 5 years in endourology bring? Also James Boring, Esteban Acuña, and Thomas, please come on stage to moderate this panel.
Thank you for having me again. I was asked to talk about the future in the next year of the endourology. So again, disclosure. So it's a big subject that we have to talk, but if you notice in the last 10 years that the most of development were focused in the retrograde intrarenal surgeries. Few in SWL and PCNL have rest of the development. So I will just put something, what is new and what is gonna be invested more in endourology. So first of all, I will talk about smaller scope, stone dusting laser, fans acceleration, maturity of the directing scope, the pressure sensor and the robots. Let's go and see, what about the smaller scopes? We know in the beginning of the digital that each company wants to improve the vision and the size. But apparently the size was important than the image. That's why even companies like Wolf, they went smaller. Even disposable, they went below 9 French. They don't believe in more in 9 French. Olympus came with the finest and smallest reusable scope. It's a 5 French at the beginning. The shaft is about 8 French. Indian companies went down 7.5. They abandoned the 9 French like the endoscope from Debra. This is a hybrid scope. You can use it for 20 operation. Many scopes, they went down from 9.2 to 8, 8.5. The first generation of 7.5 was Poussin. If you look at the size of Poussin, they said 7.5, which is comparing to the semi-rigid from Olympus, which is 6.4. You can notice that it could be smaller than that because it gives you an idea how small these scopes went down with the size. A huge mid after that, companies followed the trend of the size, not the image. Remember this. Why is it important to have a smaller scope? Because of the access of the first time. And this is bother you as a urologist. You put a stent. I'm sorry, I couldn't do your stone. But look at this picture. Every French count. Imagine that one French counts. And this is very important to have a smaller scopes that gets you to the target. Smaller scopes help you to treat small babies, like this baby, 18 months old. Even the deflection was impressive inside a small baby by 7.5. Difficult anatomical variants. If you cannot approach by 9.5, you can approach that small infundibulum by 7.5 without risking incision by the laser. So it makes your life easy. Innovex came again. Most of the companies went down 7.5. The image was stable, and this is a very unique with the engineers in most of the companies, especially China company. They want to keep the image as good as possible. You know that when you get smaller, the image is could be affected, but they kept the good image as you could see here. Now, huge mid went to 6.3. So it's just like a hallucination of the size. We want smaller. And you can see here, despite they went 6.3, the deflection, the angle of deflection is small. The length of deflection is small. So this 6.3 is not for everything. It's for special cases because it has some characteristic. But this is a story of going smaller. And this is what indicated by Olivier when he said this could be help you in the children and emergency cases instead of stenting the patients. 5 years old, lower pool deflection, you can see you are working on a small kidneys. So I remember this study, it was in 2005, which is 20 years ago, when they said 8.4 is acceptable, 7.4 is ideal. So why we are talking now about 7.5? Because the company, the engineer, the facility did not reach the maturity to achieve a 7.5. So I would imagine that we are talking about 6.3 now. So after 20 years, somebody will talk about 5 French or 4 French. This is amazing, because that was an evidence that the people 20 years ago, they were thinking about 7.4. This will abandon the balloon dilatation. Who is doing balloon dilatation anymore? Look at the massacre. Look at the vandalized ureter by a balloon dilatation by 15 French. It is an active dilatation which should be not accepted nowadays with the small scopes. We go to the second point. We have a modified Holmium now, and we have a TFL. To enrich the choices for you is not to replace and to compete. Many companies, they came with the TFL, multi-laser stores, they shifted to TFL, Plovis, Drive, even Coloplast, they don't have a laser, they bring it back to the system. Why is the TFL one of the dusting laser TFL first? Because it's a faster, more dust, proven by many publications, even in United States. And you can see how fast, this is a 2-centimeter stone. You don't need to take a time and then completely dust it in 9 minutes. And the secrets behind the TFL is the low peak power. You can see that the stone does not move at all. Kidney, 20 watt, 12 watt in the ureter. Dusting, ablation proved that it's much better than the other laser. You can see how the quality of the golden beach that you can achieve with the kind of quality of laser. Uric acid, like calcium oxalate, this laser is fantastic for every type of a stone. Some people we can reach, maybe my lecture about TFL, I'll show you some hard stones. The aim is to reach the dust, which is the aim of the endourologist now. You can see the difference between the dusting between the high power Holmium. I'm not talking about modified. I'm talking about the quality of dust that achieved by the TFL comparing the Holmium. So Holmium get jealous. They said, why can't we do a dusting something? So the understanding the Holmium is energy, frequency, equal power. So they added the pulse duration. They came to the thing about modulation, dusting, fragmentation, popcorning with the same look, 10 watts everywhere. Then they created Moses in 2017, and because they want less retrobulging, and this is, you have to keep it in mind. Less retrobulging means you go faster, you achieve more, as proven by many studies. This is from Mustafa Hilali from Canada, Montreal, where they prove it's an important thing. Quanta system, they work on not on the pulse modulation, they went to the peak power, and they said, what about if we win the peak power of the Holmium 2000, 10,000? I want it to be low as a TFL because I want more dust instead of playing on the pulse modulation. And you can understand that in the new concept of the thulium fiber is the reduction of the peak power. So the Holmium wants to decrease the peak power to reduce the retrobulging, improve the size of the dust, and improve the time. So the secrets in the next 5 years is lower the peak power, as you can see, which is achieved by Quanta, and they decrease the 10,000 to 2,000 to be reached at the 500 to mimic the TFL for dusting, and keeping in the same time the high power, peak power for the Holmium. So you can have this machine for the prostate, and you can put it for the stone to mimic the TFL for the sake of dusting, as you can see here. So the secrets in next 5 years is not the pulse modulation, it's the peak power, as you can see. Hard stone is for low retrobulging. Now, this is the summary that I made. If you can notice that Magneto, which is the new Holmium laser, went down to the low peak power to mimic the TFL. So the idea here is to go for low power. The third point with the advancing is the fans. We have talked about it. The fans came to help you. It will modify the shape because companies, they don't stop to modify things. As you can see here, different companies, they are trying to help you to find what is the best solution. And you can notice here the fans, the new development in 5 years will be in the smaller size. This is 8.5 from a Chinese company from Jianjiang. And softness of the efficiency and the shift from stand to suction. Imagine that you have an access sheet. It's a standard. You take this, just the tip, and you shift it to suction. So it's a 2-in-1. They want to innovate for you. And again, they fabricated something, we call it flexible urethral access sheet. You can see the lever there, and it will help you to direct it to more deflection. What about directing the scope? Yes, it was an idea that this will show you the space created inside the scope might be important than the fans, as you can see here. And this is the 7.5 with a suction. It can aspirate these particles less than 200, 250. And you can see 9 French 5.1 is aspirating the whole dirty dust inside and then will clear the image with a while. And you can see the stone there. And 7.5 with a working channel 3.6. Again, we have a problem of plugging despite we did because it depends on the size of the dust. It depends on the irrigation methods. Now, fifth point is the sensor. My friend Thomas he spoke about the sensors. I will speak about it in a details. Flexible uteroscope inbuilt was the first one, LightView. You can see here, this is the system of the you connect it, and it will measure the pressure for you. We were talking about the importance of the measuring the pressure. You can see here how just initiating the LightView. The only problem is the size is about 9, and the stone is there, and you can see the pressure is elevating with the time, but it stays below the preferred 41. There is alarm, so you have to stay below 40, and you notice this. You can see that the inbuilt, sorry, you can play the video, please. This is a video of LightView when it's working with, okay, maybe next. Can you shift, please? Por favor, you have to shift it, or maybe you have to close it and bring it back, please. Sorry for the interruption. I have 1 minute. Okay. Is it okay? No. ¿Qué pasa? So we have to restart it, maybe? Okay. I cannot, I don't know. No, the whole slide is, it's not only, yeah. Go to that slide, the last slide, because we don't have time. I'm sorry. No, before that, please. Before that, no, before. Again and again and again. Before. Yeah, before. Yeah, before, little bit. One more. But that's it, okay. Gracias. So next is, I will just skip this one. I will show you this is without access sheet and this with the access. It tells you how much pressure you apply without an access sheet, which is a good idea for the beginners to start doing a good operation and without compromising. This is a scope from Hook, Chinese. They compete with the LightView. This is a scope from Zebra. You know how many scopes with a sensor in the market? About 20, but they have only one maybe. This is from Zebra, and we'll show you that how do you measure the pressure. The Chinese, they can give you a version in Spanish, a version in English. The second point is the neutral access sheet. Imagine the sensor is not built in the flexible, it is built in the access sheet. You can see the small sensor in the access sheet, which is, I believe personally, it is not practically, because the access sheet, you have to put it inside the kidney, it has moved everywhere. If you put it in the junction or it doesn't measure the real pressure. And with the deflection movement, it might be damaged. So this is not really practical, but they offer you something else. What about the sensor guide wire? It's there, more likely for the cardiology, but it's not proven yet. And now the inbuilt processor system, like these two companies, they said, okay, why don't we offer you a system, irrigation, pressure, temperature, everything there. So this system will tell you how do you work by the system of irrigation, pressure, sensor, and temperature. 6th point is the robotic. We know the robotic came, many publication here, prevent surgeon fatigue, higher accuracy, improvement of the ergonomic, precise rotation. The first one was Avicen, then came the Stirlab from France, and the Ethicon constructed their Monarch, which is used for PCNL and for retrograde, Zaminex from Korea, South Korea, and they are trying to improve the surgeon ergonomic, and this is one of the conclusions by Denston and colleague, that it's a significant improvement in the ergonomic with the robotic. The only thing that improved the robotic is the respiratory synchronization, because it moves. So the robotic will synchronize with the movement. You can see here even the stone guide basket retrieval. It's a complete platform, could be applied for you, studying, maybe give you the stone volume, what you do. So the future platform for this robotic is the cost effectiveness. It's very expensive. Ureteral axis sheath force, it depends on the human being sensation. Artificial intelligence may be installed and completed with this robotic and measures the internal pressure and the temperature. What Michael dealt with, he said, every technology that starts as a challenge become a necessity with a time transforming industry and saving life. And remember that we will never see the result unless 5 to 10 years. Thank you very much.
Thank you very much, Saeed, for a wonderful talk. Pablo, do we have some time for questions? Is Pablo here? Okay. We have time for questions. At least one, I think. Any questions from the floor? If not, I'd like to ask you a question, Saeed. Don't run away.
Yeah. Okay.
Come back.
Yeah.
Quick question. We had a comment before from Norberto that we can drive Ferraris and Lamborghinis, but if they don't have a dashboard, we don't know how fast we're driving and so on. And in the future, maybe flexible readeroscopes will become like cars. My car has the automatic cruise control, keeping the distance, lane assist, you name it. We'll be able to measure stone size, maybe measure pressure, measure temperature. Do you think that we're going towards a multi-measurement system that tells us the efficiency of the laser and everything, adjusts our laser settings for us, or is that a bridge too far? Do you think that we're going back to the basics and using our flexible readeroscopes as we are, or is this, like Michael Dell says, will becoming a necessity?
I think with the fastness that we live here, it's a must in the future. We have to accept the reality that this is so fast for us. If you look at the retrograde internal surgeries since 2016, disposable lasers, modifications, this is a competition between the companies, not a competition, not for the sake of the patient or the doctors, this is for their sake. And we receive them and we utilize them. I think we have to be wise. How do we react toward this fastness of the instrumentation? We have to raise the right KOLs. The key opinion leaders should be honest in judging the instruments, because there is no time for the researchers. That's the important. So that's the point here. And doing much researches on these things, it could be fascinating, but we don't know about the, what you call it, casualties during the development of the instrument without a real guide. The guidelines, the key opinion leaders, and the honesty of the companies. These are 3 pillars that I believe they will protect us, our patients, during the next 5 years.
Where do you see break wave or burst wave technology fitting in to this equation?
I wanted to put it here, but it's fantastic. But you told me that it's not approved yet by the FDA. It's a completely ultrasound protected. I saw it once. I said this one will slow down the flexible ureteroscope. But the problem here, each country, it depends on the prices that you can offer the surgery. Some of the surgeons, we like flexible ureteroscope. I don't know, I was talking to Argentinian people, they said flexible is the same price as WL. But most of the country, the doctors will, he will option to do flexible rather than his WL because of two things. He wants more money and it's more fun for him. So this is the problem. We cannot, any option is WL. It's not the choice of the patient, it's a choice for us. And now we cannot go inside every clinic of every doctor and we judge him. We have to just educate people and let it go.
Sí. Excelente presentación, doctor. Dos preguntas. Uno,
Two questions. One, the devices that you use with pressure sensor, the sensor is in the tip of the sheath or the ureteroscope, because I saw some Chinese devices that are in the non-flexible area.
True. There are two types of sensor. One installed at the tip of access sheet, but I'm saying that that's not practical because if you stop access sheet, it has to measure every space if you go to calyceal system. But the access sheet might be stopped in the junction. You can not go inside and swim inside the kidney. The other problem with the manipulation of this atrixis and sensor, it might be broken. So it's not a real-time measurement. For the uteroscope inbuilt sensor, I think this is the future, but they are developing the putting sensor, putting DIS, putting I don't know, measurement in a small scopes. So everybody is pushing to put everything in a small instrument. We believe now, maybe I can tell you now, we are in 2024. Maybe in 2030, I will present something about a unique scope, has everything, as Thomas said, everything inside. I believe in it, because 10 years ago, we were not like this.
y la tecnología con el magneto ayuda
and the technology with magneto laser is more similar to the thulium fiber with regards to the dust it can create.
We have to distinguish between TFL and holmium, but they want more dusting because holmium is not going to compete with the TFL for the dusting. That's why Quanta wants to reduce the peak power to similar the dusting, but it's not for the hemostatic effect, it's not for the prostate. We have to distinguish between the technology and the peak power in each one. But I think Magneto will bring something, but it is big. I don't know about, it is big machine. It is 150 watt. And we come to my lecture that why I need 150 watt, where I need for the stone 20 watt, maybe for the prostate 80. So it's a double machine. We don't know, maybe the company will make it smaller. It's very fast.
¿Alguna otra pregunta?
Any other question?
Okay. Thank you very much.
Thank you.
Bueno, vamos a continuar entonces. Horacio, te vamos a invitar para...
Now we shall continue. Horacio, please. Do you want to present the debate here, or you are going to moderate from there? Ladies and gentlemen, welcome to the first fight of this evening. Urologists, male and female. We are going to see two, and we'll see how it works. On one hand, there in a gray suit, percutaneous surgery, the old champion. We know how it breaks, how it kicks, but it's still here. And Mike Christian Cristallo Tyson to present it. A big hand. And on the other corner, new technologies, the new things. We know that it's good. And will it be the same? He will defend it, and let's start.
Bueno, vamos a muy buena, la verdad. Gracias, Horacio.
Very good, and thank you,
Vamos a
Horacio.
abrir el debate sobre
We'll open the
algo
debate on something that is quite controversial.
si la cirugía percutánea va a estar
If
con nosotros o
percutaneous
no en los
surgery
próximos
will
años.
stay with us for several
Ahí me
years or
toca
not, I
hablar y
have to
tratar de
speak
convencerlo. Va a ser
and
difícil, ¿no?
try to
Porque
persuade
Mariano
you. It's
preguntaste
going to
quién
be
hacía
difficult
percutaneas,
because
entonces,
Mariano
¿cómo hago?
asked today who would do percutaneous,
Entonces,
and
voy a
everybody
tratar de
raised their hands.
convencerlos
So I will
de
try to
por qué
convince
para
you and
mí
persuade you
la
why,
cirugía
for
percutánea
me,
va a desaparecer.
percutaneous surgery will
Y
disappear.
cuando, bueno,
And
hablé con Cristian y
when
le
I
dije de hacer
spoke
el
with
debate,
Christian and
bueno,
I
Cristian y yo
proposed to him
la
to
parte un poco más
organize this
no.
debate,
Se me ocurrió esta
I
frase,
came up with
¿no?
this
Para tratar
phrase
de explicarles
to try and
por qué
explain
para mí,
why
tratar de
to
transmitirles
me
por qué la
and
cirugía
to
percutánea va a
convey to
desaparecer.
you why
Le agradezco a
percutaneous
Maurito
surgery will
por el dibujo.
disappear. Thanks, Mauro, for the
En realidad,
drawing.
a ver, ¿por qué? Porque la endurología, como
For
todo,
me,
¿no?
why?
No
Well, because
solamente nuestra subespecialidad o
endourology, like
especialidad o
everything
neurología,
else,
sin duda que es pasión por lo que hacemos,
it's a
pero
passion that
creo que
we
van a
have
estar
for
todos de
what we
acuerdo en
do, but I think
que
you'll all agree
es una
that
subespecialidad, por
it's
así
a
decirles,
subspecialty,
que
so to
se mantiene
say,
en continua
and
evolución.
that it is
Esto es algo
evolving
que
permanently.
es
And this
real
is
y
something that is
seguramente los que
real,
tengan más
and
experiencia
those who
lo
are
van
more
a ver. Es muy
experienced
probable que lo que estén haciendo ahora
will
no lo hacían cuando
probably
estaban haciendo la
know
residencia, por ejemplo,
that
nosotros,
what they are doing today they didn't do when they were in the
y probablemente
residency,
no sea lo que hagamos
and
en un futuro,
probably
¿no?
it's not what we are going to
Entonces,
do in the
creo que
future.
la charla
So
esta de
I
tratar de
think that
explicarles
this
por qué
talk and trying
la
to
percutánea va a morir
explain
o va a
why
desaparecer es
percutaneous
difícil,
will disappear,
va a estar
it's difficult to say
va a estar
that.
un poco llevado
It's
por esto de la evolución, ¿no?
it has to do
Y
with evolution.
todos conocemos la cirugía percutánea, es
We
una
all
cirugía que
know
ya tiene muchos
percutaneous
años.
surgery. It has
Ustedes,
existed
nosotros,
for many,
¿no? Ya
many
esta
years.
publicación la conocen todos.
This
Fíjense
publication,
que
you know,
se publica en
all of you know
1976,
this.
por lo
It
tanto
was
tiene más de
published in
50 años esta
1976, so
cirugía.
it's 50, more than
Tienen
50
algunas
years
similitudes que
old.
me dirán, sí, pero
There
bueno,
has
no es la
been
misma cirugía percutánea
evolution,
que
and you'll
hacíamos
say, well,
cuando
it's not the same
aprendimos o
percutaneous
en la
we
década del
did when
70, la
we
década del
learned, or
80.
in the
Hay
70s or the
algunas
80s.
evoluciones,
There
conocen la
has been
aparición
an
del ultrasonido, la
evolution, the
aparición
appearance of ultrasound,
de la energía neumática,
the
obviamente el láser,
pneumatic
sí, que
energy,
también se utiliza hoy
laser,
en día en la cirugía
of course, that
percutánea,
is today
pero fíjense
used in
que, a
percutaneous
ver,
surgery, but
por ejemplo, por decirles, la cirugía, es decir, el decúbito
the
supino en posición manubria, que lo
the
seguimos haciendo hoy
cubitus
en día,
supine
lo
that
publica
is
por
still
primera
used
vez en la década,
today
fines
was
de la década del 80.
published
Yo no había nacido,
for the first
y es algo
time
que lo
at the end
seguimos
of the
haciendo.
80s. I hadn't even
Entonces,
been
bueno,
born, and we still do
ustedes me
it.
dirán,
So you might tell
sí, a
me,
ver, claramente
yes,
que avanzó la cirugía
it's
percutánea, y la
clear
cirugía
that
percutánea avanzó
percutaneous
en lo
surgery
que es la
has moved
miniaturización, es real.
forward,
No hacemos los
especially
tractos
in
que hacíamos antes,
miniaturization.
hacemos mini
We don't do
perc,
the
hacemos super
tracks that we
mini, acá
used to
incluso
do.
hay gente
We did
experimentada
mini
en eso,
perks, super
ultra mini,
mini,
micro, todo esa
ultra
calidad.
mini,
Y eso también
micro.
viene de la mano de,
But
como decía
that
recién,
comes hand in
de los
hand
avances que hay, como
with
que
the
se ha sido,
progress.
o el coletazo, diría yo, de los
And
avances
I would
tratados de
say that
buscar para
this is the result of the
buscarle el lugar a la
progress
cirugía flexible
that
en
was
litiasis cada
made
vez más y
trying
más
to
complejas.
find a role in more and more
Por
complex
decirles, en
lithiasis.
1998 la primera,
In
la
1998, for
primera publicación
instance, the
o la
first
primera comunicación
publication or the
de la
first
cirugía
communication
del mini perc, ¿no?
of
Y han
mini perc,
pasado casi 30 años
almost 30
y es la
years have
cirugía que
gone
seguimos
by,
haciendo.
and it's a surgery that we still
La
do.
evolución, la
So
realidad
the
es que,
evolution, the
como decía anteriormente,
reality is
si
that, as I
nosotros
said before,
tenemos que estar continuamente en evolución, la
we
realidad es
have to
que
evolve
la
all the
cirugía
time,
percutánea
and if that is
no
the
está,
case, percutaneous
o por lo menos no está
surgery
así de manera comparada con tal vez lo que me
cannot
toca defender a ustedes,
compare
que es la
to
cirugía
what I have to
intrarrenal.
defend, which
La
is
cirugía intrarrenal
intrarenal
sí avanzó,
surgery.
sí ha tenido ciertas
Intrarenal
evoluciones, todos
surgery
lo hemos
has
vivido, pasamos
evolved.
de la
We
era
have all
digital
seen it
a
from
la
the
a
moved
la
from
óptica, a la
the
digital.
optic
Han
era to the
aparecido
digital
múltiples,
era,
lo que
multiple
son los ureteroscopios single use o dispositivos
single-use
dispositivos
ureteroscope
de
have
monouso de
appeared,
múltiples marcas. Hoy en día, piensen
multiple
que para el
brands.
año pasado había
Last
17
year
aprobados
there
por la
were
FDA o
17
por la
approved
Comunidad
by the
Europea, y ya
FDA
tenemos
or the
incluso
European
ureteroscopios de 6
community,
French.
and we
La
had
realidad es
6
que
French
cada vez
ureteroscope.
vamos a
So we move forward all the time. This is the size of an open end. So evolution is maintained, and what you mentioned about measuring intrarenal pressure, etc. We saw the revolution of the appearance of different types of laser technologies. This is real because it was tried for flexible ureteroscope, but we use laser for percutaneous, but clearly the progress has caused that with the pulse holmium laser and the appearance of new lasers, we can treat more complex lithiasis. Also, the sheaths have changed. The one we used several years ago is not the same as the one we use now. We had some presentations on suction, but the sheath that we will use in the future will probably not be the same that we use today. Suction also from a plain ureteral that would aspirate the dust. Now we have direct suction or a sheath with a suction. So this model of evolution, revolution, I think that is more for renal surgery than for percutaneous surgery. And why? Intrarenal surgery, we have not only been disruptive, but novel things have appeared that have put forward or that have made it possible for us to perform this surgery for larger and larger stones. And there was a review or a revision a review last year. It was quite controversial. It made a big impact, like saying we'll never need again a percutaneous surgery. And obviously with a Twitter that you all read of Olivier Traxer, who said, well, this is the era, the end of percutaneous surgery. But many opinions appeared afterwards, especially expert opinions, controversial, saying it's impossible that we will not have percutaneous surgery anymore. And some reviews that said, yes, it's okay, you have the latest technology, the best laser, the best ureteroscope, but there are limitations. And one of them was this, that you treated the lithiasis and all that amount of dust that was generated prevented from seeing the reality of treating a lithiasis, such big lithiasis in that manner. Several years ago, we always said that the snowball effect meant the big disadvantage of treating larger and larger lithiasis. Nowadays, we have suction and stones that are larger and larger can be treated with an intrarenal kidney in a retrograde treatment because we see and we control what we do, and the possibility offered by this new suction and aspiration sheath will allow us to try and prevent to do what we did before, and that for me was a mini perk. You all know this publication, the first experience with suction, and the idea is not so much to speak about this, but I want to show you the results. These are multi-center studies. This triggered the suction sheath, and this group, what they did was to treat very large stones. The one that we saw in the video was 1,300 cubic millimeters, but this group, practically about 40% were larger than 1,500, so they treated very complex stones, and the stone-free rate, grade A and grade B, was 97%. So this change, we all agree on that, and we need to see what is its role in replacing percutaneous surgery. But it's true, this lithiasis that probably last year in this course, I have no doubt that I myself would have advised a mini perk. Today, these patients are treated and approached in a retrograde manner. So my question is, if I'm going to generate or I'm going to use a sheath, yes, a percutaneous sheath, one that will probably reduce the diameters In this case, mini perk, super mini, micro perk, whichever you choose. Why can't I use the same sheath with the same diameter and getting the same effect, advantageous effect, which was to improve pressure and treat more complex lithiasis and improve the diameter? And why can't I do it and prevent renal puncture? But clearly, we have to get back to reality. What I said at the beginning, it's difficult in our environment to say that percutaneous will die because these patients are still approached percutaneously. Even we in our course had a panel of lithiasis of Staghorn calculus. So the message is good, but we have to understand this reality, which is what we see on a daily basis. For that same reason, 2 weeks after the tweet that was revolutionary, Olivier Traxer says, okay, it's not totally dead because a lithiasis of 23,000 cubic millimeters, none of us who are speaking of a Staghorn stone would approach it retrograde in a retrograde manner. I won't even ask because everybody would say no. So, and to conclude, percutaneous surgery will disappear? Well, I am writing a big question mark, but I want to go back to the beginning of my talk. Speaking of evolution, and I want to ask, and I asked ChatGPT, if a surgical technique does not maintain a constant evolution, will disappear in the future? And the answer was it's quite probable because it will be replaced by another. Maybe not now, maybe today I cannot say that it will die today, but probably, and there are many young urologists, we have a lot of paths to tread, but what we said, it's impossible for percutaneous surgery to die. In the future, who knows, maybe we'll have a more valid answer. Thank you.
Bueno, hola a todos. Antes que nada,
Hello,
gracias.
everyone. Well, first, thanks, Luis Pablo, for the invitation once again. A very outstanding course you organize every year. Thanks for such an energetic presentation. And I have to defend percutaneous surgery because I believe in it and because I am certain that it's more current than ever and it has come to stay. When we question whether percutaneous surgery will stay or not, we are comparing pears to apples. Each technique has its own absolute indication, but it's true that there is a gray area where there is an overlap between flexible ureteroscopy and mini percutaneous surgery, and there's where the discussion lies. What happens is that today the clinical practice guidelines are not reflecting what happens in the usual practice. Why? They are outdated. They just consider linear parameters, lithiasic size and stone location. And they're not considering the technology developments that Luis was telling you about, aspiration sheets, the evolution of laser, digital disposable laser ureteroscopes. So this is not in line with the guidelines. Hence, saying that percutaneous surgery will die is a fallacy. One more. And I want to invite you to the avant premiere of the axiom fallacy of the same creators of the flexible surgeries only with a sheath. TFL will kill homium, fast this, and the death of PCNL. I mean, leaving jokes aside, Luis has shown this tweet. The Maradona of urology left us in awe, saying that percutaneous surgery was dying. But I believe that this is a hurried statement, and we lack scientific experience. So both Luis and Olivier want to, well, cheat us in a way. Why? First, it is fake that there is no technology evolution for percutaneous surgery. Percutaneous surgery is still evolving. Today we have mini nephroscopes, better and better vision, aspiration sheets for percutaneous surgery, and the evolution of laser equipment that we use for flexible ones. They have evolved for percutaneous treatment. Second, we are speaking of using flexible surgery for large, hard, complex stones. This is not an easy method, and it is prone to complication. And third, there are anatomical issues that are unavoidable. There are patients who will not be able to be operated on via the endoscopic approach, and we will have to resort to percutaneous surgery. But no more opinions. Let's speak of data. What do we have in the literature? First, trends. Here we see the evolution over the past few years, both globally and in our own institution. We see there's a clear increase and growth in flexible endoscopic surgery. But again, there's an ascending progressive curve for percutaneous surgery. Today, percutaneous surgery is still current and on the rise. It's far from disappearing. Secondly, what do we look for when we want to approach a stone having a higher stone-free rate with a smaller number of complications possible in the least time at the lowest cost and with the best Q of L for the patient? What do I say about this? Well, Luis's paper is very good. I mean, the one he has shared. But notice this one. It includes 25 centers, 124 patients, 57% zero stone-free. It's not that high. The true stone-free. It's not exempt from complications. Adding aspiration or suction also brings about some complications, and oftentimes we have to go for a second look. What is most interesting about this paper, as we said, is that as the treated lithic volume increases, 1,500 to 3,000 cubic millimeters, the possibility of leaving the patient stone-free drops dramatically. And for stones of over 3,000 cubic millimeters, the odds ratio is 0.29, very low. Also, there's no control group. It is not an analytical comparative study. What happens when we approach large stones endoscopically, more than 2 centimeters? This is a meta-analysis with a systematic review, reporting a good stone-free rate, 91% on average. But if we play a closer look to achieve that stone-free rate, we need more than one procedure. Out of 2 patients that will be undergoing surgery, one will need at least 2 interventions to get to the stone-free status. So we are exposing the patient to 2 surgeries. This is the most complete meta-analysis and systematic review in the comparison subgroup, comparing mini percutaneous surgery versus flexible surgery with suction sheets. In terms of stone-free, there were no differences found by authors. But if we pay a look at the close print, the evidence that this statement is based on is 3 of the 4 studies included, which are retrospective with little scientific power. If we look at the average size of the stones, they are large, but not that large. And the density is also low, 140 units. What happens with larger and harder stones? Well, probably this will not be enough. And using sheets, well, we know it's not complication-free, especially at the ureter level. We have to be very careful with ureter lesions. We have heard a long time ago about 50% of ureter lesions caused by sheets. Diricelli et al. Have proven that in those patients where we used a sheath but did not leave a double J later, they had greater post-op pain and more visits to the emergency room. Or even in thin sheets, there's twice the probability of causing injury vis-a-vis when we do not use them. And what does this mean? Many of these patients will be placed a double J after surgery. And why does this matter? It affects quality of life. And this is one of the parameters we seek to improve quality of life. Notice the impact of having a double J on quality of life. Pain, hematuria, it's strikingly enough, 45% of absenteeism of at least 2 days, and 32% with more than 30 days. That's a lot, in addition to anxiety disorders, sleep disorders, impaired sexual function, and the like. So sheath means double J, probably, and at some point this deteriorates the quality of life. This is yet another interesting study. These are patients where the quality of life was measured in 2 different groups. They were all patients who were originally going to be approached endoscopically with a flexible scope, but when not being able to place the sheath, they were broken down into 2 groups. One group was subject to many percutaneous surgery, and the other group, well, we used a double J, and surgery was deferred for a second moment. And in comparison in terms of quality of life, it was far better in the case of the mini percutaneous surgery group. It is true that there is scientific evidence showing the benefits of suction today, and it is a quality leap, and it expands the degree of indication for flexible surgery. But it does not mean that it will that percutaneous surgery will disappear. If we compare flexible surgery with suction in larger stones, 2 to 3 centimeters, see that the stone-free rate drops. 73% in favor of percutaneous surgery. Surgery time is smaller, smaller need for second surgery, and there's no increase in complications. This is interesting because percutaneous access allegedly adds morbidity, but there are no further complications or major complications. This is the meta-analysis, the largest systematic review published to date. As of November 2023, comparing randomized controlled trials, 42 trials, 4,571 patients. Primary endpoint, stone-free, complications and second look. Secondary endpoint, visits to the emergency room, hospital stays, and ureteral lesions and quality of life. How did it do? Stone-free, far better in favor of percutaneous surgery. 1.13, that's the relative rate out of 1,000 patients treated with percutaneous surgery. We will have 100 patients with stone-free compared to the use of the flexible surgery. This is 10% better, even in the subgroup with a lithiasis of the less than 20 millimeters. Major complications, there were no material differences, even in the subgroup where percutaneous access was over 24 French. Third, second procedure, percutaneous surgery has fewer possibilities of second look. Out of 1,000 patients subject to surgery, 150 patients less will have to undergo surgery again. It's a 15.3% improvement. And how did we do with unplanned visits? Not reported, lack of scientific evidence, hospital stays, of course, is 1 more day versus the use of the flexible surgery. That's against percutaneous surgery, but there have not been any stenosis cases reported, and quality of life has not been assessed. This other comparative randomized trial compares mini percutaneous and flexible surgery. Here, I would like to underscore that the flexible, he corrects himself, the percutaneous one has a better stone-free rate, especially talking about the lower pole. What happens if we add aspiration to percutaneous surgery? We'll see that by adding suction, we improve parameters even more so. Percutaneous not only for flexible access, but we lower surgery time, we lower the bleeding rate, the hemoglobin drop rate, and post-op temperature. And lastly, we will use percutaneous surgery with aspiration vis-a-vis non-aspiration in high infection rate patients. Aspiration is a risk factor for infectious complications, both in the univariate and multivariate analysis. So percutaneous surgery with suction has evolved as well and has taken a quality leap. As for costs, this is a comparative study, stones 1 to centimeters, flexible versus percutaneous. The marginal cost does not go too high for this type of surgery, percutaneous surgery, but with the caveat that it's just one surgery. What happens when we have to add a double J or a second surgical procedure? Surely this will be larger for flexible surgery. So in conclusion, why has it come to stay? Because anatomically speaking, you cannot solve this endoscopically because the stone-free rates are higher in the case of percutaneous surgery, so especially high volume, high complexity, and high hardness stones, because surgery can be resolved in just one surgical timing. There's no possibility of urethral injury, and these patients' quality of life is so far better than in the case of endoscopic surgery, and cost effectiveness is higher in favor of percutaneous surgery. Olivier has just realized this. Luis, it's now your turn. So remember, friends, as Luis says, well, PCNL, percutaneous has come to stay. And the discussion is open.
Felicitaciones a ambos. ¿Hay alguna
Congratulations
pregunta?
to you both. Is there any question? Any doubt? You have done wonderful. No, you have not gone against any of your colleagues. Good.
Me pareció muy interesante la visión de la calidad de vida.
The quality of life vision is very important. When you speak to the patient, they generally hear about risk and benefits of the procedures and they engage in both procedures. So what would you tell patients? What's best about flexible hoses and what will happen with it? What is worse for the patient? And same thing with percutaneous surgery. Well, what Chris said is true. Oftentimes we underestimate the subsequent double J beyond complications inherent to flexible ureteroscopy, which you are all familiar with. The posterior double J is something, a limiting factor, and we have underestimated it several times. Even there are questions to the emergency office. We offer an anti-bucamic drug. We don't pay much attention to it, but what Chris showed is real. It's difficult also, and this is my take-home message, the fact that we say the procedure is ended or that we won't do it anymore.
Pero bueno, un poco lo que mostraba ahí en la charla,
What I showed in the talk was precisely this. Have to discuss it clearly with patients, tell them all the pros and cons. Especially patients who have had a double J will probably say, please do not use a double J again. It's happened to you, I'm sure, many times. And here's where the discussion comes into play. If every option is valid, you have to adapt the surgical indication to each patient's preferences. Excellent presentations. I think that the issue of double J depends on the patient. I am working at a hospital in Chile that benefits they benefit the mining companies. So using a double J in a patient that is going to work at the copper foundry or who's going to drive a truck is difficult. We try to avoid it because it would mean leaving the patient out of work for 3 weeks or even a month. And something you haven't touched upon is the carbon footprint caused by the flexible ureteroscopes. I had to go over it. It's 11.5 kilograms of CO2 what are used when producing a flexible ureteroscope. Oftentimes, percutaneous equipment are reusable.
Bueno, vamos a cerrar como toda buena pelea.
Okay.
Hay un
We
ganador.
are going to close. A round of applause, and let's cry for or in favor of percutaneous surgery.
Vamos a aplaudir y a gritar por la ureteroscopía flexible.
Cheers and applauses for flexible ureteroscopy.
Muchas gracias.
Thanks very much.
Parece que hicieron trampa, ¿eh?
I think you've cheated.
Muchas gracias.
Thanks very
Vamos a
much.
continuar.
We'll continue. Today, Professor Samari showed surgery with a suction in scope. Also, Luis showed suction with sheath, but there are many cases that do not call for ureteroscope suction or sheath suction. This is what we are going to see. We are going to see my presentation. The first thing you will see, can we play the video, please? These are operating rooms. They are smart. At the German hospital, there is a new tower which has 10 of these ORs, which are wonderful. They are smart, and as you can see, they are connected to an auditorium so that we can exchange opinions, questions, advice with the person performing the surgery. It is a very interesting concept. Those ORs have a dome, and that dome is what allows us to see what we will see now. Next, this is a patient with a small lithiasis in the proximal ureter. We placed a double J, and 2 weeks later, we removed the stone.
Podemos hacer que no se craquee, por favor, si no, recomencemos la presentación.
Let's make sure it will not stop. Otherwise, let's restart the presentation. Dr. Baruso, Dr. Salvador, please come here to comment on this surgery.
Vayamos de nuevo. Total, tenemos tiempo para conversar.
We have time to talk. Gaby is a patient with a stone in the proximal ureter, 6 millimeters. We place a double J in them one day, and then 2 weeks later, we will remove it. We have a semi-rigid ureteroscope. Our flagship is a semi-rigid ureteroscopy for us. You standard procedures with the semi-rigid ureteroscopy, right? Yes, especially in the case of ureteral stones. But even if we perform retrograde surgery, 100% of the times we go for a semi-rigid to see what the ureter is like, to obtain dilation and to ensure that no fragment has migrated, or that we may find the stone in the ureter or anywhere in the ureter. Exactly. Tonio, this patient came at 2 in the morning. He was fitted with a catheter, and he came 2 weeks later. Does this patient call for imaging, for control imaging, or shall we bring him to the OR directly? I generally do not perform any control image. It is very difficult for this stone to be removed alone. If it's not there, it's gone to the kidney, so it won't be flexible surgery. I'll try not to really. So it's an administrative issue to see whether I ask or not for a flexible scope and whether ultrasound suffices. Stones over 3 millimeters will be there. In the case of the smaller ones, there is evidence indicating they may not be there. This is a video we shot last week. It's very interesting. It's a new ureteroscope on the market. You will see many of them available at the exhibition hall. Competition makes quality to improve, so this is very positive. This is a Storz ureteroscope, one called FlexX C1. It's in French, with a 3.5 work channel and 70 centimeters long. What struck us first was the weight. You will see it outside during the lunch break. Weight is really striking. And for procedures like the ones seen today that are 1 hour, 1 hour and a half long, weight is not a minor issue. Bending is 270 grams, so my first impression is very favorable. It is a ureteroscope that is nice when it comes to look and feel. Ergonomy is very good, weight is very good, and secondly, what struck us is the following: image quality.
Parece realmente un ureteroscopio reutilizable digital.
It
Y esto es un
seems like it looks like a digital ureteroscope, and it is
imagínense en un quirófano donde uno puede modificar flujos,
disposable.
de
So
calidad fabulosa.
the
Vean el edema
quality
que
is
tenía el
fabulous.
paciente
You
por el
see
ojo.
the edema of the patient because of the double J. Luis already mentioned the symptoms it causes, and James has a conference about it. You see the edema in the proximal ureter.
Tenemos esa litiasis ureteral. La
We
tratamos con
have
el
this
ureter o
ureteral
tratamos de ir al
lithiasis.
riñón
Do we
para fragmentarlo.
treat it in the ureter? Well, I try to push it to a place where the ureter is more dilated, but
Gaby, en esta época que tenemos ya
at this
disponibles los
time when we have available
¿utilizamos algún
flexible,
dispositivo para evitar
do
la
we use a
retropulsión o si
device
nos va al riñón
to
no es un problema?
prevent retropulsion, or if it goes to the kidney, is no problem? What do you do? Well, it's not a problem. I prefer, because of a matter of time and the cost of the instruments, not to open a flexible. I try to approach it there, but practically I don't use retropulsion. So almost 40% of these cases will get to the kidney, even if you are very careful. The lithiasis will go to the kidney, as in this case. So in 40% of the cases, we must have a flexible ureteroscope, because it's not good to have
¿Qué pasó? Nada.
one,
No pasó nada
and
porque
what
su litiasis
happened?
se fue al riñón.
Nothing,
Entonces,
because the lithiasis
sepamos que
went to the kidney.
litiasis
So
ureter
let's know
proximal,
that
la
in the
probabilidad es de un
proximal
40%,
ureter
que es esta
lithiasis, the
litiasis negra, esto
probability
lo que les contaba,
is
270
40% for
gramos,
it to migrate, and
270 grados de deflexión,
207 degrees
3.5 de
deflection,
calibre,
3.5 diameter, 9 French.
liviano,
And you
realmente
see
muy
that it's
agradable de
very,
tratar, tanto
very
vamos a ver
light.
un
It's
poco la,
very
al
nice to
procedimiento.
hold. So let's go to the procedure.
Aquí es este.
Perdón.
Este es el segundo, perdón.
¿Puedo preguntar?
Puede preguntar,
Can I
doctor.
ask?
Veo que retira el
I
doble J.
see that you remove the double J, you don't leave a guide, and you go in through the flexible directly without a guide.
Dos o tres cosas, buen
Two
punto.
or three things. That's a
Esta
good point.
litiasis
This lithiasis is small. The stone is small, so probably what we'll do is we'll create a couple of fragments and remove the fragments with a basket. If your question is whether we need a safety guide or not, the answer is in some cases yes, in some cases no. If you place the guide, you make sure that it will go to the kidney, so you will have to open a flexible and you will increase the cost of your procedure. If it is a procedure that won't take too long, you think it won't take too long, maybe a safety guide is not necessary. So what would you do? Would you use a safety guide? No. As you say, it will migrate to the kidney probably, so we increase the cost and we'll have to open a flexible. It's not bad to place a guide, but if the ureter had a double J for 2 weeks there, so it will be easy to get there. Well, we did a semi-rigid ureteroscopy, but we couldn't go beyond the iliac vessels, and it happens even in patients with double J. The ureter was very edematous, and so this is the placement of the flexible. Gabby, you have this stone in the upper calyx. What are we going to do? Fragments or dust? Well, you are working without a sheath, but the ureter is soft, so probably if they are small fragments, 3 millimeters or less, you'll be able to remove them. If you're patient, so as to go in and out, well, it's if you can remove the stone, so much the better. Does this patient need a sheath? No. As you see, the ureter create more harm. And in this case, I think the technique is perfect. No sheath and fast. That's Dr. Wanda Ramos, our fellow.
¿Cuántos fragmentos crees que haría,
How
Javi?
many fragments do you think you'll get? Do you have a strategy about fragmenting? We all agree that we are not going to dust this stone because it's small, we'll try to divide it into 3 or 4 fragments and then remove them. I would see if the larger fragments, I can take them out as you are trying to do. I cannot see what type of basket you're using. Sometimes if they are too small, it's difficult to take them out with a basket. So I would remove the largest, and then if any other remains, if the size is suitable for popcorn, I would do it. And then if you can take out everything, so much the better. Now, in this case, you can see the quality of the image. So if I hadn't told you that it was disposable, you wouldn't believe it. We used it only once last Friday because it has been available only since last Friday. I'm more of a dusting man. I don't go beyond 20 regarding power in the kidney. And this has been a first event, and you might want to have a piece of the stone to analyze, but I would dust. So would anybody do something different? Any comment? We agree that probably the sheath will not be necessary. Probably if you are sure enough, you don't need a safety guide, and you will try to dust, as Antonio said, or to create a couple of fragments to remove. Do you think that using this digital, what do you think about using it for endothelial tumor? Well, you mentioned it yesterday. The quality of the image is very similar to a reusable device, so maybe we'll have to see what the guidelines say and get large series. The problem with urothelial tumor is that they are rare. It's difficult to get patients because those are very, very rare tumors. So saying that one is better than the other, the study will take many, many years, but the quality of the image is really remarkable, and YouTube is not a minor issue. When there is a small bleeding, the disposable digital lose their light, and this really caught my attention. Tonio, final comment. Can we stop the video? We are using a thulium fiber laser, and those are the setting, 1 joule and 10 hertz, 10 watts, the short pulse. When we use a thulium laser, we use a short pulse because per se the pulse is long. So if we use a long pulse, it will be extremely long. So, and on the left pedal, we have joule, and on the right, 1.5. It would be a bit difficult to get that stone because it's brown, so probably the resistance will be a bit more. I think I don't have too much experience in thulium fiber because we have pulsed thulium and Moser 2.01 conventional. My impression is that in general, the oxalate stones, and that's my impression, maybe I'm biased, do better with holmium. I have no experience with thulium fiber. Our experience has been different. We still have a lot to learn. There are stones like this that were easily fragmented, and it was 1 joule. And in some, we get to 2.5, the limit of energy, and they don't fragment. So the thulium energy is very fast and it dusts easily. But for this type of stone, they are maybe not the best. But for an 8 millimeter, stone, would you use the same laser? Well, today we are fortunate to have magneto. As Said said, it's a holmium laser where you have a setting magneto that converts it into a thulium laser. So probably with this one, we would start with a long pulse with a peak power, a low peak power, and increase it according to how the stone responds. Before the magneto, We had thulium fiber and holmium. We generally start with thulium, but if it doesn't respond, then we change. So here the fiber is the same. So what we do is we just change the device. If in this scenario the patient in the other kidney had 3-4 millimeter stones and has already had a colic, how do you plan? Do you place a stent? Do you not place a stent? And if you are going to do a ureteroscopy and there is no previous stent, how do you do it? It's a very good question, and it has to do with what we discussed with Bhaskar this morning. There is evidence that treating the contralateral lithiasis is beneficial. Patients will have less colics, but this is a 9 French ureteroscope, so maybe you cannot get into a ureter that has never been treated, but if this procedure takes 15 minutes, we have an hour left, so we try to treat the other, and we try first with this ureteroscope, but otherwise, if it doesn't work, we'll place a double J. I agree with you. The contralateral lithiasis has to be treated, and if possible, Tonio said today that it increases the risk a bit. It hasn't been our experience. Norberto and Bhaskar has been very clear. If you select patients well, they are not infected patients, and I think it's a benefit for the patient to treat the contralateral stones. Well, what you were saying, the contralateral lithiasis, except if it is larger than 2 centimeters, I would always treat it, even if the other side is naive. If you can go up with or without a sheath, I would do it. And what you mentioned is very important about the weight of the ureteroscope. Yeah, it really calls our attention because you think that you are operating the patient and you are wearing a special apron, and then and also the ureteroscope. So, and then your shoulder hurts, so it's better if it's very light. Well, thank you, Gaby. Thank you, Antonio. And now we'll continue with our agenda.
Vamos a hablar sobre redes. Tenemos el hashtag, vamos a premiar hasta nuestro top influencer.
Now we are going to speak about social media. Yesterday you had a very good conference about cancer, prostate cancers. Dr. Jose Antonio Sanchez and Alfredo hasn't been able to make it, so we're going to have someone else replacing him.
Soy el primer orador.
The first speaker.
Said se encuentra, sí.
The first speaker is Dr. Said.
Síganlos, todos tienen muchos followers.
Follow them because they all have lots of followers.
It's not. So Pablo asked me, how do you get more followers in the I'm Not a Star? So it's very simple for any urologist to have more followers. So the tips of X and Twitter, Twitter is a platform, is important, it's a freedom to speak, it's to deliver a good message. So the passion, you have to like it. You have to like the social media, you have to accept the cons and pros, and you have to be honest. You don't need to manipulate words. Do not be too commercial. I mean, talk about the techniques, not the company or the machine. Record every operation, revise it, ask colleagues, visit others, spread good knowledge, and stay focused and make friends around, good friends. Let's go for the passion. I say always, do what you love, not to love what you do. So it's very important you have to love what you do in the Twitter. And be honest, credibility is a fortune. You have to be honest and credibility. Listen to the good key opinion leaders and declare everything. You shouldn't hide anything that you have an interest in. Not too much commercial. Try to mention the technique. Talk in details about it. Do not engage with company accounts, too many. Scientific societies like, I don't know, American Latina and groups, mention those people, national, international key opinion leaders. Record and revise is very important because you are seeing that videos I have shown you a while ago, because we recorded every operation and we learn from the details and we see other techniques. It's very enriching that you don't believe that you have the best technique. You should go and see others. You will be shocked. I learn from others rather than myself. Make short clips and direct message. Do not go and roam around your message. This is one of my secrets. I ask my nurses, my colleague, to record every operation. These are my keys around my necklace with the keys on the Laker hospital. I take photos, my nurses take the photos by the iPhone. I go home, I take these videos. I go home with a cup of tea, glass of wine, I don't know what, and you revise it. And you take it, you have an eye move. I know you are young, so if, for example, one of the seniors give you an operation flexible, you take that operation and you go home and you revise it. You will discover, I would do this. I would do this, why I didn't do this. This is very important to revise good steps and error. And we learn from errors rather than from the success stories. Then spread the knowledge. Don't be shy. Don't be say, I'm not a professor, I'm not a professor, I'm still young. No. Follow the QOL pioneers, follow them, follow the messages, always in tweet. Make it short to tweet. Do not extend too much information. People, they don't like big talks, like blah, 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 in like 15 lines. Make it 3 lines, 4 lines, direct message. And people love emoji. You know, they like the faces, the videos, the simples of the tweet. Stay focused, no politics, no parties. Do not talk about politics. Do not talk about local politics. Do not mention someone bad. You have to compliment people if you like. If you retweet, it doesn't mean you are endorsing. Show pitfalls and success story photos of loving the friends rather than show. Do not take it as a show business. Help junior. Follow their learning curve. You will learn from juniors and their videos, because when my resident does an operation, I take his video, then I revise it myself. Maybe then I ask him what steps you might improve yourself. Then we agree that these steps are very important to deliver it for the young people, not to do this and do this. Thank you very much. Questions?
Nuestro segundo disertante es nuestro top influencer del año
The second
2023.
speaker is our top influencer from 2023. He has beaten us all. Jose, you're welcome. He's going to give us some tips.
Bien. ¿Quién ha tomado alguna fotografía de lo que
Who
se va a comer?
has taken pictures of what you're going to eat, what you're going to do? All of us. That was the concept of Instagram. Transformed as all social media. I'm going to share some data. Instagram is the 6th most visited site in the world. It's the 11th most searched term in Google. It's the 4th most used social media in the world. And Latin America is the 2nd most used. We may see here that it's beaten by Facebook by a small margin. We have Instagram here, ranking 2nd. After Brazil, Latin American countries with the largest number of Instagram users are Mexico and Argentina. We may also see that It is used as a key source for news, not just to share personal things. They have become important places where people use references for news purposes. They say, I saw it, I saw the news. Where? On Twitter, Instagram, Facebook, two important Latin American countries as reference sites. And other countries, we also see a high penetration rate.
Bueno, yo soy José Antonio Sánchez, yo soy
I'm José
cirujano
Antonio Sánchez, surgeon, a urologist graduate from the National Medical Center. I had a fellow in renal transplant and co-founder of Urológica and Fundación Urológica in Guadalajara. Those are my social media. When I graduated, I fell victim to scrolling. Scrolling, infinite scrolling. That is, you're doing nothing and you start going past different publications. There were a few surgeons who have been certified in kidney transplant in my country. I'm the 26th professional certified. I wanted to tell the world, hey, I know how to perform transplants. I'm a urologist. How can I reach out to them? Publications would take too long. Theses would take too long to be published. And what did we have in hand? Social media. What did we do? We learned the easy or hard way, the 3-second rule. We had 3 seconds to get hooked to our content and know what we were doing, to tell people what we were doing. We shot some videos and realized that images were not enough. We realized that the first 3 seconds would determine whether people will stay with us or just keep on scrolling. We used several tools and realized that we did not need a significant budget. We had just graduated. So we started segmenting. We realized that people who followed us, who felt empathy with us, were in our age range, people who had the same concerns as us, but who had other sufferings. Young urologists do not start with transplants, maybe a circumcision, some smaller things, but when you start trusting you, they realize what the potential is that you may offer. So some people approached us. He's a comedian in Mexico, and viral words were a center for us to become famous in our country. You might think of quality versus quantity, but here it's the opposite. You have to post more, become more visible, because we fall victim of infinite scrolling. People who are waiting for coffee, they have scrolled and that's it. You do not need major instruments, iPhones or smartphones. Some others are Android fans. We had nothing, no professional cameras. Everything we posted and what has brought us here today, thanks to Pablo, is what you see here, the phone. That's it. So we started shooting videos. We realized that tools were simple. We did not need major knowledge because at the end of the day, we study urology and forget about the rest. And we could shoot some videos that became viral. And people started looking for us as a reference for certain types of surgeries. Here we see that people don't often speak of, for example, removing catheter. People look for content. People have a catheter, they don't know how it will be removed, who will remove it. They started looking for us to remove catheters. We removed the double J catheters. For us, it was cool. Then these people before undergoing surgery would come to us to remove the stone. We were removing stones already. And that's how we started. What you see there is my team. There are 2 basic tools. One is CapCut and the other one is Canva. In both, you may spend $100 a year and you will automatically have at hand everything you need for your postings so that they can look a bit more professional, even if, remember that we're going for video quantity rather than quality. what is worth is telling is what we know how to do. You are your own brand, you are the name selling, so you do not have to be that serious to be the best. As a result, people became more loyal. We developed a calendar with more professional publications. We worked on the design, and that's what got people to know us. We operate patients, not urologists. I would like to thank Pablo, who trusted me a year ago. I'm here for a second year in a row, and I wouldn't be here if it weren't for my children, my wife. So thanks very much.
Stacy, how many followers do you have?
Stacy.
Oh, I'm not sure. I think we could check.
What are the tips and tricks that you use for Instagram or for Twitter?
I mean, I think the goal is to really choose the platform that you prefer. Hay gente que le gusta el video, hay otros que prefieren.
There are people who like video, others who prefer writing something. So we have to choose which platform is most comfortable for use. I like Twitter for discussions about urology during congresses, but also I have a show in the States and Canada to publicly report on health issues, for example, on urological health issues. Holger, please tell us. Follow Holger, follow his video so that he can tell us how to make a funny post. Holger, please.
Bueno, muchas gracias, Pablo. Segunda vez.
Thanks very much, Pablo. Second time in a row in this Congress in Buenos Aires. It all started in 2021 during the pandemic. We founded a YouTube channel to inform patients and attract patients. That was not the first idea, but it was the consequence. These are results after 3 years. I had to get used. At some point, I liked seeing my face and seeing myself on the internet and online. So things were becoming serious. It was more convenient for me to be on Instagram. I felt more free there. You see my Instagram site, Urolo Free. Here, what was the motivation? Which was the motivation? Well, I have traveled a lot over the past few years. A doctor, at the beginning, my purpose was to teach people what I saw. I am familiar with the whole lab technique. These were the early posts. Now things have changed. They are similar, but they have changed a bit. You can see how I transformed myself from a serious doctor to a man who plays billiards and explains some whole lab technical issues through the billiards game. As we have heard, there are several platforms to post content on social media. These are the two I have experience with and the most important in our profession. Compared to YouTube, the Instagram audience is quite younger, so maybe half of the room belongs to this group, but all the others, maybe you can try to follow this. There are several important differences. It is very much focused on short content. Instagram and the vertical format is totally different from YouTube. YouTube is, I mean, in my experience, this is what we have seen with the data. It works more and more as a browser. That's what we are at Clinic Witness. Patients do no longer search how to become operated on because of hyperplasia. If they go to YouTube and if they optimize the search engine, you will find us, and in this case, myself. It's been a surprise. I would have never imagined patients would come to us because they have a relationship with me and they trust me. Why a funny post in the field of urology and where to post? Humor as a vector for complex content may prove useful. Entertainment attracts people's attention, especially with short posts where we only have the first 3 seconds. Added value plus humor may be one of the best ways to share knowledge. But humor is individual. So when Pablo told me do or deliver this presentation of a funny post, I think it's very subjective. What we have or what we should try in social media is do storytelling. The visual feelings in storytelling are not so individual, they are global. And I'm going to share an example. This is an account of an American urologist who has 25 million clips. In my opinion, he's a perfect storytelling. Plus, he is very similar to George Clooney, and it has perhaps helped him a lot. How do I do it? Well, this is what I wanted to do here, what I wanted to teach you here. The tools I used are the same cut and Canva for editing and assembly music. I have my own selection, as many of us, but also you use the app Epidemic Sound. And as to the structure, we more and more use AI. We all know this, but one important thing is this application here too, which we use, because whenever we want to make progress with all of these tools, the basic version or the free version is no longer sufficient. We need to invest. Key algorithm factors. This is very important. It's not that what we like maybe is what people like. We have to see what happens with the algorithm, something which is impersonal. There are different types of publications in Instagram, which you can see there. Each serves its niche. You have to determine which one works best depending on motivation. Interactions, this is very important, and it's still even more important in Instagram. Likes, comments, we can imagine this, but Instagram is giving push in the case of shared or stored posts. And you can imagine in the case of video, the visualization time has to do with the real duration. The first hour after posting is decisive. I don't know if you knew this. It is of the essence. This is not my data, this is just an example, but at least you can avoid posting at times where you have fewer followers. The objective is to create content that will not only reach followers, but also new users. This is what we need to achieve if we want to grow. The hook, attracting attention in 3 seconds. There are some ways of attracting people's attention in order to continue watching a video. And what are common errors made by physicians? Well, at least in my opinion, they are not consistent or compatible with Instagram ideas. Many lack irony about themselves. There's no humor without boldness, and we are too serious sometimes. Static, explanatory videos with no storyline. This can be done in YouTube, in any media, but remember that the target audience in Instagram is different. Few people between ages 18 and 34 will be interested in prostate cancer. This does not mean that there will not be any motivation to post, but we are talking about the fight against the algorithm here. Two complex contexts with no clear hooks. Many address existing followers, so reach becomes stagnant. And in this case, we get stuck where we are. Addressing patients is very important that I see, but much of these posts, many of these posts address patients who are not on Instagram. So we have to realize this. On Instagram still, and this is important to note, there's some of the patients are still young, but there are others who are older, and they still are interested in these topics, but not for the time being. Introducing yourself as a physician and not as an individual human being. That's also important on Instagram. People want emotions. Instagram conveys and provokes emotions. If I stand there with my pinafore and explain the same thing I do in YouTube, I won't be successful. Plus, value added and entertainment. Instagram is an entertainment platform mostly. And I'm going to end by responding to the question, the original question, how to make a funny Instagram post. I write down ideas in my notebook. Scientific information is at the core of what I do. Humor as a vehicle to deliver content. Complementary captions with serious quotes. I sometimes use publications available on PubMed to make things more serious. Also striking a balance between seriousness and entertainment. This is what I try to achieve. And next, I will give an example. That's a hook. The Chinese friend there, see, has no sound. Here I'm explaining the pilot we use, those who use laser. And at the end of the video, it is 20 seconds long, and at the end of the video, I posted a call to action. People can have more information in the caption, and the estimate is that the video should last 20 seconds plus the time to read the caption, another 12 seconds. That's 2 clicks on the video. Conclusions and key take-home messages. Know your target audience, understand the algorithm. Hooks are very important. You have to be creative, stick to humor, and offer value added. Also very important, showing, not saying. This is one of the most important things in this platform. And in order to be successful, it's not free, it takes time, effort, and resilience. Maybe trying, testing, and being constant. And if we are fortunate, we raise a thousand, maybe we have 500,000 followers. Thanks. Does anyone in the audience want to ask any questions, since we have influencers in the urology world? Rather than a question, I would like to ask for clarification as a urology influencer. Don't think you have to be on all social media. Don't you think that it's mandatory? Develop your own special image, work on it, and choose what you want to communicate. Maybe you want to address other physicians, maybe patients, or maybe you want to attract patients' children or parents. Do networking, and that's important to work well. Hooks are necessary, but if you want to be on Instagram, maybe you want to be on Twitter or only YouTube, and it's not necessary to be everywhere. Simply that. Thank you. I once heard a statement from Barack Obama which made me become a urologist. He said that in life you must have a plan and stick to it. With Stacy, I don't think she knows me, but we worked together during the corona pandemic through social media. We analyzed social media and realized that they generate likes, recognition, but also anxiety. Anxiety to see whether your tweet or posting will attract people or not, the time it takes. There is a B side to social media. And I wanted to ask you how you manage that, whether you get organized in your day-to-day operations, whether you allocate a certain time, how you regulate that, because it's not everything without a silver lining. Thank you.
Well, I said that I have two teenager children. When I started with the channel, I asked them if they wanted to help me, and they said no way, and I do it myself. It takes time. It's an additional job. I publish 4 publications in Instagram per week, and that takes 10 hours. Maybe I also have 2 small kids, and so I have to take care of them and hold one, etc. And communications are practically automatic, so maybe I sacrifice the quality for the speed of the publication. So the quality is lower, but the speed is very fast. One of these videos can be done in 20, 30 minutes. And that's it. And if people like it, okay. If they don't, well, Jose Antonio, you mentioned the number of followers. There are limits also. So when there are comments from colleagues or followers like patients, etc., when you have negative comments, what do you do? I understood also that I'm not a gold coin, so you cannot make everybody laugh. Somebody will always be against what you say. I have a teacher I love a lot. He chaired a Mexican council, and he said, "Aren't you ashamed?" And I said, "No, listen, I'm here and I'm answering your question, so I'm not ashamed at all." Any other question? Well, thank you all.
Vamos a continuar con el programa de la mañana. Hoy vieron que
We'll continue with the morning session. Today we spoke of education, we spoke of publications, and now we are going to have the last segment of this morning to speak of some notions that are not usually shared or conveyed. So I will invite Hernan Sandro, who is our General Director of the German Hospital, Cecilia Canton, a neonatologist, and Dr. Rudolf Schroeder, who is the Medical Vice Director or Assistant Director of the German Hospital.
vamos a hablar de algunos conceptos que son muy
We are
interesantes.
going to discuss interesting notions, 3 of them. The notion of value. Why will someone go to see Esteban and not some other doctor? What's different in Esteban? How to create that? The second thing is, today we spoke of Mariano and Norberto, and they are leaders. And leaders have personal characteristics, but there are certain characteristics that you build. And Cecilia will say why it's important to measure. All of us here have shown our things, but they are 3-point: value, leadership, and measuring the standards we need to bear in mind. Please, Hernan.
Bueno,
¿Qué tal? Buenos días,
Well,
buenas
good
tardes.
morning. Well, afternoon. Good afternoon, actually. I have several challenges with this talk. First of all, that I am not a physician and I'm speaking at a medical convention. I would never have expected doing it a couple of minutes before lunch. That's very difficult too. So thank you for being here, still sitting there and listening to our talks. And thanks to Pablo Contreras and Dr. Vitagliano, who are chairing this Congress, this convention, for inviting me. I have to discuss the meaning of value. Value in health, I think, is defined by the quality of the care. So along that line, I wanted to give this talk that will take 7 minutes. Pablo introduced me as the general director of the German hospital, but that's not true. I am not the general director of the German hospital. I am not a professor at the University of Buenos Aires. I am not the president of the Association of Human Resources of Argentina. All that is not true. That's me, Hernan Sandro. And I act as president, chairman, teacher, graduate, because we are what we do, not what we say. And I think that's important when we approach any activity, professional activity. No one can be a better professional than a person. And we always take care of what we value the most. And probably here there are people who love plants. And when someone gives you a plant, you always ask, should I have it inside, outside? Does it need sun, too much sun? How much water? And we provide the care to that plant according to what we are told. So that happens with plants. But when we speak of persons, we think that we can give the same care to all of them, and on that basis we will get at the same results. Well, no, we are over almost 8 billion inhabitants in the world, and each of us and each of the others need a different treatment to be taken care of. And nature has always been wise because we have only one mouth but 2 ears, so we can hear more than what we say. Hearing more than what we say invites us to reflect on a phrase that says, treat thy brother as you would like to be treated. And that phrase sounds very well, but it is still focused on others. It says, treat others, as the other, a patient or a mate or whatever, as you would like to be treated. And for that, we have to hear more than what we say and ask more. And of course, that takes much time, but I'm sure that that's worthwhile. Because in a hospital, the place of care par excellence, and when we say that value in health is defined by the quality of care, if we could create a formula, a team can be, or the equipment in the hospital is the same, the OR, walls, smart devices, etc. But when we include persons, when we add persons to that, and you are part of the persons that make up the teams in the healthcare institutions, then you multiply. So installations, processes, equipments add, but persons multiply. So we have to take extreme care of those persons, the patients, the working team. I insist, in the hospital, our responsibility is greater because someone chooses us for us to take care of them. If someone chooses you as a professional, they choose you for different reasons. Maybe it's not the person, him or herself, who chooses, but it's a family member, so that's our responsibility. And when we speak of people, we speak of working teams, so the effort of those persons generate higher results. And in a hospital, we see there is a physician, there's a nurse, there is a technician. I won't bore you telling you how each of those functions is important. Human beings need care from the moment we are born. I mean, a baby needs care when he or she is born. And I want to discuss work because I come from the world of care, but professionally, I come from human resources. I know that work is central, so your work has a role throughout your life and the patients too. And in all families, different problems appear. Intrafamily violence, alcoholism, that's a problem that exists in societies in Latin America more and more. Drug consumption at earlier ages, bullying at schools, a father leaving a child at school and the child doesn't want to go in because they don't have a good time, and that changes your way of approaching the rest of the day. Also problems with a job, and this slide I added it today because the game addiction is something that happens to people and it is growing, and this happens to everybody, to the persons. It happens to someone in your family and it happens to our patients and to everybody. And this phrase is important. I mean, just leave your problems outside your office or outside your hospital, but that's not true, because if we believe that a labor contract means that you are going to offer your work and someone else will pay you, well, I'm wrong. What we do is we manage emotions. So in any relationship we have, the patient just comes and pays for the consultation. So we have to understand what happens to the other and what happens to me. So we are managing emotions all the time. And there's a road. Alice in Wonderland says, it doesn't matter what road you choose if you don't know where you want to get. It's important to know where you want to get, and the road is also important in every relationship. You have to understand that on the other side there is someone, an individual, and we need to take care of that individual. Be very careful with if we harm that person, and we all agree that we have to take the utmost care of those things that are valuable. And when I treat someone else in a different manner, I am not only approaching that person, but I am approaching the people who surround me, because they see how I treat that person, and that will generate a certainty that when they are in that place, I will treat them in the same way. It can be a workmate, a patient, or a colleague. I have no doubt that a care circle will allow us to have a working team that is better. And when I say this, a circle is because I take care of my own place. I am doing what I have to do. The institution doesn't need to have a policy for care, etc., like management, and they just give names to things. So we are going to have better working teams. We will have better institutions in which we work, and we are going to have better societies, and we are going to have better countries. And if we have better countries, we are going to have a better world. So what I propose is to develop around you a circle of care, so that people are in the center, and that generates value in institutions and in relationships. Thank you for your time. Thank you for listening, and happy 2025.
estamos. Ahí va. Y con esto pasa. Perfecto. Bueno, buenos días. Muchas
Well, good
gracias por
morning.
la invitación,
Thanks
por
for the
estar acá con
invitation
ustedes, por la atención.
and for being here with
Necesito
you.
hablarles porque
I have
es
to
importante
say
utilizar
why
estándares
it's
de calidad
important to use
Me dedico a
quality
pediatría
standards.
preventiva.
I
Los
am a
últimos
pediatrician
2
and
años cambié
neonatologist for
el
the
rumbo
last
de
two
mi
years.
carrera y me dediqué
I
a la
changed
calidad
my
y seguridad
career
de
path
pacientes
and is
basado en
devoted to
información en el Círculo de Calidad Clínica.
care of patients' care.
Y bueno, quería contarles un poco
And I
de esto
wanted to
que
share
me cuesta a
with you
veces
something
instalar como a
about
los
this.
equipos quirúrgicos
And it's
y voy a empezar
sometimes
por decirles
difficult
que si bien
to
las entidades
start
acreditadoras
with
de
it.
las instituciones de salud
I will start
tienen
by the
mucho tiempo,
beginning.
recién es a partir del 99 donde se
In
publica en Estados Unidos
1999, in the
el documento
United
Error es humano,
States, the document
empezamos a
to err
pensar
is
en la
human. This
seguridad del
document was
paciente
published, and
como un
only then
objetivo
did
dentro
we
de los
start to
cuidados en instituciones
think
de salud.
about the care of the patient as
En los
something
equipos
important in
quirúrgicos
healthcare
de la
institutions. In
Organización Mundial de
surgical
la
teams,
Salud para el
the
2008 empezó a
WHO for
estudiar las
2008
complicaciones
started to
postoperatorias,
look at post-op complications,
la mortalidad tras cirugía mayor y los
mortality
eventos
after major
adversos
surgeries, and adverse
evitables
events that many times can be prevented.
y se arma un grupo de trabajo
And the work group is
para
organized
la prevención de infecciones asociadas a la herida
for
quirúrgica, seguridad
the
en la anestesia,
prevention of
equipos
infections, the
quirúrgicos seguros
surgical
y
wound,
el manejo de
safety
los
in
datos. Los 4
anesthesia,
primeros
and the
retos de seguridad del
management of the.
paciente, recuerden que el primero fue la disminución de las infecciones asociadas a la salud y el tercero la
This was
disminución de
the
los efectos
second
adversos
challenge.
relacionados con
There were
con la
others
medicación.
related to medication and to
Quería
infections.
hablarles sobre
This, I
cómo
wanted to
era el
speak
desarrollo de
about
la calidad y seguridad
the
del
development
paciente
of
en la
patients'
especialidad. Este
quality
es un
and
artículo
safety
que
in
les
the
recomiendo,
specialty.
pero bueno, una tiene que hablar de lo que sabe
I
y
recommend this
voy a
article,
contarles
but
mi
I need to
experiencia cuando
speak
yo empecé
about
a
what I
trabajar con los
know, and
equipos
I'll share with
quirúrgicos en el
you my
hospital alemán.
experience when I started to work
Empiezo a
with the
sentir que
surgical
todo lo
teams
que yo
at
había
the
hecho dentro
hospital,
de los equipos
and
de
I felt that
neonatología,
everything
toda
that
mi
I had done
experiencia,
in the
mejores recetas,
neonatology
tal
teams
vez no era lo que a
and
ellos
my experience
les
in
hacía falta, porque la verdad es que
processes
son
improvement,
son
maybe
inteligentes, son
they weren't
muy
necessary
efectivos,
there
expeditivos,
because
pragmáticos, entonces
they are
no me necesitan.
pragmatic and
Cuando
they
fui a
don't
ver
need
los
me.
tableros
When
y los
I
indicadores que
looked at
tenían,
the indicators
lo
they
que me
had
pasó
and the
fue
graphs, what
que al
happened
querer
was
hacer un
that
benchmarking
when
con
I wanted
lo que
to
sucedía
start
en
benchmarking with
otras
what happened
instituciones
in
o la
other
experiencia
institutions
en
or
otros grupos
the
de trabajo en
experience in
urología,
other work groups
ahí
in
dije, bueno,
neurology,
evidentemente
I
tenemos
said,
un
well,
camino para
we have
haciendo
a road
y no voy a
that we
hablarles de
have to
urología, voy a
walk
hablarles
along
solamente
together.
en
And
dos
I will
diapositivas
speak,
de
I
lo
will
que es
share just two
neonatología.
slides on
Soy
neonatology.
neonatóloga. Nosotros en neonatología, les quiero
In
mostrar esto porque
neonatology, and I want to show you
hablando
this
con
because
el equipo de
speaking
trabajo,
with the work
esto
team,
que tenemos en neonatología, en los equipos
this
quirúrgicos no lo
in the
tienen.
surgical team, they don't have
La
it.
neonatología es una especialidad que ha mirado siempre
Neonatology is a
la
specialty that
mortalidad
has
infantil, ha
always
mirado
looked
siempre
at
sus números, ha
mortality and
crecido y
its
ha
figures,
implementado
and it
prácticas
has grown and
para
it has
mejorar esos
implemented
números.
practices
Y
to
nosotros
improve
tenemos
those
a nivel
figures.
internacional
And at
ya
international
reconocimiento
level,
y a nivel local
we
la red
have
Neocosur, que es una red muy buena
at
que nos
local level,
permite
the
nosotros
Neocosur
todas
network,
las neos que están
and there is an
afiliadas a esta red
international networks
pueden
as well.
cargar sus
And
pacientes y los resultados con
you
sus
can
pacientes y
load
las
your
variables
patients and the
que
results
afectan
with your
esos
patients
resultados
and the
los tenemos
variables that
ahí.
affect
Podemos
the
ver un predictor
results
de
or the
muerte
outcomes.
o
There is a
outcome
predictor
combinado
of
como puede
death
ser
or a
la
combined
displasia
outcome
broncopulmonar.
like
Y lo bueno de esto
bronchopulmonary
es que
dysplasia. And what is good
a las
about
neos
this is
pertenecen
that
a esta red
the neonatology
les
units
permite
that belong
medirse.
to this
Ustedes
network,
detectan,
they can
vuelvo
measure
para atrás,
themselves.
ese es un predictor de muerte, ¿no?
This
Y
is a
dice,
predictor of
empiezan a
death
hacer la edad gestacional, la edad
and
para las
a
malformaciones,
gestational
los efectos
age,
corticales
weight at
cerebrales y el
birth, the
sexo,
use of
se
steroids,
genera un
sex,
score de
and
mortalidad.
that
Con esto,
creates a score of
cada
mortality.
una de las neos está
And with
identificada, vamos a
each
seguir el
of
número
the
50,
neonatal units,
que son amigos míos, y
number
como van a ver,
50
de
are
acuerdo a
friends of
las
mine.
características de los
And
pacientes
as
que
you'll
tuvieron,
see, according
van a
to,
tener
according to the
una cantidad de
characteristics
muertes
of their
esperadas en
patients,
el sentido de la de
they will have
129,
a
y esos
number of
tuvieron
expected
130. O
death.
sea que la
In
razón
those
que les
days,
di
it
es
was
de 0,6
197, but they had
de mortalidad,
130.
con un intervalo de
So
confianza que
mortality
está
was 0.6, and with a confidence interval is below 1. And here we have mortality published by different centers. What is good about this is that they can compare themselves and know what their outcomes are, to know if the strategies that they are using are the right ones. The truth is that surgical teams are not the same. I cannot I cannot have the data to benchmark. What are the challenges of urology? Is the incidence of sepsis after the procedure similar to that of other centers? The percentage of stone-free after the procedure is the one expected. So what are they doing to get these results? What could improve? And a phrase that I want to leave you is, without a starting point, there is no direction that will take us somewhere. We should also think about the benefits of adherence or respecting standards at institutional level. It improves the institutional performance, it improves cost effectiveness, it turns out into an organization that is highly reliable. When we spoke of media and they're used to disseminate information, well, the responsibility of quality sectors have to provide objective indicators that show that the care in that institution is good, to empower patients, to give them the possibility of choosing and be certain about the care that we are providing. This allows to educate the teams, have access to quality experts, and there are results in all the dimensions of the care. I see that in surgery they just measure the clinical effectiveness of certain treatments, and the outcomes in patients do not only depend on that effectiveness, but also on other dimensions like care focused on persons, safety, accessibility, the continuity of care, and that depends a lot on a change of paradigm and multidisciplinary work. It's no longer a relationship between the physician and the patient where the doctor was up there, but this system has to change. It has to change in leadership and work with people. And it allows us to measure ourselves, compare ourselves, and be one of the 10 best hospitals in Latin America. This is our graph with indicators. And if I am not mistaken, Dr. Bernardo made a comparison about something Luis said. Luis was concerned because they had to measure the pressure, and he said to the industry, we have to measure the pressure because we need to control that. And when you manage a service of urology and when you're in charge of a whole working team, you have to measure other things. And Dr. Bernardo made a comparison with racing cars. I know nothing about racing cars, but this is the same. We have to have a graph because it's not just one single indicator that we need. We need many other things and lots of information. I have to see everything as a whole and know where I'm aiming at so that I can get there. And learning too. We have a control of safety incidents with patients, so we have to analyze them and create improvement plans and evaluation. The quality standards that we have are assessed or are evaluated periodically through a direct assessment or through a close medical history. And so we need to challenge everybody for this ongoing improvement. And I feel I'm privileged because I work with an excellent team, and I'm thankful to them because in these last 2 years that I spent with them, I really like them a lot, and I'm very happy, and I want to thank them and you for your attention. And now we'll hear about leadership tips.
Bueno, buenas tardes.
Well, good afternoon. Thanks for being here.
Pablo me ofreció dar esta charla, la verdad que
When Pablo offered me to deliver this talk,
primero en decir que no.
I would say no. Why deliver a talk on leadership? And when we told me I should deliver it in 7 minutes, I said it was impossible.
De los temas que hago yo y creo que obviamente dar una charla sobre
I'm used to delivering talks on surgery,
es más fácil que dar una charla sobre liderazgo y sobre
and that's easier than speaking of leadership, especially before people who lead teams. So I thought of sharing a couple of ideas of what I think a good leader should be. I started Googling, asking ChatGPT and artificial intelligence to lend me a hand in speaking about leadership, and maybe you can bring with you a nice impression of what I think leaders should be like today. First, a leader should be able to motivate and guide people towards an objective. So having an objective and grasping those people to motivate them to go to that place. If we speak of motivation, motivation can be broken down into two: is having an emotive and transforming that motive into action. Motivating someone means finding an objective where we want to go and then heading for that objective. There's no point in motivating and not having where to go, because people will say, well, why get motivated at work if I don't know what to do? We have to find a path and give a path for people to progress. For that to happen, you must provide context. It's not just we head here, but providing an environment, a mystic teamwork to ensure that context will bring people to realize that objective. Also relevant is the fact that we need to make people do, but enjoying that on the way. Just by giving them an order to execute it, knowing that the one who has to execute it is not enjoying what they are doing, this will lead to failure. So we have to think of some motivation, of a sense of what they are doing. And also essential is understanding who we are working with. If we don't know the people we are working with, it's almost impossible to set a path for them.
Voy para atrás. No hay un tipo único de liderazgo.
There is not one just leadership type. There are different kinds of leadership. It's not that you can learn to become a leader. If you can learn to be a leader, it's not just one fixed leader saying that you have to do this or that. There are leaders who are in an operating room. This is a true picture of a large surgery we performed. 6 surgeons working simultaneously, and we had to lead and do what we intended to do. One thing is leading a battalion at war, and another thing is leading a soccer team. It depends on the objective, the context, where you are. Leaders have to adapt to that to lead their teams. People are not born natural leaders. You learn to become a leader, you practice it, you teach it. And we may all be good leaders if we take these things into account. Let me just deliver one exercise. Let me see if this works. Can you hear the mic? Let's engage. Sorry, but with this mic is not working. Let's see, my theory is correct. I'm going to ask you all to raise your right hand. Apologies for the time. Your hand. Raise your right hand. Raise your index finger, the thumb, the small finger. Once the index finger again, and we touch your forehead. Great. Now we say hi again. Once index finger again, we touch our cheekbone. Cheekbone, I said. You touched your cheeks, but it was a cheekbone. The chin, sorry. So we lead with example, not with words. People tend to believe that just by saying something, they will do what you want, but it's not the case. People imitate actions, behaviors. So if we want people to do something, we should do that. If I am a surgery head and I want my surgeons to start on time, if I arrive late, no one will do what I wanted them to do. So you must realize that people learn from the example. You have to lead with example. If you do not eat well, children will not eat well. Well, the exercise did go well. The world changes through example, not opinions. What I also think is important is empathy. If someone comes to talk to me and I want the person to do something, but the person is not comfortable with me, I will not manage to make them do it. So we need to work on the affective presence. You need to know each other, work on emotions, make people feel comfortable with you. Attend the meeting knowing that the person's gonna be there will make me uncomfortable. Probably it will be very difficult for that person to make me do what we want them to do. We have to create an emotional climate for people to do what we want. Very quickly, we need to be flexible, not just stick to an idea. Ideas change. Maybe you go in one direction and realize halfway that that's not the right path. You have to go the opposite direction. You have to be flexible, courageous. You fall, stand up, fall, stand up. Don't quit in the face of adversity. Making progress is synonymous to a good leader, human approach and empathy. Don't stick to ideas. I should do this or that. No, just do it. The I should is very bad. No one does anything. Action, action, and action. Be open to diversity. Listen to other opinions. In your work team, you should have people who think differently. A good leader has good assistants. A bad leader will look for third-tier assistants to feel top. Always look for top players to complement and supplement your actions. In concluding, and so that we share a take-home message, leadership means having a positive influence, guiding others towards a common objective, and inspiring people is much more effective than instructing or commanding. Thanks very much.
Bien, para terminar la mañana vamos a invitar a una gran amiga, la doctora
Laura Moro. Friend Laura Moro.
Laura es la jefa de
urología del Hospital Urology head at the Maciel Hospital in Montevideo. She is a leader, an opinion leader in Latin America, but today she will not talk about catheters or endoscopes or stones. We have talked about values, standards, leadership, and now we will speak of equity and equality, gender and equity and equality. Welcome, thank you. We'll try to be brief because we're all hungry. I would like to thank you, Pablo, again for making me a part of this, which is ever more successful. The talk that has been ascribed to me is not something to be thankful for, but well, this is something that someone should mention. We are going to talk about gender and equity in endourology.
Bueno, para hablar de esto, primero quiero que sepan un poco la
I want you to know what is the story behind the history of women urologists in Uruguay. We are 105 urologists in the country, 86 males, 21 females, 19 residents, 9 males, 9 women, 10 males. Today, graduate urologists account for 20% of the total number of professionals in this field. How do you access urology? Well, first, it was through a postgraduate test. There was no internship. The first woman joined in 1996. Pablo has given out some tips. It was myself. The second one joined in 2001. I was 5 years speaking about football, women, and cars. I uh, was up to the test. And in 2004, that was when the big change took place in urology in my country. That is, women started through a specific internship. In the past, there was the surgery internship, and if the teacher allowed you, you could try urology. Access was complex, and since tests became anonymous, two women joined the internship first in 2004, and then every year there were women admitted to the urology internship. Urology was the last specialty in Uruguay where women joined. Highly complex a situation for us. I must say that despite the tough path, the evolution amongst male urologists has been good, far better than general surgeons. I'm thankful and proud to say that they are achieving equity that doesn't happen in surgery. It's sad because there are women surgeons who were my mentors, and despite that, in the case of surgery, the number of women became stagnant. What is the training in endourology? Well, we do not have fellowships as such. Understand it's just 100. Everything is small, different from what happens elsewhere. There was no need so far. During the internship at the clinical hospital, the university hospital, there is a rotation 4 months per lithiasis, which is small, and some 15 years ago, third and fourth year residents go through the Maciel Hospital Urology Ward, the hospital where I am head now, where I have a full year performing just endourology and laparoscopy procedures. That is why I want trained residents to come. They need to have experience other forms of surgery to make the most of that year. They conduct 350 procedures in a year. It's not perhaps a lot for other countries, but yes, for Uruguay. The rest of those who perform endourology have become trained in private centers. So it's at the private center's will to invite you in or not. Focusing now on the survey, we conducted an online anonymous survey. 55 responses, 24 women, 28 males. The numbers were even, to my surprise. And in terms of the generation distribution, 27% were urology residents, 27% junior urologists, young urologists less than 5 years in the profession, and 46% senior urologists with more than 10 years experience in the profession. I asked this because I wanted to know what was the interest in urology in Uruguay. And surprisingly enough, 37%, that is the majority, were interested in the training in endourology. Of those who engage in endourology know about the explosion of this subspecialty. It has made significant progress in terms of the technology used, and this is what is making it more attractive. I asked by age who has had access to fellowships or internships, either abroad or what you can do in Uruguay. As you can see there, in terms of age, clearly in the senior group, the majority of answers were negative. There was no such training, but in the case of young people, we start seeing a betterment in the curve. They have greater access. Also, we asked about the difference based on age and gender. We see that in the case of senior urologists, 66% were males who had access to training, 34 women, and in coming generations, even though there are still more men, the gap is narrowing. This is a question addressed at what you perceive. I want you to understand that these are perception surveys. I don't know if it is reality, it's what people perceive. Have you perceived any difficulties because of your gender to access training opportunities in urology? 70% said no, 25% said yes, and 5% doesn't know, doesn't answer. Now, when we look or break down these global figures, which appear to be okay, we might think we are well off, but actually we asked, we tried to go deeper. We asked whether women considered they had equal access, opportunities and experiences in endourology training. Figures there start to change, even though those who said yes are a majority. Amongst the senior group, in the younger group, the figures drop. But take an even deeper look. We asked whether they were in disagreement with equal opportunities between men and women. The group that said no, that they did not identify equality. The vast majority of those who do not perceive equality are women. It's a matter of perception. You may say yes or no, but that's what women feel, at least in Uruguay. They don't feel they have the same opportunities. I always try to bring down figures to reality. There are 18 endourology centers, including both public and private. 6 endourology centers employ women. Of these, only 4 have urologists who are women who are trained in all forms: intrarenal, percutaneous, endourology, full. And out of those 4, out of the 6, better said, 4 have urologists, and in 2, the women are assistants. They are not the main urologists or chief urologists. So out of 18 centers, only 4 have women employed with true full training. Of course, we are fewer as a percentage, but it's been 17 years now. Maybe some others might have been trained. It's more complex than just a matter of gender. Access is difficult. Maybe the only more democratic thing would be going to Maciel Hospital. I don't decide who comes to my hospital. It's the professor who says this or that person will go to your hospital. The reality is that for many years now, I've had an even number of women and men. We are on the right track in this regard, on the path of equality. I invite you to read this publication, a far more complex survey conducted in North America. Pablo showed me this to explain why I had to speak about this. The result, when you look at it, will see is the same. Males feel no difference, and women do feel a difference. So at the end of the day, what happens in Uruguay is the same as what you may see in the States. And lastly, this, you will hate me, out of the 4 centers that have women working as endourologists, the head or person responsible for these centers are women. Thanks very much.
¿Preguntas o aportes para el panel?
Any questions or contributions to the panel?
No, muy cortito, muchísimas gracias porque
Very short, and thanks a lot, because there are weak points from the authorities. Thanks for your transparency. I want to thank, and I think that one needs to open a bit the mind to how to improve institutions. We have hated Cecilia. We have had visceral hatred against her, but she has had a huge resilience. And nowadays we thank her that she's there pushing us, because maybe you do things automatically and you don't realize what your mistakes are. And then there comes something with scientific strength and points them out. And today, the hospital, as a service chief, I hate the number of meetings that we have, but it has improved things. and we have staff because here we are the visible faces, but there are many, many people who are behind us, and thanks to them, we can be here. We have very professional people, and they point out things with doing exchange, and it was difficult for us after some time to incorporate the remarks from the clerks that are in charge of quality and ongoing improvement. So maybe we physicians find it a bit boring, or we don't like to receive negative comments, but nowadays I thank for all the remarks that we get and for the ones that will still come. Thank you. Thank you. We finished the module, the morning module, and now lunch.
presente, profesor Castillo. Así que invito por favor a Esteban Acuña, Felipe Águila, José Antonio Salvador, Felipe Pauchar y José Ignacio Acuña para que nos acompañen. Las va a moderar Alex y Sandro Barea. Venga por favor, Sandro. La verdad es que es un gusto y muchas gracias. Sinceramente, muchas gracias.
The truth is,
¿Cómo se atenderán los chilenos con piedras en esta semana? Porque están todos aquí. Pero bueno, cuando hablamos, dijimos, bueno, son los primos del otro lado.
we said, well, these are the cousins. We have cousins on the other side of the river and on the other side of the mountain, so it's family. So thank you. Well, Pablo has already commented what this section is going to be about. Dr. Marchand will start in the surgery. Fernando, Dr. Marchand, can you hear?
Bueno, aquí estamos todos atentos. Venimos de almorzar, así que.
Well, we have just had lunch, so you have to be a bit patient. The first thing we are going to ask Fernando is to give some comments about the case. I'm sorry, we cannot hear what they are saying. We cannot hear.
percutánea miniaturizada realizada súper miniper. Tenemos un diámetro de 14 French para utilizar y ya le iré mostrando. Este es un paciente varón que presenta un dolor lumbar sordo del lado derecho. Te ve bien la imagen, Sandra, ¿no?
I'm sorry, we cannot hear, so we cannot interpret.
Simple en la cual demostró una litiasis.
There was a lithiasis that we could see, and it was complemented with a CT without contrast, as you can see, as the one you can see here. And we detected this renal lithiasis, whose diameter, largest diameter, is almost 27 millimeters, and the volume, complete volume, is 2,500 cubic millimeters, with a density of 700 UH. And here, of course, the discussion with everything you've said in this course, maybe we could have tried to do a ureteroscopy with fans or this or aspiration, but for us, those are elements that we are not familiar with, and we felt more comfortable with percutaneous surgery, especially with the miniature instruments we have that we can discharge the patient on the next day. So if you have any doubt, please ask. It's a simple case, and these paelic stones in the inferior calyx are in Valdivia. We place the patient in a Valdivia position, supine. I don't know whether you have a question, Alexis or Santos, with respect to the case.
Escucho bajo, ¿ah?
I don't hear clearly.
No, si están preguntando, no escucho.
If you're asking something, I cannot hear.
Ahí sí. Sí, Alexis.
Now I do. With respect to the surgery, did you give previous antibiotics or anything special? Well, in this patient, he never had a urinary infection, so the only consideration we have is to ask for a uroculture as close as possible to the procedure, and cephalosporin third generation, cefixone 2 gram 1 hour prior to the onset of the procedure. Well, this is the setting.
Bueno, primero que todo,
First of all, I want to introduce our technologies, talking with the anesthetist that patiently has been here waiting. We have our two residents, the Valdivia position, you know. We have a resident who is with the ureteral catheter already in place. We have the C-arch. And you will also see our nurses, and the patient's chest is already uncovered. We have marked a line, and it's a 090 position so that we can insert the needle in the lower calyx. And there at the back, we have this pump, which is an irrigation inspiration pump, which is key to use the super mini tech. In other things, you can use serum or saline, sorry, but here we have to use a pump because we need a pressure of 500 millimeters of mercury. The pump settles, defines that automatically, and it allows for a good irrigation. This basically, we have our instruments here. What you can see here is the super mini perk. I'll introduce it to you later on. And now I'm going to wash, and you'll have your two talks, and then we'll come. Dr. Acuña, please.
Sí, créeme. Buenas tardes, gracias Pablo.
Good afternoon, and thanks Pablo for the invitation. Thanks Gonzalo.
Bueno, es un honor que estemos.
It's an honor to have the cousins here together, and with our captain there performing the surgery. My topic is pre-op preparation of the patient. I am Dr. Esteban Acuña. Many guidelines say that the surgery for Staghorn stone is the standard treatment is nephrolithotomy, and they provide the different guidelines. We have to get the labs, we have to have a ECG. Besides the images, we start with the CT, X-rays, and since it's a Staghorn, we would have to have some contrast in case there is a doubt about the elimination. Then we have to get a bone scan. We have to explain the patient, get the informed consent, where we are going to discuss about the pros and cons, and this has to be signed prior to the OR, and then we give them antibiotics, or if needed, we have to do antibiotics for a longer time, and we should also ask for the stone to be cultured. It's very important for the planning to see some software. The Hospital de Clínicas doesn't have that software, so besides getting the 3D image, it calculates the volume, and it also calculates the time for the different surgeries. When we have the image in 2D, that's the one on the left, we could try and see where to plan and what calyx to choose. And once we have the 3D image, we see exactly where the papillas are, and so what the right way is to try and get there and pass the guide or plan a combined surgery. And see how many tracks. There can be two.
O tres tractos, como una cirugía que acá está mostrando el doctor.
Like the surgery that Dr. Sen is showing. And the purpose always is to try and leave the patient free from stones with minimize and at the same time minimizing morbidity. So we have to have clear in our minds that to plan the approach, we have to think what could be the worst complication, a sepsis, although it's not probable, but it's a high mortality if that happens. In that sense, there is a number of papers and meta-analyses and systematic reviews where they start looking for the risk factors and they determine different risk factors. And so currently, what I was commenting this morning, C-reactive protein is a marker that is not so good per se, but when you get the index with albumin, you can get very good predictions so that you see which patient you have to take good care with and which not. Work was done to evaluate protein C with the albumin index, and you see that by doing the conversion and the area under the curve of all the biomarkers, that was the one that had the highest sensitivity. So a very important item that will change the practice is that I'm going to ask PCR with albumin to all patients so that the patients, regardless of what I think or I don't, and we have to review different papers, we can improve that. What for? So that we won't have complications that would be serious. We have to be as standard as possible and try to have all the patients presented to us by volume, because this is a review by the group of Dr. Kleiman, where you see that if you use the formulas, especially in Staghorns, the volumes are not the real ones. So in order to be standard and to plan, you have to look for the software. It's free, and then will be standard. We'll be able to do standard. So we have to look for tools like AI, and surgeons can understand better. And the thing is that you have to take the time to plan the surgery, and you have to assess the risks, and so that the surgery can follow and continue, and so that the patient will be controlled and not the member of. Now Felipe de Águila is a colleague, is the head at the Hospital San José in Santiago. Good afternoon. It's an honor to be here with friends and professors and people I like a lot.
Perfecto, me tocó hablar de un tema súper interesante.
My topic is extremely interesting. It's renal puncture and CT. My only conflict of interest is that I like rays a lot, and I was an endourologist that irradiated a lot. Probably it's not very good when you try to educate. When you have fellows, you have to understand that it is a problem. Many times we have to choose between something that is good and another thing that is also good. And for those of you who don't get a CT, let's combine, because things don't have to be white or black, but we can combine irradiation and do fluoroscopy, but you have to start. You have to start using ultrasound. And this surgery has undergone different changes. We have discussed this throughout the day. And ultrasound has always been with us, and it was there waiting for it to be given the importance that it has. It's important to understand that we we have evidence that renal puncture have to be done by the urologist. We have seen how in the US, progressively, the number of punctures have increased that done by the urologist, and we do most of them in our case. And the puncture done by the urologist has less complications, shorter admissions, because you have to know exactly where you have to puncture. It's also important to understand that lithiasis is a pathology that is complex, because remember that we do average 2 CTs, and the follow-up is up to 24 months, and it is done with CT. A percutaneous surgery in hands that are not so expert maybe needs to irradiate more than 8 millisieverts, and there are factors that will determine more exposure, like obese patients, multiple tracts, etc. So for all this, it's very important to look for strategies to reduce radiation, and all the ones we know, like lowering the doses, trained operator, collimate, the space of fluoroscopy. The best strategy is ultrasound. We know that to the extent that the neurologist is trained, he improves his performance, but as they train, they also reduce the exposure to irradiation. This is an important argument to start to use ultrasound. For about 10 years, we said that ultrasound was not inferior. So if you do percutaneous surgery with ultrasound, doesn't mean that patient will have remains of the stones. I want to persuade you that not only does it help to reduce the radiation, but it provides other information that we didn't have when we only used radiation. The first meta-analysis showed that regardless of the position, supine or prone, there were no significant differences. And the last meta-analysis shows once again, with over 3,000 patients, that there are no differences in the performance and the outcome we get in surgery if I use ultrasound. We know that obviously when you use ultrasound, the radiation is much, much lower. That has been proven. Maybe it takes a bit longer, and this is part of the learning curve. And when you start to use ultrasound, maybe the puncture will be slower. We have to choose the case appropriately. But if we add and subtract, we will always gain if we add ultrasound to our percutaneous procedure. It will give us a 3D vision. It will show us the direction, the depth. It will be a more cognitive than intuitive procedure. We'll see the structure, recognize posterior calyces. We can use the Doppler. So only benefits is what it contributes. You have to consider the hypermobility of the kidney. The space can be more restricted. There is a certain difficulty in the technique when you cannot see the needle so well, but as I say, most of the things are advantages. And finally, comment that ultrasound is here to stay. It is a necessary evolution. The reduction of exposure is very important for our patients and for us, because patients will undergo one procedure, but we are here every day. So it is a complementary tool. It's important to choose the cases well, especially during your learning curve. It allows a safe, feasible, and efficient percutaneous access, and it's a curve, a learning curve that is shorter and shorter with the advice of professors like the one we have here.
Fernando, ¿nos escucha en quirófano?
Fernando, can you hear us at the operating room?
¿Me escuchan? Estoy muteado.
Can you hear me? Hello.
¿Quieres comentarnos cómo va?
Would you like to tell us how it is doing? Yes. In this case, I'm on the patient already. In the viewer, these are my hands. In the viewer, placed on my hand, we can see the Valdivia position. And two quick things you can see here. I have two lines. The first one is that looks for my colon safety line. This patient had a posterior colon. So when the patient came to the operating room, I sat him and measured the distance, the safety distance between the column, the backbone, and the side. I draw this line. What does this line mean? From here upwards, I cannot do anything, because if I puncture, I may touch the colon. From here to the bottom, I can do whatever I want. This position, it changes. There's the colon here. We have used a 090 technique. You will see we're going to use the contrast medium. Raise, please. The first thing we do, you see the continuous ray. I have the needle, but let me show you that what you do is mark the calyx that you want to choose, and you puncture. That's what you can see. Stop the rays, please. You can see there the needle. That's the direction I'm going to follow. Then with the little image, I will ask the technician to give me 90 degrees with the ray. That's what you will see. He's moving the rays. What do you need? There.
Y entonces esta parte a veces puede ser un poquito engorrosa.
So this is a bit, or maybe a bit cumbersome. He fixes it at 90 degrees. I have a needle. It's to perform the exercise. And we're going to administer the rays, please.
Ustedes pueden ver justamente toque de rayos. Pueden ver, ahí están poniendo contraste, se ven bien los
They're
rayos.
using the contrast medium. You can see well, right? Give me the puncture needle, please. Or another one you may have. What you do is stay there.
Vean los rayos en este minuto, no lo que es. Y ahí uno fija. Y si ustedes pueden ver,
if you pay attention, there's the line below. You draw the line. Let's focus again. And once we have done that, there we go. This is always a bit difficult. It's not a very comfortable position, but we manage, and with that we use little radiation. I have to reach 0, please. And then we have a puncture line, which I am showing with my finger. We have the needle.
Rayos. Y entonces ustedes pueden entrar un poquito más, por favor, pueden ver.
You can see that I'm standing on the needle. I drew a line. A bit of contrast medium, and there you have the puncture. And just as you can see, the needle runs parallel to the operating table with just 2 or 3 touches. You can install the guide. It is there. You can see it there. You can take it with cytoscopy. It is important. It is a needle diamond tip with echo tip. And then after that, we will make one shot with a super mini perk with one shot, which is the one that I'm going to have now. This is 14 French, well prepared. And this is the sheath that we're going to use the mini perk.
Me pueden ir preguntando, voy a hacerla, ustedes pueden ver ahora bajo rayos.
You can see the images with some light rays. There we go. I'm not exerting any extraordinary force, as you can see. It's skill rather than anything else. Not so much contrast medium. We are inside already.
Bien. Corte de los rayos. Un toque más, por favor.
One more touch, please.
Se ve bien, ¿no es cierto, Sandro?
Sí, perfecto.
You can see right, Sandro. Now, use saline solution to determine that or to prove that the placement is correct. You see there, you see right?
Una cosa que uno podría montar el Super Mini Perk es la guía
You might mount a super mini perk on the guide to see whether we are okay, but the truth is that we are there, and so I asked the resident to remove the whole guide and we're going to set up the equipment. It consists,
acá está la parte que va asociado a
this is
esta
the
cánula
part associated to these amplats. You have to find the red dot. Just like with anything else, you will connect it and screw it here. Now we have the special irrigation in place, which is the one, it goes directly to the pump. There is a resident, and what we are going to do, Dr. Benitez, this is a super mini perk. It has 8.5 French, very thin. And this is the one that I want to use for exploration purposes. Please, here, Andres. And it has this stop here so that you will not go too much into the kidney. A bit of irrigation, please. We have irrigation and aspiration already in place. Let's check everything is okay.
Me falta acá. Vamos a poner el tope final, que es el.
We are going to set up the laser top. Is irrigation working? So you see the endoscopy, right? Perfectly well. We came across the laser.
Un poquito ahí estamos de hematuria, estoy un poquito más atrás de
a bit of hematuria, slightly behind vis-a-vis the usual pattern. I advance my amplats and I perform the lithotripsy. We have 1 joule with 20 hertz. That's the setting. That's because basically what we're looking for is to have fragments. I do not want to perform dusting. I want to fragment the stone. The 14 French amplats may remove fragments of up to 5 millimeters in size. So there's no point in dusting the stone. That's the fun part of it and what makes the procedure fast. This is the laser setting. A bit closer, please. That's me. I cannot come any closer. But believe me, it's 1 joule, 20 hertz. We are going to start the stone removal. And not to bore you, let's move on to the next talk, and not to bore you. We were hearing Dr. Aguilar talk about the puncture under ultrasound. Do you have any comment, experience in defending this, which you have just done? Generally speaking, I use ultrasound when I have some reasonable doubt that colon will cause some trouble, or if there is a prominent liver that will cover up the area where we're working. I do not use it customarily, but based on what Dr. Aguilar says, it's a good tool since you become used to performing a nephrostomy in order to then use it in percutaneous surgery. I don't believe in dilation under ultrasound. Great. Let's move on. Just one question. This is Esteban. Hello, Esteban. Especially for young urologists and residents. What tricks do you recommend in order not to remove the amplats, the guide? I was surprised to see that you work with no guide wire. It was an ortho's trick. We're certain that we were inside, but there is a catheter. It's a double lumen catheter. It's 7 French to 9 French, and you can set up and install 2 guide wires along the way and leave one outside. That's a good option too. So I'm going to start with the procedure and you continue with the talks, right? Okay. Jose. Once again, thanks very much for the invitation. I have to defend something which is undefendable, that is using conventional surgery at this time of aspiration mini-perk and supine mini-perk being in fashion. This is outdated. These are my disclaimers. I have others, namely that in 2016, that was the last year when I performed a conventional percutaneous surgery, and they moved to a mini-perk, and it was the last year when my team won something ever. It is unarguable that PCNL has a key role in the management of diseases. The consensus is more to centimeters in size, but there are complications for the patients and the healthcare system because costs rise. Conventional percutaneous surgery, conventional access is more than 20 French. After that, we can discuss mini-perk, ultra mini-perk, and as the smallest to bear a rigid nephroscope would be a mini percutaneous surgery. In theory, I mean, the onset of mini PCNL have similar fewer, similar stone-free rates, reduction in complications, and the question is why standard PCNL would have a bad name amongst urologists, just like this lady here. When we talk about complications, what we see in this paper, when you look at serious complications, multi-organ diffusion, death, it's less than 1% of time. So these risks, which appear so terrible, are infrequent when we look at hard data. Now, if you calculate this, there are more theoretical complications, bleeding, perforation, postoperative fever. But when you try to improve, how can we improve? By better selecting patients, administering antibiotics, previously selecting the density. In the case of more obese patients, we have more complications. With elderly patients, there will be a higher complication rate. And in hospital A, when they have chronic kidney disease, and something relevant too is that these surgeries are more successful. Better results are obtained in those centers where there are more than 120 cases a year. It is not the same treating calciform stone vis-a-vis one that you might treat with mini-perk. What does evidence tell us? Mini PCNL was comparable to standard PCNL in the treatment of staghorn stones. Advantages including shorter hospitalization, among others. The stone-free rates are similar, and the transfusion hospitalization rates are lower. Nonetheless, when you analyze a breakdown of data, we realize that at least in this study, patients that underwent standard surgery had more assessed and greater risk of complication, and they were more obese elderly patients. We have seen that age and obesity are risk factors, so it was expectable for conventional percutaneous surgery to behave worse than percutaneous surgery because they are more complex patients with a more complex treatment. This other paper looks into mini percutaneous versus standard. Mini percutaneous is the winner in all risks, hospitalization, infection, and the like. But once again, when you look at hard data, after 2 sessions, conventional percutaneous surgery has a better stone-free rate. When the stone is more than 2 centimeters large, the stone-free rate is better. And when there is more than 1 stone, also the stone-free rate is better. So they are comparable in smaller than in larger calculation approaches. What do meta-analyses tell us? We are going to discuss a couple only here. This is a large one, choosing 20 papers that met the criteria for this meta-analysis. We see in favor of conventional percutaneous and mini percutaneous, prospective randomized and randomized trials. Values were similar. Surgery time, conventional surgery is shorter in terms of the time required. Hospitalization period is shorter in percutaneous surgery vis-a-vis traditional one, and transfusion rate is low in the case of patients who undergo mini-perc. Same thing with fever. Once again, when you look into data in this study, it reaches the same conclusion. It does everything well, but in stones with +2 centimeters, the stone-free rate is better with conventional surgery. This meta-analysis included 7 papers, and here there was percutaneous, mini percutaneous, but broken down into 30 and 24 French. The stone-free rate is similar. The surgical time is shorter in favor of conventional percutaneous surgery, and as regards hospitalization period, the smaller the diameter of the conventional percutaneous surgery, the closer it resembles results for mini percutaneous surgery. Same with transfusion rates in favor of mini percutaneous, but again, when we look at the 24 French endoscope, it is more similar to percutaneous surgery. Same thing with fever. So it appears like conventional percutaneous surgery in stone with a size of more than 2 centimeters will behave better. If you look for younger patients, we will do better off. But also, if we look for a more seasoned surgeon, we will also do better as well. That's it. Thanks very much.
Gracias, José Antonio.
Thanks, José Antonio. Felipe Pochard. He's a urologist from Viña del Mar Naval Hospital, and he was going to tell us about mini-perc. Well, while they prepare the slides, I would like to thank Pablo for the invitation. I will talk about mini-perc for a coralliform lithiasis.
Bueno, ahí está. Bueno, ningún conflicto. Esto es un poco lo que vamos a ver, algunas cosas de introducción. ¿Qué es la mini-perc? Que algo habló el doctor Salvador
By way of
recién.
introduction, what is mini-perc? Mini versus standard. He touched upon it. Mini-perc suction, which changes the story, and some conclusions. This is a classical chart, which we have seen for a long time. If you look at the publication, it's 10 years. But the green line is percutaneous. This has remained stable throughout time. Elsewhere in the world, you see the difference. And Latin America, these are the trends from the Italian hospital. I had not seen the new presentation shared by Christian in the morning, where the percutaneous surgery rate increased. Maybe the pandemic had something to do with it. The yellow line in the chart on the left is the percutaneous surgery that remains stable throughout time. We know that 20 years have elapsed on percutaneous surgery is still playing a role in what we do in our day-to-day activities. Now, what is mini-perc? Salvador presented this. We have a difference between what he shows and I show. Standard to me is everything equal to or larger than 24 French, and it's not me who says this. It is one of the publications that I have made. Mini will be more or less what is between 14 and 20, ultra mini 11 and 13, and micro-perc 4.8. This is an interesting study published several years ago by Meliani, assessing ex vivo and cadaver pig kidneys, the lesion area caused by dilating using different instruments and different diameters. At the bottom in the circle, I have marked the equipment items for mini percutaneous surgery, and the damaged area is far smaller vis-a-vis the damage caused by standard equipment. This is a meta-analysis analyzing the lithiasis of more than 2 centimeters The stone-free rate shows no difference. Surgery time is a little bit longer in the case of mini perk because the channel is smaller. Conventional mini perk with no aspiration or no suction. As to fever, even though it's similar, there appears to be a trend towards patients experiencing fever. That's because of using the nephroscope in the mini perk and the amplat sheath. Drop in hemoglobin is significantly smaller using mini perk, and that you see when you finish a mini perk, you remove the tract, and generally there's just a few drops of blood. Whereas in the conventional surgery, you have to press upon it. Transfusion, a lower rate for percutaneous vis-a-vis mini. Hospitalization time is also lower using mini perk, and that's talking about mini perk, the conventional mini perk. But now that we can use equipment including suction, situation has changed. There is a systematic review published this year which included 24 studies. In their conclusions, they see that the traditional percutaneous standard surgery minimizes bacteremia and sepsis, whereas traditional mini perk might increase intrarenal pressure and bacteremia. And this goes in hand with what the other study said about fever. But if we add aspiration, the infectious complications risk decreases, intrarenal pressure decreases, also fever, the risk of complication, surgery time is reduced, it increases the stone-free rate, and also reduces the need for additional procedures in those patients. They conclude, lastly, that aspiration or suction is a very attractive evolution for PCNL in any stone volume. And since we are talking about Stackhorn stones, I wanted to show this with you. There are different calculations. That's the video. This is a Stackhorn stone, 3,874 cubic millimeters. It qualifies as Stackhorn, but this one too, and it is 48,000 cubic millimeters in each kidney. So I believe that at the end of the day, mini perk with suction is a wonderful tool, but the standard surgery also has a room to play. By way of conclusion, mini perk is as effective as the standard surgery. Mini perk offers a lower complication rate. Mini with suction allows reducing infection rate and increases the indication, and we need to continue performing standard percutaneous surgery. Well, we need to have someone in our ward who may perform the surgery should it be necessary. Thank you.
¿A dónde está Luis Rico? Que quería que me uniera ahí.
And now, where is Luis Rico?
Fernando, ¿nos escuchas en quirófano?
Fernando, can you hear us in the OR? Hi, hello. Can you share what you're doing? Well, can you see the endoscopy well?
¿Sí?
Perfecto.
Bien. Tuvimos que subir un poco.
We had to elevate this part because we have this area which is yellowish and which is easy to approach with a laser. You see that it fragments easily, but we had to increase the fragmentation setting. Now we are in 30 watts because we have this part that is darker and it has been very difficult to treat. It's very shiny. Do you see it's shiny too? We'll try to change that.
Video. Ahí está. Ahí. A ver si es que me da menos brillo ahí. Ahí está un poquito menos brillo. ¿Sí? ¿Se notó? ¿Cambio?
Sí, sí.
Sí. Y esta parte ha sido un poco más dura.
And this part has been a bit harder. You see that I'm working with 30 watts and it doesn't fragment the stone. Only now is it starting, and I wanted to show you something about the super mini perk, and on certain occasions some fragments, a fragment make it close here, and I push this button, which is the aspiration button, and I bring this towards me, and these fragments fall in a sort of basket, and I don't have to use graspers or anything. And these fragments, only the fragments that have the diameter of the cannula, the amplats, can get in it. And eventually, those are the ones that you can aspirate. I don't know whether you have some other talk or doubt. So maybe we can have another talk while I'm finished. Now, Dr. Acuña, and then we'll get back to you, Fernando, later.
Bueno, aprovechar de agradecer nuevamente la invitación.
Well, thanks again for the invitation. It's an honor to be here. Combined kidney surgery, for which patients? There's little evidence. This SIRS was minted in 2008 by Scofone, and it is not very present in the guidelines. Two revisions I think are very interesting. One by the Krakow and Scofone group, it's a narrative article where they mention 14 studies and they conclude that this type of procedure is good for diagnosis and actively to treat lithiasis, and it's for patients with larger volumes and more complex patients. The other systematic review, which was already a meta-analysis by a group from America, they, as a result, they have a better stone-free rates, and they have less complications and less admission time. So the advantages that these two conclude is that retrograde ureteroscopy allows for a diagnosis. It is not necessary to use an access sheath. The endovision for percutaneous access means less X-ray, and it increases the possibility of a puncture. It's easy to have a urethral percutaneous guide. We have a better vision because of antegrade and retrograde irrigation, and in patients in supine, thanks to gravity, dust and fragments come out through the incision, and the final revision of the calyces can help us to move from flexible to percutaneous, and not always will you use laser, and the final revision of the calyces. Therefore, and this is a conclusion by the groups, it's 2.0 percutaneous, it's more modern, updated and versatile, it's very easy to combine. And we could even speak of a 3.0. What are we doing in our group? We decided to make a diagnosis of our last cases, to incorporate more formally a SIRS to improve our rates, and we decided to use a guide. And we had results that we had rate of success with residual lithiasis smaller than 3 millimeters, that is similar to the literature, and this allowed us to increase our score. So what do we think? Something is developing now in our lithiasis group. In a guide score 1, it is not strictly necessary, although the limited evidence tells us that it could improve for all patients, but it's not strictly necessary. in GSS2, you could consider it. I think that the most potent group is group 3 because they have multiple lithiases and they have incomplete staghorn. And group 4 is more complex patient with a high load of lithiases. And you have to decide whether you do a combined from the very beginning or a traditional percutaneous, and we keep the combination for a second look. Thank you.
Muchas gracias, José Ignacio. Invitamos entonces a Esteban Acuña para que nos hable de
Now Esteban Acuña will discuss Super Mini Perc. He is the chief of urology of the Duvalle Hospital.
Muchas gracias. Como presidente de
Thank
la
you. As the president of the endourology branch in Chile, I want to acknowledge and recognize Mariano and Norberto, who are friends, and they have led the way, and I just couldn't but do it, because here I'm speaking about Super Mini Perk and being maybe the pioneer in this part of South America, but that is thanks to someone who's here and who's a professor in laparoscopy and robotic. Dr. Castillo was the one who opened up the road for me in order to get where I want to go, although I spent 1 year traveling to his center and he allowed me to go into the first surgery, robotic surgery in Chile. He allowed me to do a release of a bladder with a robot, and I devoted then to what I know how to do, and those are stones. This is in 2008 when Octavio took me to the course of Lidu, where I spent 2 weeks, one in the course with Pablo Escobar, and then on December the 10th, I was allowed to perform the first puncture, and that, Octavio, thank you very much. And the guidelines, everything has been said. These are percutaneous stone, and this is nephrolithotomy, and I discussed Super Mini. In 2015, Dr. Zeng makes his first publication, and in 14 centers, he can collect 146 patients, and he applies suction in a sheath with a single channel, so where you have suction and the irrigation is performed through the nephroscope. In 2017, he presents the second generation, and this is a reusable device. It has a handheld and a single irrigation channel in the sheath with those holes that you see down there in the bottom. And this is the flow, this is everything that you need. On the right side, you have the first generation device where suction is done through the sheath and irrigation through the nephroscope. And on the left side, which the second generation, both suction and irrigation go through the sheath, generating major flow in the tip. And the key of success for this surgery is...
La siguiente, por favor, que no me pasa. Bueno, el éxito de la cirugía
the
es estar lo
success
más
of the surgery is to be as close as possible to the stone, and you collapse the system in order to suction the whole dust and fragments. This is the equipment. We are going to place this handheld device with the shape of a Y, we connect and we place the nephroscope. There are publications already that show that this suction helps to have a better performance, but not in very large stones. There are multiple analyses that endorse, and in the area that Felipe has already mentioned, this is the evolution in Ovalle with the standard percutaneous 24. Last years we started with the mini, super mini, before we used the mini perk, and the first surgery we performed was last year, where we treated a stone that measured 19 by 13 by, well, I couldn't hear, with a 2,200 volume. And here you see that we are working and we are removing the fragments. I tested multiple settings with I consulted with other colleagues up to how much they get with the aspiration, and I could increase up to 40 or 60 watts without any complication, with irrigation and suction working all the time. This is a presentation I made at the Chilean Congress with the 15 cases of GAY 1 and GAY 2, and the grade A was without residual stone, and B was 1 stone, and C was more than 2. And we see that the volume to be treated went between 820 and 5,500, and the results we got in this case was 80% stone-free, 0 fragment, 3 cases with multiple fragments, and then we did a second look and they all remained stone-free with the complication in GAI 1 and 2. We didn't have any 3 or 4. And the recommendation of Dr. Zeng, and this was in the course, he said that irrigation is set as 200 and 250 milligram, and suction between 150 and 200, and you need more irrigation pressure and so as not to collapse the system. And when I saw this, it was very important for me, and we are negotiating to get this equipment. And Dr. Aiken says that Super Mini is here to change everything. Suction is the future. Thank you very much.
Bueno, Fernando, ¿estás por ahí? ¿Nos escuchas?
Sí, estoy acá. ¿Me escuchas?
Sí, te escuchamos muy bien.
Fernando, are you there? Okay. You can see the endoscopic view. We have our urethral catheter already in place, and I'm going to show you the rest. There's no bleeding. I am removing the device. Many people are scared of performing a surgery with a pump with continuous irrigation. Sometimes we don't know if the pressure is going to be the right one and it will be maintained. And we are having a case study about that topic and we want to publish it. And that is, how do patients do with irrigation and suction? You can see here the equipment in place and measuring the pressure through the urethral catheter. This catheter that you see is connected to a pressure line, and it connects directly to the anesthetic device that measures central venous pressure, but now we do it with our catheter, fixing the height at the kidney. You can see the anesthetic machine or device. There you have central venous pressure. In this case, it's the kidney pressure. Aspiration is given and irrigation is full. And you see that the pressure is 9 millimeters of mercury inside the kidney. So it's absolutely safe If I get close to the catheter, it will probably grow a bit. There you see that the number has grown to 11, and I'm close to the transducer that is sensing the pressure, but it never goes beyond 15 millimeters, which is totally safe. So being afraid of using these devices because of intrarenal pressure are not true. We have been monitoring this for months, and we think that in any miniature percutaneous surgery, nothing happens. And now we are going to leave a ureteral catheter. We don't leave double J in these cases. You're going to see the trajectory. It is hemostatic, no major bleeding, so we can remove the instruments. And I finish now thanking Hospital Alemán and especially Pablo Contreras for his kind invitation, and the Chilean colleagues that represented us admirably. Thank you, Fernando.
Una
¿Desea
consulta
alguna
al panel.
pregunta? Sí.
Sí, al panel y si te quieres sumar también, Fernando. Una
A
consulta.
question to the panel. Do you think, after we have seen everything we've seen today in all the presentations, that operating a staghorn, it calls for a multi-tract?
Yo personalmente pienso que no.
Personally, I think no, but it depends on the staghorn. There are different types of staghorns and different types of anatomies. There are staghorns that don't need a combined, and there are others in which you know that you will need something different. But in general, with a combined, you can do everything.
Yo también estoy de acuerdo que la verdad es que si hemos aprendido algo hoy día, yo
If
creo
we
que
have learned something today is that never is a word that doesn't exist, and there are certain patients that call for it because certain conditions are there. So having a second tract is a very dynamic decision, but we always get a tract, but a miniature tract. We cannot do a standard tract. It will depend on the instrument you have available then. If you have a flexible nephroscope or a Sears, it's difficult, but otherwise, well, a multi-tract is welcome. In China, and I invite you all, this is an extraordinary course in Chile, where in direct surgery, the physician created 5 tracts with a super mini, and there he asked what was the maximum we had done, and everybody, the maximum was 3, and for him it was 15, and it will depend, and he doesn't use flexible, only rigid instruments, so it will depend on the instruments you have. Well, we have a couple of minutes for questions from the floor or comments from the floor, if there are any.
Algo que comentaron bien
Something that you commented is sometimes we are a bit afraid when we start with the super mini perk, the use of pump, because if we think of pressure, etc. And Mexico, it hasn't become popular because certain professor from the north of the country, he had a serious complication because he was using a pump. So have you had any complications that will discourage people that are very experienced with standard tract and now migrating to miniature tracts with suction? And I think that it is different from an MIP with a clear Petra sheath, because these equipments are reusable. And then could you share your experience if you've had any? Well, the same thing happened when they showed me the equipment. I asked what happened. And they said that everything remains the same, the vision, I mean. And with Jose Antonio, we did some work. We took some ex vivo pig kidney, and we placed the super mini perk equipment, and we measured at 200 and 250 the irrigation pressure, and for irrigation 250, and the pressure is stable, just as Fernando showed before, the patient in vivo. And we also assessed what happened with the temperature, because we used 20 or 30 watts and the increase was 2 or 3 degrees. So it's an equipment that is very safe, at least what we studied ex vivo. I'm waiting for the paper to come out because I'm still afraid. I've done 58 super mini, but the ones that are for Staghorn, we do super mini Sears, and it goes very well, but I prefer the system to collapse than to have an overdistension. And in Eurovivo, talking to Dr. Gadi, a trick that he uses is that he starts to reduce or increase suction in the stone catcher, and it has a valve, and when I use it, I don't find it, but that allows to regulate a bit better the suction. Having the pump and changing the setting, you have to play around a bit. But although Dr. Zen describes his recommendations, until the pressure sensor is not included, I prefer things to collapse a bit. I don't know what the complication could have been, but there's a big risk because if air gets in, the patient will have an arrest. So I don't dare use a super mini perk. I think that the indication is similar to a flexible with aspiration sheath. I don't see any big advantage. I continue to use mini perk, but I think that you have to be very careful about who is the one who puts together the system. You should sense before starting. You organize the whole system outside, but then you test the system, and the pump tells you when that it beeps when air starts to pass, and so I ask a change, and I stop and I start again so that no bubble will pass. So thank you, thanks to the whole panel, and we are going to continue now with our program.
Hola, buenas tardes. ¿Cómo andan a todos? Era para
Good
comentarle nomás
afternoon.
que ahí ven un QR.
You see a QR code there. That's the Congress Instagram. That's where we are uploading the pictures taken by the photographer and by you people. You can find yourselves in the pictures and post them.
El doctor Janak Desai tuvo un problema con su visa, con lo
Dr.
cual no
Janak had a problem with his visa, so he won't be able to be in Buenos Aires, but he has just sent his conference. So I would like to invite Esteban Acuña, José Antonio Salvador, and Belén Romero Echeverría, so that they will moderate the talk, the conference he has sent
que nos mandó Janak sobre la cirugía con Trilogy. Si
on
podemos verla, por favor.
surgery using Trilogy.
Dando un paneo de todo lo que tenemos disponible, ¿no?
We have shared a snapshot of everything available. Sheath suction in the morning, the wonderful surgery performed by Fernando. And now a new technology that combines ultrasound and suction plus the pneumatic device. As discussed in the discussion today, percutaneous surgery is still in fashion, so Trilogy is very interesting for large, hard stones. In time, it removes a large volume. So let's go to the next surgery. Tonio, Esteban, or Velo, if you want to interrupt, and we will stop the video as necessary. Les pedimos disculpas, pero el sonido del audio del video es muy bajo y no se puede traducir. Ahora sí. Es un hombre de 60 años.
Mitral valve, so the anesthetist was a little apprehensive and has requested that try and finish it as quickly as possible, and therefore we thought that with the help of trilogy perhaps we'll be able to break the stone very fast and pull it out very fast. Let us see whether we succeed in this endeavor or not. So this is a typical prone position with a pillow underneath the chest and another pillow underneath the pelvis. The abdomen is lying free for abdominal respiratory excursions. This is a line marking the iliac crest. This is the 12th rib, the 11th rib, and there is a very small window through which we should be able to puncture. So this is the spine, and my puncture site is 1 palm and 3 finger breadths away. So somewhere here is where I am going to puncture. Okay, this is my posterior axillary line. I'll put the needle by experience on this line. And this looks okay, it might hit the lower calyx. So I'll ask the assistant to put contrast. Okay. So we will reach the lower calyx. This is where I intend to go. Okay. So I will infiltrate a little bit of local anesthesia. This is more for tamponading and a small incision. Of course, this is not over pushing and creating a counter, because the key to the game is a proper dilation, a proper entry, which all the endourologists are aware of. For any good PCNL, the foundation is a good dilation, a good puncture, and a good tract formation. So as you can see that we have now finished the 14 French dilation, and which is the end of the Teflon dilation. Now I put the guide rod with the initial 2 dilators already in position, because they are lesser than 14 French, so it will go very smoothly inside without any pushing. And this is the 3rd telescopic dilator. And now the 4th telescopic metal dilator, the Alken's dilator as they are called. And the 5th one, followed by the 6th one. You can see how quickly you can finish this dilation. So people do balloon dilation, which is of course not a bad idea, but the argument that this takes a lot of time does not stand true, because you can see that the entire dilation process gets over in less than 2 minutes. Actually it's 40 seconds. So we have gone for the full dilation, followed by the M-plugs dilator. Since this is a big stone, we are doing a standard dilation. Standard dilation of this kind is more or less become redundant, because we don't need it. Very rarely we have patients coming in with this kind of a full staghorn stone. You can see that there is contrast trickling by the side, which means this M-plugs is very much in position. Going through the main bulk of the stone and trying to take away the lower part of the stone so that there is a little bit of stone mobility.
Sí, páralo un poquito. Aprovechando ahí algunos tips que estaba mostrando el doctor Desailly, ¿quiénes usan contraste con algún colorante para poder hacer la punción y saber que estamos sacando orina cuando hace el trayecto? ¿Sí? Sí. Sí, pero es bueno sobre todo en el comienzo, pensando, porque ustedes son expertos, yo todavía no.
You are experts, I am not. The other person was speaking of mine. He was asking about the use of dye. It's an aid, and you see well when you are or are not, when you perform multiple functions, and there's a little bleeding, and you say, this is blood, urine. If it's blue, you are in the right place. Another thing, I thought that dilation was very easy. I had never seen something so simple as smooth. He must have good muscles. Do you use Alchem, balloon? What are you using? We apologize, but the comments are being made off mic. When I do not use Supermini, I use Alchem, and it's good to have it handy. Any question or comment? Taking advantage of the experts present. No, let's go on to the video then.
Felipe Puchac, ¿nos podrías decir trucos del trilogy, ya que tú lo tuviste en prueba, hiciste alguna truco del trilogy, ya que tú estuviste
since you participated in a very good study, we changed the way of holding the equipment. Do you have any tips? Can you share that, please? We were fortunate to use this equipment item in several cases. It's good, fast, efficient. There are some buts or downsides. The main one, or one of the main ones, being that it's a bit expensive, but other than that, the weight, I mean, it's a bit heavy, robust. So if you're working the prone position, those who criticize the who perform percutaneous surgery in prone position, the deltoid would be raised. They said they got tired. I do it in supine position with the arm at 90 degrees. It's not uncomfortable. And this is what we wanted to study with Jose Antonio. We measured through electromyography how the different muscle groups were activated with trilogy and also with the ordinary electroclast and prone and supine position. And there weren't major differences, to our surprise, I would say. That's one of the major criticisms raised. Yet another problem I had using it is that sometimes the equipment gets clogged. There is a rod at the end to unclog it or unblock it, but it's a waste of time. You get upset. Other than that, it works well. And also, you have to be careful with the rod because the equipment is heavy, and the distance between the rotoscope and this handpiece, the rod can get heated and break. Please use the mic.
Sorry.
The master got overheated and ended up breaking. Does it happen with this one as well? It is not frequent, but it did happen sometimes. So we try to ensure the assistant would be ensuring that we had everything in line. If there was too much heat, we stopped trying to have it cool down. This is a problem with it. The company says that the rod was too long. If the rod were shorter, it would not vibrate that much and heating would not take place. But it happened a couple of times to us. And the rod is expensive. In your experience, Tonio, with the use of lasers, I don't know if you are using lighter class for some specific cases in point. It is a politically incorrect question. Reality is today using thinner tracks. We do not resort to pneumatic lighter-clad master. This equipment item offers thinner rods as well. We do not have trilogy at the hospital. We have lighter-class master, but given the trend to reduce tracks, you move to the use of laser vis-a-vis the pneumatic system. That's the reality today. In relation to the rod, a couple of months ago, we started using trilogy, and the new trilogy, as you perform a deflection, there is a kind of traffic light. A light turns on, there must be someone watching it, of course. It turns red when the deflection is too big. And as to the technique, if you're going to start using it, it is important that, as you saw in the video, you have to hit on the stone. You have the idea of laser. You paint, no, and this is different. Support is very important. It's very similar to the Olympus's shock pulse. You have to hit the stone, fragment it, and suction it. Apologies, Luis. Did you have the opportunity of using the thinner rod, the super mini perk? For the mini, yes. The advantage or the great advantage offered is not reflected in the mini. It will take longer, but it's valid. You can use it. Against it, I may say that the mini perk rods are single use, whereas in the case of the standard one, you can use it 5 times. They are chipped. You can use it. Once you place it, it's 3 hours. It's complex because how can you have 2 surgeries in 2 hours? Even if you are the best surgeon ever, changing operating rooms make it impossible. That is a fact. But the standard one lasts 5 times. And as to suction, did you see any changes? Well, you will mark that. You have to start playing around with settings. We started with 100%, then we dropped to 80%. It will depend on the lithiasis. Helgar? I had experience with shock pulse, and something that I have just seen in the video is that coating is dropped and it's left inside the cavity. The metal portion is left. I don't know if it struck you, if you have used Trilogy regularly, whether that metal coating or that metal thing will bring about subsequent issues. I don't know. This did not happen to me when I used it. I used it in 2 sets, 10 cases each. And for the first one, I used Trilogy in the gun approach after the session, measuring muscle activation using the gun in the opposite position, in supine position, is far better now. The handle is far more robust, similar to 3-pulse, and it is indeed not very comfortable. You cannot use it. But I've had the misfortune of breaking one rod with a mini perk, and they were all happy because it was the boss who did. They were scared that they would. These traffic lights, I mean, the green line shows you whether you are exerting too much torque. Any other doubt, question? Are we done, Pablo? Well, thanks very much then.
tenido un almuerzo copioso, así que vamos a
We
tomar
had a
15 minutos,
hearty
un café bien
lunch.
cortito
We're
y
going to
volvemos
have a
con
short coffee break and we come back for the rest of the afternoon. We're going to resume. We're going to invite Norberto Bernardo, head of the urology ward at the Clínicas Hospital, to speak about complications in percutaneous surgery. Thanks, Norberto. And also the moderators, Dr. Lorena Valderramos, Josefina Bertanacian, Mayra Bedoya, and Alexandra. Welcome. How are you? Thanks.
¿Estamos?
Are we done?
Bien. Buenas
Okay.
tardes a aquellos
Good afternoon to those I haven't said hi yet. We are going to talk about something we never want to speak of, but which we need to, which is complications. So I have no disclaimers in a technique that has been in place for over 50 years now, and where when created, there was nothing more than open surgery. Now we speak of a number of alternatives to percutaneous surgery, but the truth is that back then there wasn't much more than this, and nonetheless, it's not dead, it's still alive, but with its complications. The concept is we have to enter through the skin, preferably a single path, and remove everything inside, trying to comply with the three-sided objective. Leave the patient stone-free with no complications and in a single approach. So we try to draw a plan as if we were explorers, and even so, with every plan in place, we need to know that there will be complications that may be grouped into these. You can see here the most feared: septicemia, bleeding, puncture of any of the nearby anatomic structures, hypothermia, and the development of a fistula. When it comes to avoiding, preventing urosepsis, some data to take into account is that incidence of septicemia is relatively low. The problem does not lie in the low incidence, but in the mortality rate, which is very high. So it's not that frequent, but when it does take place, we have the worst situation ever. And the idea is to bear in mind some of the features that might have a say in us, in our lives being easier. What is the incidence of urinary tract infections in percutaneous surgery? The literature reports and underreports 16% from the CROES study, and of all the patients on which we perform percutaneous surgery, 1 out of 10 develop a feverish condition. And who are the most prone to having some of these complications? Women are more prone than men, having a positive culture beforehand. That is, in the past 6 months, the culture values were positive over the past 6 months. More than one kidney puncture when necessary can be performed, but we know that septic complications increase, and estruvite stones, we know there is a germ there, and even if the culture shows negative values, that's estruvite, and the biofilm cannot be sterilized, even if we use the best of antibiotics at hand. And the idea is not to develop resistance to something we're not going to cure. We're going to bring it under control, but not cure.
Of the patients, 1 out of 10 who have a fever, 8% do it in the context of a pre-op negative culture, and 18% with a history of a positive culture. And this complication, which is fever, happens in the first 24 hours in about 40% of the patients. Then come the rest, where the rest of events start to appear, infectious events. What are the germs? Either we put it inside the organism or they were around the stone. And considering if they were in the biofilm that covers the stones that we are treating, what we have to consider is that if we move those germs, some mechanisms have to be borne in mind whereby those germs can get into the bloodstream and then can have a systemic impact. One is the pyelovenous reflux, the other is pyelolymphatic reflux, and the pyelotubular reflux. But there has to be pressure for there to be a reflux. There is a gradient of pressure higher in one place than the other and favors this to move into the bloodstream. So when establishing the pressure, generally we speak of millimeters of mercury when we take the arterial pressure, but it's not the same to speak of millimeters of mercury than 2 centimeters of water, which gives us the idea of where we have to place the irrigation bags when we are trying to perform an endoluminal procedure. So we know that in terms of water pressure, we assume that inside the system, what is normal are the pressures between 12 and 15, and everything that is above 20 is considered increased. And when you go beyond 40, if we had a measure for pressure, there is no doubt that this reflow is happening. Over 40 centimeters of water, some sort of reflow is happening, and this favors infectious complications. When being less aggressive, for some time we reduced the diameters because clearly, as was shown in previous talks, the diameter of what we introduce in the kidney is related to the level of bleeding. However, to the extent that we reduce the diameter, if we do what we have always done, which is just to reduce the diameter, we probably increase the pressure in that closed system in which we are working. And when we speak of infectious complications, recently in vivo and in all the talks, a number of notions were given that changed the history as was presented here. Esteban spoke of how percutaneous procedures changed. So to do something different, I irrigate on one place and I suction in the other. So it's not the same channel where the pressure goes in. So the hydraulic system was the same, but the hydraulic of the fluids changed, and that is why we can measure pressure, irrigation pressure, and negative pressure of suction so that the system won't collapse and the pressure will be low, acting faster. The fact that we have a sheath as shown, an irrigation sheath and suction sheath, causes the pressure to be always below 30 millimeters of mercury, and that because of that procedures are faster. The possibility of having infectious complications is lowered. It's a predicting element, this reduction. And when I told you that we've been doing the same but smaller, that is to reduce what has allowed to compare that the active suction has less infectious complications and less operating time. Now, when we have to go with the worst, in the worst situation, sometimes we have a series of indirect signs that indicate that it's septicemia, not only hyperthermia, but hypothermia, not only tachycardia. There is a number of parameters that we have to consider which indicate indirectly that the faster we find them, the lower will mortality be, which ranges between 66 and 80% of the cases. I'm not saying fever, I'm saying septicemia, a fever in the ICU. That is the patient that we have to go out and tell the family there is a risk for this patient to die. A patient that goes to the ICU because of infectious problems, we have to tell the family, because if we tell them, this allows us to prevent medical problems and legal, that is, if the patient dies, and then the legal problems that ensue. So what are the things we have to look for? If there has been a positive pre-op urine culture, if we had a positive intra-op or urine culture, the size of the stone, because the larger, the more probability of infectious, neurogenic bladders, we know that is risk factors, and if we have some changes in the renal anatomy, a poorly rotated kidney, for instance, then the complications are higher. And what depends on us, intra-op factors, are the pressure that we decide to have and the time that we decide to devote to the surgery. So, considering that a negative culture doesn't tell us too much, or that the positive culture, urine culture, doesn't predict the germ that the biofilm could have of that stone, what we need to rescue is the importance of having a culture of the stone. You can do many times a culture of the stone and there are no complications. But if you didn't ask for it and the patient is in the ICU because of an infectious complications, you will feel much better if you did get the culture of the stone. Now, when we have to perform a percutaneous procedure and we place the needle and pus comes out, we should drain the system, interrupt the procedure here, and come back at some other time. This is what the guidelines say, Europeans and American guidelines. We have to place a drainage, stop, take a culture, and then give the patient the treatment and then come back. However, the literature, anecdotally, has shown that when you compare in patients that pus comes out and you have to decide whether to follow, to continue, or to stop according to what the guidelines say, what calls our attention is that the complications were more when the procedure was done sequentially rather than if you continued at the time pus came out. This is anecdotal, but it is supported by the fact that at least one should consider this, considering also that there are very few papers in the literature. And so, although there is no evidence that at this now appears in the guidelines, there are special considerations about infectious complications. It has been said that there should be a 1 diameter difference between the internal diameter of the sheath and the nephroscope of at least 4 French. It's rather an idea than something that has been documented in the literature, but at least for some time this has been repeated over and over. And what common sense tells us is that when urine is infected, the idea is to work as shortly as possible and removing all the fragments if possible. And I say this because in these infectious stone, like the one you see here, if we place a needle and pus comes out, we are going to place the nephrostomy in one calyx, and that doesn't drain the system. So we should destructure the stone so that the urine that is trapped there will drain, and then we'll come back, but not leave a nephrostomy and the other calyces there obstructed. So if in 15 minutes you can take as much as possible from that stone, the problem is to leave a kidney with pus in all calyces unobstructed. In that case, one could consider to move forward with the procedure as fast as possible. It would be concerning to leave residual lithiasis, would it? Well, no, if the drainage has been enough and efficient in order to maintain an infected system at very low pressure. If you campaign mini percutaneous, not super mini, but mini percutaneous, it is clear that the standard has less infectious You are compare big and small, and that's it, not different hydraulic systems. So we should rule out infection before touching a patient and start with antibiotics if the culture is positive. Do prophylaxis always. If the urine has pus, stop and work at very low pressure. Among the other infectious complications are bleeding, and bleeding means that we did something bad. If we get into the center of the papilla, there is no risk. Otherwise, all those who started with percutaneous surgery 50 years ago would all be in prison. So we should highlight the importance that the needle, with whatever diameter you choose, goes into the center of the papilla. There are more risk of complications in the upper calyx than in the intermediate and the lower. If we do something wrong, if we go to the upper calyx, the consequences are more severe. This is something we should remember. If there is bleeding in the short-term post-op, what we need is to reposition the sheath. We have to prevent an excessive angulation that could break the kidney. A coagulopathy should be corrected in order not to have an acute complication, and if the bleeding is deferred, which happens in 1% of the cases, that's the patient who comes 1 week later with a retention of urine, with clots, then that patient has to be assessed, and arterial and venous blood are associated, so interventionist cardiologists have to see that patient. Acute bleeding, if it is slow, with just removing the sheath and compressing is enough, but if it is sudden and arterial, then we should try and stop the bleeding, and then we should call interventionist cardiologists. They could solve this and do compression. If the bleeding is deferred, angiography, hemodynamic support, and transfusion. We should remember that sometimes nephrostomy can interfere in the visualization of a fistula, arteriovenous fistula, and the interventionist cardiologist will help us. And when embolizing, don't do it with spongostan. If you're in a public hospital and they say that they only have spongostan, but probably half the patients will bleed again. The best thing is to have coils to embolize if necessary.
¿Me pasarías la siguiente? Fíjate si me avanzás la siguiente, por favor. Bien, con respecto a toda la información
to all the information that avoids headaches, the computed tomography is absolutely necessary because there are things that are seen in the CT, and sometimes the ultrasound doesn't provide that information to prevent the needle from going to the wrong place. And when trying to avoid touching neighbor organs, it's something that before is said by the CT, and the ultrasound tells us intra-op where we are. So we need to have an ultrasound to tell us that we shouldn't go this way. This allows us to see if there are neighboring organs or big vessels that should be avoided, and this results in a reduction in bleeding. And even so, if feces come out through the orifice or through the place where we left the nephrostomy, we are in trouble. We have to define whether it is extra or intraperitoneal. If it is extraperitoneal, we can do certain things, like in this case, where there is a perforation in the colon in one of the posterior aspects, and after getting into the lumen of the colon, we get into the kidney. First, we have to separate both cavities, a double J for endoluminal, and remove the nephrostomy, praying until it is placed in the center of the lumen, as happened here. And after 7 days and lots of praying, you remove the nephrostomy, just because if it was extraperitoneal. But if it's intraperitoneal, laparoscopic or open surgery, without any doubt. The supracostal approach is, if it is necessary, if you want to go above the 10th rib in 100% of the cases, you will go through the pleura. That's sure. We generally don't do that, but we know that that's going to happen. Above 12, we are going to touch more, to violate more. 15% on the left side and 12% on the right side. And if we go above the 12, well, we will also have complications. We will have hydrothorax, pneumothorax, hemothorax, and there we will require our friends to help us. And for irrigation, be careful with the temperature. About 1.5 liter of blood goes through the kidneys per minute. If the temperature is 10 degrees, then the temperature will go down. If the patient is elderly, they will die. If the patient is young, no. And if there is a perforation, just place a nephrostomy and that's it. And then let's come back later because there will be no complication because that has already closed. And the idea is that if we have doubts and we couldn't explore about a stone that may have migrated to the ureter and which can cause a fistula, let's place a double J, and that will help us maintain low pressure so that we don't have a later fistula.
La pila o estoy enfocando mal. Pásame la siguiente.
Something is going wrong. Now, speaking of all the complications, the idea is not to create fright, but just know what complications can appear. Complication means that something we did was wrong, but we have to try and do it as few times as possible. This is a safe procedure, especially if you work in a team, and I can guarantee that the shark will not eat us up if we all work together, so that none of these complications will lead to a high-risk medical and legal situation. The idea is to prevent the risk. Let's work in a team. And again, Pablo, I wish to congratulate you on your achievement and for honoring me with my participation here with you. Thank you. Thanks. I have a question. Do you consider that the fact of having smaller tracts has changed the rate of embolizations? The literature says that it decreases the complication of bleeding. There have been less embolizations, that is documented. It is so. And I thank you for your question because I go against the current like a salmon. We don't highlight enough the importance of getting into the center of the papilla. When we get into it correctly, bleedings don't happen. But when we get in the wrong place, if I get in with a smaller thing, the bleeding will be less. But when this started 50 years ago, it started with 50 French, and they wouldn't end up in prison because they highlighted the fact that they had to get to the center of the papilla. Now they go with a mini perk, and if they don't see bleeding if they get to the center of the papilla. But I know very few who, when they place the needle and urine comes out, they take it out and then they go in again. And so let's leave it like that. And that is the onset of complications. Thank you. Any advice for us? Because we are now fellows, the four of us. Yes, definitely. And like the salmon, I swim against the current. This percutaneous surgery is alive and kicking. So sorry, but don't get misled. Maybe they won't invite me anymore. Don't get misled by the industry. They have the flexible procedures are very profitable. And we thank the industry because they help us. But when I said today, the best is yet to come, it has to do with the industry that hears what we say, but it's easier to do flexible percutaneous procedures. You'll need it. Less, of course, but you'll need it. So someone who likes to work with stones has to have all the resources available, even knowing that you're going to use it less. But I cannot become a leader with a monotherapy. Sorry, I cannot do that. There are more prestigious people speaking of this, but monotherapy, no. It's a matter of intellectual honesty. I can say that someone else does it, but I cannot say that it's the only thing that I have to offer. So learn percutaneous surgery. Something calls my attention when you said that if we get in and pus comes out and we can decontract the calyx, we do it, but we are new and maybe we don't have the experience you have. So do you consider some time as a minimum period or not go beyond that? Well, those are two different questions. If the question is if pus comes out and the system is drained enough through the needle, place a nephrostomy and come back another day. But in terms of time, time is one factor, pressure is another factor. So I think that what was presented of super mini perk, that's the notion, less time, less pressure. And I wouldn't go beyond 1 hour, but not with a kidney that is filled with pus, a kidney that has a history of positive culture. The biofilm is there, even if I don't see any pus, because complications are there. And when they are there, patients die from sepsis. I have a question. If you have a negative urine culture, an obstructive stone, do you take any precaution and you give an antibiotic? If it's negative, we do the usual prophylaxis. However, what I wonder is, in the last 6 months, could there have been an infection in this patient? If the culture is negative, but there was an infection in the previous 6 months, I take that patient as if pus had come out when I puncture, because it's risk. And so you give them, if the culture is positive, what the guidelines say is that the patient has received 7 days of antibiotics. This is changing now. The international guidelines of urolithiasis said 7 days, but they are being updated. So that patient has to receive antibiotics for 7 days and then move on. But with the culture is negative and there is a history of infection, you have to look at the patient differently, not only negative culture. Patients who are embolized, for instance, with coils, as you mentioned, if the patient had a lithiasis in the future, the coils make the puncture more difficult, or it doesn't make any difference? The idea is not to puncture when the coil is visible. I mean, the coil is visible with a C-arc, so you shouldn't puncture in that place. And the other thing is that the coil became a stone. We have treated stones endoluminally that it was actually a coil that went into the ureter, and be careful with touching that because we broke it and then the coil metal appeared, and you can end and maybe your eyes can get filled with blood because it opened up. So you have to tell everybody before if you are seeing a stone in the place that has to do with embolization. In your experience, is there any specific management in patients who had sepsis after the procedure, especially those with recurrent urinary infections? If there has been a sepsis, well, if there has been a sepsis, I ask for help. This is a management that requires more people on the boat. We can follow the guides, but this is a potentially unstable patient. The best thing the patient can have is ICU. because the patient is unstable. The patient is not a patient that you can take to the ward and who had 37 or 38. The patient has other parameters that tell you that there's a septicemia somewhere. So that goes beyond our possibilities. So we indicate antibiotics, etc. But we need someone else on the boat, because if it ends well, you are the genius. But if you did not call anybody and things went wrong, you have no defense. Dr. Bernardo, with respect to culturing the stone, when do you do it? Is it in the short-term post-op, or do you do it with all the patients? We try to do it always as soon as we have a small fragment, we send it to culture and we continue. Not at the end, not at the end. The first fragment that I can grasp, that goes to culture, and we also analyze, but the physical and chemical analysis or test is not so interesting. But we need to culture the superficial area. So if you broke a staghorn and you send something from the center, that's not good. You have to send something from the outer surface, because that's where the film is.
Bueno, muchas gracias, Norberto. La verdad que muchas preguntas, así que muy bueno.
Very much, Norberto. Many questions. Let's move on with the next speaker, who will talk about mitigating colics because of a stent placement. The moderators will be Manuel Martínez Pagano, Javier, our resident, and Vicky.
Muchas gracias a Pablo y Luis para la invitación.
Thanks, Pablo and Luis, for inviting me to this excellent Congress. Apologies because my Spanish is not good enough to deliver the talk, so we'll have to shift to English, and I will be back in Buenos Aires soon to practice my Spanish.
Okay, so today we're going to talk about ways to mitigate or lessen stent colic. We're going to understand when stents can be safely avoided, and we're going to talk about some of the pharmacological interventions. So why do we place a stent after ureteroscopy? Well, one idea is to maybe reduce the incidence of ureteral strictures, although that's probably not necessarily borne out by the literature. We want to reduce renal colic, although stents do create colic, and maybe we're going to allow for small fragments to pass from ureteral edema. There's also a secondary benefit to stents, at least in the United States and some other countries. Certainly it's easier to remove a stent than to place a stent emergently, but there's also a financial benefit. If you take a stent on a string out, you can bill for an office visit. If you do a cystoscopy, that's $368 in the United States. But there are a lot of problems with stents: incrustation, biofilm, infection, pain, lower urinary tract symptoms, reflux, migration, and of course the forgotten stent, which comes back 2, 3, or 5 years later. Patients are informed about stents, but they don't always get it. If they go online, we did a study and we found that a lot of the information on websites is not very good. We looked at 100 websites talking about stent complications. More than 75% of the websites had the information at a reading level above 6th grade. The average was 9th to 11th grade, and so patients may not understand what they're reading. And the mean score for stent information was 14 out of a possible 24. So the information wasn't always necessarily good. There were a lot of omissions. 3 good sites were a site from the National Health Service in the United Kingdom, mykidneystone.com, and also Wikipedia. So why do stents cause symptoms? It's estimated that about 80% of patients are going to have symptoms after a stent. Maybe because the stent is too hard, maybe because of the size of the stent. The distal portion of the stent causes more irritation because of receptors in the bladder. People have tried drug-eluting stents with a variety of different chemicals. So far, none of these have shown any significant benefit in trials. Dissolving stents.
There have been several preclinical studies. I did a study in pigs about 20 years ago, and only about half of the stents actually dissolved completely. In the studies, most stents lasted between 2 weeks and 2 months. One study showed that all 10 stents in a pig dissolved, but we really haven't seen these commercially. So when can you avoid a stent? Well, the best way to avoid a stent is to not place a stent. So when can you do that? Stent omission is associated with a decreased risk of pain, but an increased risk of unplanned visits, either to the office or to the emergency room, and certainly more calls. So when can you go stentless? Well, you don't need to place a stent for most shockwave lithotripsies, certainly less than 1.5 centimeters. You do not routinely need to place a stent prior to ureteroscopy. The American Urological Association guidelines recommend against routine pre-stenting. You don't need to place a stent if you do a routine ureteroscopy and there's no injury, if there's no stricture and there's normal anatomy, if they have a contralateral normal kidney and normal renal function, and if the patient has been pre-stented. Even if you use an access sheath, in most cases, you don't need to put a stent in after that procedure. So if a stent is placed, the length of the stent doesn't seem to matter. The stent material might matter. There's some evidence that Polaris stents, tail loop stents, and silicone stents are associated with less pain than the standard stents. Preoperatively, you can use a belladonna and opioid suppository. There's some improvement in quality of life. Unfortunately, this product has not been available in the United States for many, many years due to a manufacturing problem. What about intraoperatively? So there is no benefit for giving intravesical or intraureteral injections of lidocaine, oxybutynin, or ketorolac. There was a slight benefit for injecting Botox into the ureter, but this is very expensive and of limited benefit. What about stent diameter? Does size matter? Well, in this case, it actually does. One meta-analysis showed that there were fewer urinary symptoms and less pain with smaller stents, 4.7 to 5 French compared to 6 French, but there was a higher risk of stent migration. Another study compared 4.7 versus 6 versus 7 French. The smaller stents had less pain, less activity restriction, less incontinence, and they were back to work faster. Interestingly, the larger stents had fewer outpatient and fewer emergency room visits. The authors were not able to provide an adequate explanation for why this might be. Opioids for ureteroscopy. So we have found opioids to be very dangerous. It is estimated that approximately 6% of all patients who undergo any surgical procedure are at risk for becoming dependent on opioids. And in one study, at least, this was found to be the same for opioid-naive patients who underwent ureteroscopy. About 6% of them were requiring prescriptions for opioids or asking for prescriptions more than 90 days after surgery. The likelihood of continued opioid use is increased with the amount of opioids that are given after the procedure. So if you give someone 20 pills, it's more likely that they're going to ask for more pills as compared to if you give them 0 pills or only 3 or 4 pills. So what about NSAIDs? NSAIDs, I think, are the mainstay of postoperative pain management. They provide prostaglandin inhibition, which relaxes smooth muscle. So not only do you get pain relief, but it's a weak muscle relaxant. They can be associated with gastric bleeding, with platelet dysfunction, and worsening renal function with chronic use. But there is no significant risk of postoperative bleeding with a single dose, so they are perfectly fine for patients who have had ureteroscopy or percutaneous nephrothotomy. What are the contraindications? Allergy or previous adverse events with NSAIDs, asthma, pregnancy, active peptic ulcer disease, or renal insufficiency with a GFR less than about 30. An interesting trial was a randomized study looking at Toradol to reduce ureteroscopy symptoms called the TRUST trial. 30 milligrams of ketorolac was given upon induction of anesthesia. You could reduce the dose to 15 milligrams for older patients or patients who are under 50 kilograms, and 80% of these patients had a stent postoperatively. Now, the interesting thing in the study was while there was a decrease in the amount of narcotics that was required by the patients, this was all intraoperatively. Postoperatively, patients required a low amount, but the same amount of narcotics. But 17% of the control patients required a Toradol dose, rescue dose in the PACU. I think the most interesting thing about this study was that these patients were all sent home with no narcotics. Only 3% of the patients ended up calling or going to the emergency room requiring additional pain medication. So this tells us, and other studies have shown similar, somewhere around 3 to 7% of patients actually need narcotics after ureteroscopy, but more than 90% of patients do not. I don't send patients home with narcotics unless they are previously on narcotics for other reasons. So what can we give patients postoperatively? NSAIDs and opioids, while they may help with pain, they don't help with voiding symptoms. Alpha blockers are the mainstay to reduce pain and to reduce some of the voiding symptoms. Silodosin seems to be better than tamsulosin, which seems to be better than alfuzosin. And this is due to receptors present in the distal ureter and on the trigone. They also dilate the ureteral lumen, which reduces ureteral spasm and reduces peristalsis. Anticholinergics, in several trials, solifenacin seems to be the best among the anticholinergics. It reduces urgency, frequency, it reduces pain, and it reduces hematuria. No effect on frequency. The combination of an alpha blocker and an anticholinergic seems to be superior to either one alone, reduction of pain and reduction of lower urinary tract symptoms. Interestingly, in a randomized controlled trial comparing phenazopyridine or pyridium versus oxybutynin versus placebo, there was no difference in voiding symptoms, suggesting that in isolation these medications don't help, but maybe added to other medications they might be of small benefit. This was an interesting study. It was a meta-analysis of 26 randomized controlled trials looking at stent symptoms, and they did Markov modeling, 100,000 Monte Carlo simulations, and what they came up with was the combination of silodosin 8 milligrams plus solifenacin 10 milligrams was superior and better than any other combination or either one alone for reducing pain and lower urinary tract symptoms. The addition of tadalafil increased general health scores, and a lot of this was due to improving erectile dysfunction in men. I don't know any men who are having sex with a stent in place, but if they wanted to, you could give them some tadalafil. So how long should a stent remain? Well, if you don't put a stent in, there's no stent symptoms, but you can still have increased risk of unplanned visits. One study looked at placing a ureteral catheter for 6 hours and removing it, and they had a higher incidence of having to replace the stent urgently. One study looked at placing an access sheath and then removing the stent after 1 day. About half of the patients still had hydronephrosis on day 3 and 6% at 2 weeks. This is not something I recommend. 3 to 7 days seems to be standard. If you place a stent for less than 2 weeks, you have still a lower risk of infection. Stents placed for more than 4 weeks, you have an increased risk of colonization and infection. If you're going to stent someone because of a colic or because of an infected stone and then taking them back to the operating room, you should ideally do it in less than 4 weeks, less than 2 weeks if you can, but ideally less than 4 weeks. Or if you're going to do a second look after a first look, ideally within 2 weeks, but certainly less than 4 weeks because that will significantly decrease your chances of infection and sepsis. Stent removal, so some studies have showed that giving an NSAID at the time of stent removal, an injection of Toradol is ideal, can reduce post-stent removal symptoms. Whether we should use a string or cystoscopic extraction. The string is associated with more accidental dislodgement, but it is less pain and patients tend to favor it. In my experience, almost 20 years, I've had 3 patients who pulled their stents out by accident. They were all in women, and I had 2 patients who somehow we put a string on, and when they came to the office, there was no string, but the stent was still there, also in women. So I don't know how that happened, but it's a very, very low risk over my experience of 20 years. Most of my patients get a stent in a string. In the handful of patients that I don't put a stent in a string, I've had 2 patients who had migration. I had to take them to the operating room and do a ureteroscopy. So overall, either way you do it, not a big deal. Patients tend to prefer the string, especially in men. What about a stent with a magnet? So this was a trial from 2017. It was a double pigtail stent that has a magnet in place, 40 patients in each group. Patients tolerated the magnets quite well. They were retrieved successfully, I think it was 95% of the time, reduced cost and discomfort. There was another trial done about a year ago, also similar findings, but this has not become widely available. Ureteral edema seems to resolve in about 4 days in a pig study. Some studies in humans have showed that stent symptoms with the stent still in place seem to resolve by about 6, 7, 8 days, and so we suspect that that's when the edema significantly resolves. So my personal preference is I remove stents after about 3 or 4 days, but if there's a fair amount of edema, I'll leave it in for about a week. The suture stent is a new concept. It's a stent that goes about halfway down the ureter, and a double arm suture goes down through the ureterovesical junction. It is associated with less urinary symptoms after ureteroscopy. It's only been used in a few trials, so time will tell whether this is something valuable. Post-op instructions, I think, are very important, and there are a number of sources. These all are in Spanish and are freely available online. Stent tracking is important. You don't want to leave a stent in place, and there are several apps that are available for tracking your stents. So this is what I do. I think it's important to set expectations during the clinic visit when you're explaining the surgery, in the preoperative holding area before surgery, after surgery. I tell the patient, I tell the family. I start silodosin about a week ahead of time because it relaxes the ureter and makes it easier to get your scope up. I give everyone Toradol, 15 milligrams intraoperatively. They can get another 15 milligram dose in the PACU if they need it. They all go home with Tylenol, and they're also given Tylenol, and we also give them sometimes Valium if they're having a lot of stent symptoms. They're discharged on tamsulosin or silodosin plus diclofenac. That's my NSAID of choice. And in addition, some patients will get a dose, a week's worth of solifenacin and possibly even phenazopyridine. No stones equals no stents. This is also a freely available dietary guideline from the American Urological Association that you can download and give to all your patients. This is what I do. It helps them with making good choices in food. There's recipes in there as well as didactic components about how to prevent stones. I thank you for your attention.
Well, thanks very much for your talk. Very clear, highly enlightening. I wanted to ask you a question. You put forward the possibility in those cases where there is post-op edema, the importance of having a stent in those cases in order not to place one as a matter of urgency. Do you ever consider the possibility of depositing steroids or some kind of mechanism before placing the stent, or is the indication always for a stent?
I have not used steroids prophylactically, but in several patients I've had where I've taken the stent out and they're still having pain afterwards. Maybe it's a week or several days after the stent has been removed. If they're still having pain, I will give them a short course of methylprednisolone for a couple of days, and so far I've not had to replace a stent in any of those patients. It's only a handful of patients, but the course of steroids seems to work quite well in those patients.
Bueno, antes que nada, felicitaciones, doctor Borin, por su presentación. También felicitar a Pablo y a Luis y a todo el equipo del Hospital Alemán por la organización y gracias por la oportunidad. Tengo dos preguntas, doctor, si es posible.
Questions, doctor, if possible. First, ask you if, in addition to the pharmacological treatment, you suggest some kind of change in urinary habits that may mitigate symptoms associated to the catheter in terms of hydration, frequency, or the frequency at which they empty the bladder and how. And on the other hand, whether you have any experience regarding the tolerance or response to treatment, poor tolerance of metal catheters for oncology cases or retroperitoneal fibrosis.
Yeah, I don't tend to tell them to do anything different in terms of voiding or drinking more or drinking less. I mean, a little bit more I think is helpful, especially if there's been a little bit of bleeding. I do find that stents are worse tolerated, and this is also in the literature, in young men, and men under 40. Men just can't handle pain like women. And also, when they void with good force, they can get reflux up the stent, and that can be very, very painful. So for a handful of patients who have really significant stent symptoms, particularly with reflux, some of them they can't even leave the recovery room, we'll put a catheter in them, and we'll leave the catheter in usually for about 3 days and then take the stent and the catheter out together. As far as the metal stents, so I was the first person in the United States to place a metal stent about 20 years ago. I have not used it a lot. I have found that they're usually pretty well tolerated, although I've had a couple of patients who I think had an allergy to the stent and we had to take it out. I have not found it to be superior to some of the plastic stents, and they're very expensive. So I've used it but sparingly, but I have not found that it's better or worse than any other stent in terms of symptoms, in my experience.
I would like to commend your excellent presentation. As to metal catheters, how well do you maintain them? And of course, pain is not an issue because in the case of oncology patients who are receiving different types of drugs for pain, we in Ecuador, we don't have metal stents, but in our experience with patients who have placed a stent in the US, it's that drains only because of capillarity. So we have just removed them. So could you say something about that?
Yeah, so I mean, the concept of the metal stent is that it, even if the lumen is, even if the ureter compresses completely, because it's a continuous coil, the urine will drain through it. I have not found, I've placed them and I've left them in for a year or more. Most of the time when I took it out, there was very little incrustation, although I had a couple that did have some incrustation, but not so much that it was difficult to remove. But I've just not seen the need for it. I've had many, many patients that I put a standard 8 French stent in, and I've been able to leave it in for a year. I check them every 3 to 6 months with ultrasounds, and very rarely do I have to change it earlier. So I have, even though I have been placing metal stents for a long, long time, I don't find the need to place them more than maybe once or twice a year. Most of my patients who need long-term stents, I'm using just a standard stent, or a TRIA stent is a very nice one. It's a little bit firmer than a standard stent.
Bueno, doctor Bonin, felicitaciones por su charla, muy claro y todo, pero bueno.
Thanks, doctor, for your talk. Because of the sake of time, we will move on to the next talk. So thanks very much for your presentation.
So James is departing in a few minutes. Thank you very much for coming.
Thank you.
It was a great pleasure. Oh, you have another?
I have another.
Oh, sorry.
No, I'm up here.
Okay, please. Yeah. Perdón. Vamos a entonces a continuar con. Hoy hablamos del DIS.
We'll continue now. Today we spoke of mini standard DIS and fans, but the laser setting is different for these, each of these. So we'll try and make it clear what's the setting for each of them.
Okay, I think so. La gente es mala,
Se puso los lentes nomás, ¿eh? No los quiere usar.
Acá los tengo.
He doesn't want to wear the glasses, but now he has put them on. Luis Rico and Pablo Valladares, Dr. Mariano González, James, Esaid.
Bueno, muy buenas tardes, me está haciendo dar vuelta.
Good afternoon. Pablo, you are having me move around. Well, thank you once again for the invitation, Pablo, Luis, and the whole German hospital, Gonzalo too, who's part of this growth of the course of the Hospital Alemán, German hospital. It's really remarkable. It grows year after year with a quality and a level that are impeccable. And I will discuss one of the new things. Today we spoke about the possibilities of having different energies to treat stones. One of the questions of course, Antonio, was if we have lasers, what happens with pneumatic or ultrasound energy? And I think that we tend to this. When we speak of different lasers, we'll see that there are changes, small changes in the lasers per se. Who of you has a holmium laser, high power, low power? Please raise your hands. 80%. Who has a TFL, thulium fiber, thulium laser fiber? And who has pulsed thulium? I think this is interesting because the original trend, and these are my conflicts of interest specifically regarding endourology, but the original trend of all of us was to learn with holmium laser. All of us started endourology with a holmium laser. The first one that appears in Italian hospital was in 2000. It was coherent, not even lumenis, it was coherent, 100 watts. And this grew and different lasers appeared with different powers. And something interesting that we mentioned today, lasers are more and more powerful. And there are giant lasers for treatments that, as was shown today earlier, the speakers on lithiasis treatment, many times we don't need that much power to treat stones. With low power lasers, we can work as well. So different lasers come up that have lower powers from the point of view of settings, but with the possibility of different energies and different parameters. And apart from this, in the industry with the holmium laser, there are modifications or changes in the holmium laser as well. And this comes together with the appearance of a new member of the laser family, which is pulsed thulium. If we think about the old thulium, the notion is totally different. Remember that continuous thulium was a laser that didn't have the possibility to treat stones because it had a permanent light energy all the time and didn't have the possibility to be absorbed by water and mechanic energy that we use on the stone. And what does it have to do with the different lasers? All the lasers nowadays work in a wavelength that is very similar. There we have the thulium lasers and pulse laser where the wavelength is very similar, but they differ with regards to absorption by water. And this will create differences in the different lasers and the different settings that we are going to use in our equipment. Something very important is what is inside each equipment. We know that we have a holmium laser. Why is it called holmium? Because it has a holmium crystal that is stimulated by an incandescent lamp that stimulates the electrons, and what comes out is photon, which is the light that will contact the water in the tip and will become energy. When we speak of thulium fiber laser, that is a different notion because it's a laser, a diode laser, and when it comes out, it goes through the center of a fiber, a core that is surrounded by thulium, and it creates a stimulus of the thulium, and a thulium fiber comes out. And the difference is with pulse thulium, because there I have a thulium crystal which is stimulated differently, not by an incandescent lamp, but by a diode. That diode will create the stimulus for that thulium, which forms the light that will come out through the tip of the fiber. And this is interesting because here we have notions that were discussed at large today. One of the things that Said mentioned was peak power, the importance of peak power. And here, when we start to compare the different lasers, the wavelengths are similar, 2,100 nanometers. The penetration is similar. The duration, pulse durations are different, but the peak power that gets to 14,000 watts in holmium. And what this creates that old notion of the mouse effect. When we look at high-power holmium lasers, we see that instead of one brick inside a cavity, we have more than one, and they will allow us to get to higher total power when we are working with high power. When we look at a thulium fiber laser, we have wavelengths that are similar, 1990 nanometers, but with a marked difference with regards to the duration of the pulse. And the main difference is the peak power, where we have 500 watt of peak power. And here is the new member that is pulse thulium, and 2013 nanometers of wavelength, and the pulse duration is up to 1200 microseconds, but 3700 peak power. And why does this change so much? Because if the peak power is different, I am going to have different energies when that fiber is coming out, that light is coming out from the tip of the fiber. It will create a different effect on the fluid that I am working with. These are the main differences in the different lasers. We have the peak power of the holmium laser up to 14,000 watts, the peak power of thulium fiber 500 watts, and a peak power of pulse thulium that gets to 3700, and this creates the Moses effect. And we need to understand this, because sometimes when we speak of how we set our equipments or how they are preset, we don't understand why we are doing what we do. So I think this is important. The Moses effect is the appearance of a bubble. That bubble will generate in the tissue the possibility of enucleation, for instance, and a mechanical effect on the stone, and to treat the stone according to the size of the bubble. And how do we set our equipment? And this is the most important point. When we started with this, we start with setting two parameters: energy or power and frequency. The energy is the amount of light that comes out, and frequency the number of shots. But then what was changed was the pulse duration. So if I have a short or a long pulse, the laser will act differently. Imagine a camera. I have a camera that has a diaphragm, and when I need to have much light, I open the diaphragm and it remains open, and that allows for more light to come in during a longer period. When I want to have a picture with much light, the diaphragm has to open and close in a short time. So I have a emission of light in a short time with a pulse laser. But when the pulse is long, the light is emitted for a longer time. So if I use a short pulse, it would be a big bubble. And this has to do with peak power. When I have a pulse that has a long duration, I will have Doña Florinda and Don Ramon, and just slap on the head, because I'm going to emit that light in a longer time. I have less retropulsion in a long pulse versus a short pulse. And then we have the energy and frequency thing. If there is much energy, I will have this type of person, much energy and low frequency. So I will have big fragments. But if I have big fragments in that case, so if I am setting my equipment to dust, well, look at the bird. This bird has the capacity to have low energy but with a very high frequency, and this allows me to dust. And to me, this is the main notion that one has to have when you are speaking of the laser setting. Let's not set it as preset, but let's understand why. Why is it important for us to have this notion of why we do this? When we speak of pulse thulium, the difference is this, that we start to have pulses during the shot and with 3,700 watts. And this allows for a bubble that is similar to the one we find when we work with holmium laser, with a different shape because the bubble is different. When we look at the result of the treatment on the stone, when we want to fragment, we can set our equipment to fragment in pulsed thulium and to dust, with much less retropulsion, because we are working with a bubble that allows to control it in the setting of our equipment. And when we look at what happens in vitro with the new papers on pulsed thulium, if we speak of dust, smaller than 250 microns, we see that the 7 different compositions of stones, pulsed thulium, look at how we set it, it treats well to dust, even if we have pop dust setting. And the same thing happens when we look at what happens with short and long pulse in pulsed thulium, and especially with regards to ablation speed, where we have results that are very similar to the ones we see with other types of energies that are more used in the literature. But especially when we look at what happens in vivo, and this is work done by this year by Proietti and Biosciuti, what they see is that the efficiency of the ablation is 0.1. And when they look at the ablation speed, we are speaking of 1.3 cubic millimeters per second. And as for the efficacy of the laser stones, that even if they are calcium oxalate, the results are 9.8 cubic millimeters per minute, so quite similar to what we see with other lasers. What should we bear in mind with this, plus what we saw about the results? This is an equipment that is not so noisy, it's more silent, and we have less than 65 dB of noise emission. And another fundamental characteristic is that it can be plugged into any 220 watt energy without needing to have more amperes in our system. So pulse thulium is the new actor in endourology. It has positive in vitro results compared to others. It has possible improvements in new generations. This is something that it will appear shortly. We have to confirm results in real life. But something important is about the equipment we have and how we are going to treat. We have to leave the patient absolutely stone-free. And to do this, we have to select the procedure for each case. Thank you.
Seguimos con la próxima charla y de última hacemos las preguntas al final.
Next, we'll have the next talk and we'll leave the questions for the end.
It's both a pleasure and a curse to follow Dr. Gonzalez. It was such an excellent talk, but he talked about a lot of things that I'm going to talk about, so I'm going to be able to skip over some of my slides. Before 1900, if you had a stone, you were probably going to die. You would get an infection, you would lose your kidney, and you might die. Up until then, it was open surgery only, and then by the 1980s, we had many options. We have shockwave, we had double J stents, which came about in 1978, percutaneous nephrolithotomy, and by far the most common nowadays is ureteroscopy, and that has been aided greatly by the laser. We talked about power and watts and frequency and the output. What I will point out, as you all know, 10 watts of output can be 1 joule and 10 hertz, 0.5 joules and 20 hertz, and 2 joules and 5 hertz. It's all 10 watts, but it does affect the way the stone will break up and retropulsion. The laser fiber that we use is also important because different fibers can carry different amounts of wattage through them. So the larger the fiber, the more wattage, but also the more reduction of flow. The other thing that I think is important to understand is when the diameter of a laser fiber is discussed, what they're talking about usually is the core of the fiber. This is the silica fiber that carries the laser energy. Outside of that is the cladding, which helps to insulate the fiber, and then the jacket provides some stability. Most manufacturers report the core diameter, and about 85% of the total diameter is represented by the core. You can see in this schematic, these are Boston Scientific laser fibers. So for example, the Moses 200 micron fiber the core diameter is 230, but the maximal outer diameter is 390, and for a 365 fiber, it's 580, so it's almost double. So if you're trying to use the laser fiber to estimate the size of the stone, you need to essentially double the size of the fiber. So the holmium laser, 2100 nanometers, well absorbed in water, the Moses effect that we talked about. This is a near contact fiber. It has to be either on the stone or close to the stone, small depth of penetration, and it's safe greater than 1 millimeter away from the target, and it will fragment any stone. Water absorption, we also talked about. This is important for tissue ablation as well as stone fragmentation. The balance of power, higher energy, more fragmentation, but also larger fragments and more retropulsion. So you need just enough energy to break the stone without moving it around too much. This is more significant probably for impacted ureteral stones or stones, small stones in dilated collecting systems. I'll skip over this. Optimizing laser setting. This is very similar to the chart that he showed. This is just to demonstrate that different laser settings can produce, at least in an in vitro setting, significantly improved stone ablation when they're optimized. The more energy you use, the more fragmentation, but the more retropulsion. Increasing the frequency tends not to increase retropulsion. So how do we avoid retropulsion? Well, we can trap the stone. We can put the patient in reverse Trendelenburg if we're working in the ureter. We can use air anti-retropulsion devices such as a stone cone or a gel or a basket. We can do low power or high frequency. We can increase the pulse width to 700 microseconds, or we can use modern, the modern versions of lasers, pulse modulation, the virtual basket from Quanta, or the superpulsed thulium fiber laser. The holmium laser, 2100 nanometers absorbed in water. Low energy, high frequency is very good for dusting. It does have a high peak power and a short pulse duration, so it's ideal for dense or impacted stones. At higher power, it is more prone to retropulsion. The smallest fibers are 200 to 272, unlike the thulium, which can go down to 150. The downside of the holmium laser is the lower power lasers. They are cheaper, but they don't have quite the same high frequency settings. They don't have the Moses effect. All holmium lasers at this point require a high voltage power supply. The system is very complex. It requires water cooling, and it requires replacement bulbs and blast shields. Pulse modulation is the newer version. The standard 20 to 30 watts is limited by lower frequencies. High power lasers now up to 120 hertz, although most people don't go that high. The pulse modulation will split the pulse. The first pulse is a short, low energy pulse forming a vapor channel, and then the second pulse is a longer, high energy pulse, and this is the pulse that gets right to the stone because now the water is essentially parted. The Moses effect, less retropulsion, more efficient fragmentation. The thulium, he talked about already, well absorbed in water. In fact, it's 4 to 5 times better absorbed in water, and this allows for better efficiency of ablation at lower powers. However, there is a risk of high temperature. So when we're comparing the holmium versus the thulium, the way I think of it is the holmium has less water absorption, so it is less efficient, but there tends to be less heating. It is complex, it's loud, it's large, it needs a high voltage outlet. It has to be in contact or in close contact, but it is very, very good for pop dusting or fragmentation. It's very good if the stone is slightly around the corner. The thulium has smaller fibers. It's a quieter laser. It is a obligate dusting laser. It requires contact or near contact. It has higher ablation efficiencies, but it is associated with more risk of strictures and more risk of damage from high temperatures. Now, this is not necessarily because the laser is hotter. It's because we don't know how to use it, or we are not using it correctly. So heat is very important. Tissue damage begins at 43 centimeters of Celsius. Cell death will start after about 2 hours at 43 degrees, but if you raise the temperature to 56 degrees, you'll start to get cell death in less than 1 minute. So 2 models, one was ex vivo, one was in vitro, looking at ureteral stones, showed higher temperatures for the thulium than the holmium in a ureteral simulation model. In humans, there have been four studies. Some of these showed slight benefit for the TFL, shorter operative time by a few minutes, less retropulsion, less bleeding. However, the largest trial to date showed a very high stricture rate of 4.6% compared to 1.6 for the holmium. Maybe because of absorption properties of water in the ureter, maybe because of heat injury, maybe because of the surgical technique. So this is an elegant schema by Kershagani looking at where to choose a holmium versus a thulium. They looked at considerations like how much space do you have? Are you in the ureter? Are you in a small calyx? Are you in a hydronephrotic system? What is the size and density of the stone? Do you have an access sheath or not? Is heat going to be a concern? And how much irrigation are you using? Are you using pressure or gravity? So think about it this way. If Rodrigo de Paul is dribbling the ball up the field, who is he going to pass to? Well, you might say, of course, he's going to pass to Messi. Messi is the greatest player who ever lived in the world. But there may be times when there are large defenders, when the other team is a little violent, that you want to pass to Lautaro Martinez. And so you might think of Lautaro Martinez as the holmium laser. He's good. He's good. You can use him in any situation. But if in most situations you're going to pass to Lionel Messi because he's better. And he's the thulium. So in conclusion, holmium laser is superior for impacted stones. It is superior for stones that cannot be addressed at a perpendicular angle. If you can barely see the stone, you can pop dust with the holmium and you can get that stone to pop out of a cavity. It is better for calcium phosphate stones. And I didn't talk about this, but there have been several studies, and in my own personal experience, thulium laser puts black char marks on a calcium phosphate stone, but doesn't tend to break it up very well. And it is also possibly better for large stones with an access sheath when you want to fragment and basket to reduce your operative time. So what do I do for ureteral stones? I have a Moses laser. I will fragment 0.6 to 1 joule at 6 hertz using pulse modulation. For renal stones, I will dust at either 0.2 or 0.3 joules. Beginning at 30 hertz, you can go all the way up to 100 hertz at 2 joules. If the stone is very hard and resistant, you might go to 0.4 and 30. If the stone is a hard stone and the dusting is just not working, I'll fragment at 1 and 10 or 1.2 and 10. I will then popcorn at 1 and 20. But my favorite is pop dusting, which can be 0.4, 0.5 at 50 all the way up to 80. And then you get small stones, and I will tend to grab one fragment and pull that out and just leave the dust to pass on its own. Thank you for your attention. I appreciate it. And unfortunately, I have to catch a flight, so I appreciate the invitation and hope to see you all very soon.
So, hola. I'm sorry, James. I'm sorry, Mariano.
Lamento, Mariano.
After the lecture, maybe you go and buy thulium. Okay? So, these are my declaration. So, we have to know these points, what is available in the market. Understanding the technology of the TFL, because it's you who is using a stone fast duster. It's a stable, durable, small fibers, temperature issue, which is accused many times by the about the TFL. What about the other parameters that is not counted for urology, is for your hospital? Look at the machines. Everywhere, TFL. Companies, they used to have holmium. They shifted to TFL. Companies, they don't have a laser. They bought the TFL. We have only one tholio in the market. Why is that? Chinese, they have the TFL. So you have available in the market because of the company. They know the secrets behind it, but they want someone to lead you how to use the TFL. Look at the technology. We know that energy, frequency, power with the holmium. It's a classic. I have been using this for 20 years. And then came the pulse duration, because the holmium with the bad face of the stone was the high power. We cannot achieve dusting. That's why they created the pulse modulation, MOSES. Again, to what? In order to go for dusting. And they proved it. And yet, some companies like Quanta, they want to go more than pulse duration to the peak power. That's why all of them, they are aiming to have a low peak power for the dusting. So the secret is a peak power. Third point, it's a fast, stable duster. These studies, even the mini-perk by Grobif Desai, showed that TFL superior to holmium. First paper randomized studies showed that TFL is faster. Studies from Stephen Nakada showed that the TFL is much farther. Look at this, 2.6 centimeter, 1,260 house field, 24 minutes, only 14 watt, completely dusted. This bladder stone, big bladder stones, 2 centimeter, 4 centimeter, it's a fast, in almost 9 minutes or 10 minutes. The secret in retrobulging, the stone does not move, so you go faster. The bubbles are soft. You have to be close to the stone to achieve this amazing result. Look at this. I don't see charring. I don't see black dots in the TFL. It's about what? It's about doing the things right. Again, the secrets in retrobulging low peak power. The stone moves because of the irrigation, not because of the laser. If you are using your laser, you will see that it jumps everywhere. So again, look at this stone, 1 centimeter stone. Maybe in 10 minutes, you can achieve up to 200 or 150 micron. More dust. And always with a short pulse, not a long pulse for the TFL. If you use a long pulse, you will char it. Again, short pulse with a TFL. TFL works in the calcium oxalate, works in uric acid. You can see clearly that TFL works very easy through dust. With uric acid, then you go to calcium oxalate with no problem. Calcium oxalate, 1,200. Calcium oxalate, 1,480. Look at the beauty of the dust. Fine-tuned dust. You can see how that stone was dusted almost, and the stone did not move at all. Prushite stone, one of the hardest stone. Calcium dihydrate stone. Look at the end of that story of that stone. You will be amazed about this. So you continue doing, you dust it, and you leave a stent, you don't leave a stent, you are not worried. Even the cysteine, who said the cysteine does not work at refill? Look at the cysteine here. You just keep away a little bit. It is very fine, like a luxury car, but you have to stay away. You will find a dust, even for the cysteine. You have to know the setting. It's a 0620. And you will see all small fragments. Cysteine, popcorning, 1.210 hertz. Uric acid, this is a big 3 centimeter, convert 0.820 hertz. You can notice that we are working in the range between 15 and 25. Alkalinization, then you remove the stent in 2 weeks. So the aim of the TFL, it's a duster. We cannot play around the fact of the dusting. Look at this, holmium equal to TFL at the beginning. This is inside the ureter. But if you go inside the kidney, you will find some big fragments toward the holmium. You can see that, right? So with the experience, you can notice it's not, it's obvious that we have a real dust. And if you know the secrets, it's about the watt. It's not about frequency. Do not invest in frequency. Look at this. You can do TFL 0820, 1 joule 12, 0620, 0520. I will say it in another way. I'm sorry, this video might be is not working. Can you work the video, please? Okay. Okay, let's go. So, can you put the video, please? So if you say that the TFL does not break stone, there is the new way that they do it. We call it UMax from the IPG company, the other one, the right side, which break the stone. Okay, no problem. The fourth point is the durable small fibers. The small fibers in India and China can last for 50 operation or 100. So the cost is good, but sometimes you need for the holmium, you need to replace it. And with the holmium, if you have a reusable scope, it might break your scope. The waves inside the CMOS of the scope, it's more in the holmium, not more with the TFL. Oh, this is a beautiful video, but maybe you can restart the presentation, take it off and put it again. Because many of people, they accuse the TFL of charring or frequency. Yes, this is same stone, same laser setting, but different scope. So the secret is not about the laser TFL causing these flashes. It's about the CMOS of the company of the endoscope. Because at the beginning, TFL came with the Pusen, they have a bad CMOS, so they was exposed to this energy. So what about the heat? Heat has no problem. I explained it in the temperature. You need the fluid, you need to maintain irrigation, you don't need a cold fluid. These are pictures that we have seen that because of lack of irrigation, you cannot accuse the holmium because this is what was done by the holmium. 80 Hertz 05, and I showed the previous lecture that holmium and TFL, they have the same safety profile. If you go too much with the holmium or TFL, both, they give you these catastrophic results of strictures. And this is the heat of the TFL, true, but it's not well used by the surgeon. He did not understand. That's why some companies, they give you a warning not to surpass 12 watts in the ureter. You don't need it more than 12 watts. So if you are safe, you will be efficient. You can see these are beautiful results of a small, low peak power. Small stones, heads in the middle, and then we're done. Big stones, 2 centimeters in the middle of the ureter, 17 minutes. 17 minutes with a 10 to 15 watt. There is no charring, there is no burning on the ureteric wall. Now, what about the parameters that you should think about it and your hospital needs to know about it? The size. We don't need a 300 kilogram in my room. I need something 45. I need something small. That's something I can move it around, I can place it around. The consumption of the energy, the TFL wins. The TFL costs a little bit of consumption because your factor or the invoice, the fatura of the hospital for the electricity will be less with the TFL, which is indirect cost that you don't know about it. Big machines, you need a plug. If you buy high power machine, you need a special plug for it. The TFL, you can take it even into your clinic. The maintenance. Ask if you have a holmium, how many times you repair it. But TFL, it lasts because it's air cooling. Simple design, no need for complication and complex things. No noise, definitely no noise. Maybe who's using TFL, who you will notice there is no noise. You can talk, you can move inside the wall. So why the TFL is the king of the laser? Because it's a safe, versatile, break all the stone, retrobulging, no frequency, faster, dust, small fibers, efficient, economic, quiet, and less maintenance. Thank you.
Bueno, escuchamos recién entonces, Mariana, con Tulio pulsado, holmium y TFL.
We have heard about holmium and TFL. Which one shall we prefer? Any question? Which one shall we choose out of these three? Or maybe we should ask which would be the most versatile equipment item that will meet all the requirements if someone wants to incorporate the most complete equipment. A question for the panel. Since they buy equipment every 10 years only, and the latest purchase was thulium fiber. Sorry, but he's not using the mic nearby, so it's very difficult for us to hear. I was in love with the thulium fiber equipment, and I had to study physics, laser physics, wavelength, and start looking at basic science papers indicating that thulium fiber works very well in a hydrated stone and very poorly in a dehydrated stone. I could not understand how a stone may be hydrated or not. And the studies that they leave the stone 25 hours in water and the other one exposed to air. In my practice, and this is the question, have you seen any difference by performing a bone window, reviewing the whole stone architecture? Because there have been stones where there is a kind of structure, a very dense structure around with a very soft core. I do not work well because that stone is dehydrated, in my opinion. Unlike the other ones which have a dense core and low peripheral density, with those I work better. Have you seen any difference in use depending on the units?
No. Most of the studies done by the TFL and the Holmium was in the vitro. It's not in the vivo. But if you continue doing the TFL, you will never use it. The problem with the TFL, it's well loved by the endourologists, not by every urologist. Why? The most community urologists, they like the Holmium because the bubble is big. They cannot move too much. The bubble will do the job. For the TFL, you need to be very skillful and near to the stone to like a distance because the bubble is small. So that's why the TFL with the endourologist is more they prefer it rather than the Holmium. Anyone ask me what I buy in machine, I told them how many cases you do. Do you do stone? If he said I do 30 cases per month, I said take a Holmium. Always I say take. If he is have a high volume cases and doing the stone retrograde morely and he is having experience, I know that how many cases he does per year, more than 200, I said take a TFL. If he does a PCNL, maybe we can go to intermediate Holmium. But with the new modification of TFL, you can break the stone, you can do inoculation, you can do endopelotomy, you can do bladder tumors. It's very hard to talk about the expert like the Hospital Italiano or Alman, they have many lasers, but how many in Argentina that can buy 3, 4 lasers? So they need one laser because we forget about this. We said, okay, you can buy 3, 4 machine. You cannot. So they need one laser can do everything for them.
Sí, con el TFNL uno puede nuclear, que
and with the TFNL, you can enucleate, which is what I'm doing. And with Super Mini, I've gone up to 4 joules in order to segment stones. So having suction, I mean, the bubble won't change much. The bubble volume will not change with energy. Therefore, it will not be a better resection in enucleation, but it will be more powerful to break it into fragments and suction the fragments. My doubt is if I'm going to use in any surgery this without suction, I cannot increase energy or power in order not to raise temperature. But in the case of TFNL with suction, I think it works quite well. Not as much as Holmium, but I do not want to enucleate with Holmium. I believe what is important here is to see what you want to do. Of course, as Said said, not all of us have the opportunity of having all lasers available, but the main concept is what I will engage in mostly. If I'm going to do just stones, then yes, probably I don't need a high-power laser, as he said at the beginning. No high-power laser is required holmium laser just for stones, with the holmium laser, a low power holmium laser, not even TFL. With a low power holmium laser, you can do it just like that. With a TFL2, with a pulsated thulium as well. So I think the concept lies in knowing what you will do. And on the other hand, one of the most important things I always put forward when asked what laser to buy is that we need to see the after-sale service, not just the purchase price, the after-sale cost. What is the cost, the after-sale maintenance and servicing? This is something that we discuss with companies. We need to have a good service, a good maintenance service. If in month one after buying the equipment, it gets damaged for some reason, you have no response, then you face a huge problem. You purchase something that was cheaper perhaps, compared to other products, but then you end up wasting money. So if we speak out of our own experience, in our experience, what is our main experience with holmium? We have had the holmium 100-watt laser since the year 2000, then two of 120, now another one of 100 watts. And the TFL that we will be received soon, pulsated thulium, which we are using now. So if we have to speak of experience with this, we have to compare results amongst all of them. We cannot tell which is best or worse, in my opinion, because each of us will use them in different environments. You have different budget and budgetary restrictions. You need to know what you need. That's the starting point. What I need, what will I do? If I'm going to engage in prostate, I will not buy TFL just for prostate. I will be going against the concept. I need a bubble there. So if I need bubble, I will have to resort to pulsated thulium or holmium. So that, I think, is what matters. Understanding what I want to do and then, well, go along that path. Super clear. So we are going to move on to what laser to choose for suction. While they put up the presentation, thanks very much again, Pablo. And according to what Mariano says, you have to pay attention to the Latin American reality. We had they chose the laser depending on the study in Latin American background. We have just one laser and we do everything.
Lo mencionábamos hoy.
We mentioned this today. Flexible ureteroscopy has evolved, and there is a discussion versus percutaneous and the others. If we are endourologists, we have to offer the patient all the possibilities. Why? Because the guidelines say for stones larger than 2, 56.7% in one procedure and 86 point something in others. The problem are residual fragments because the patient then will have to go to the emergency and will need reintervention, and then they will require 1 or 2 procedures. We have had 2 major revolutions in lithiasis. One is the power, a lot has been discussed, and the other is suction, that we can have it with the equipment, with this or with the sheath, which is the fans. Basically, there is no fight in this. I prefer suction in the equipment or in the sheath. Well, this is evolving, except when we speak of CBAG, where the sheath is a bit larger, but let's look at the differences. I can control renal pressure, I can control the temperature, I see much better. This has extended the limits, and we are approaching stones of 2 to 2.5 treated with short time. And here we see the use of baskets and the risk. Disadvantages, the learning curve, the operational complexity. We have to learn to do it well. The suction parameters are not defined. We require more irrigation to have better suction and visualization. Oliver Track said these are the precursors of percutaneous procedure, and he said something, and 2 weeks later he came out with a different post. How have these endoscopes evolved? In 2016, Gawazen introduced the sheath with continuous suction. and suction system, vacuum system, and fans, and the ones we have now. And in this study by Vinay Gawar, it's a multi-center with over 300 patients, 30 days, and then the follow-up with a volume of over 105,000 cubic millimeters. The stone-free, 57.4%, grade A, grade B when we have at least 1 of 2 millimeters, and grade 3 a fragment between 2 and 4, and grade D more. What are the final recommendations for fans? There is a difference between 2.5 and 3 French between the ureteroscope and the sheath in order to have a good passage of fragments. Vashkar said this morning that it's 1 to 2 millimeters from the stone in order to get suction and be able to get to the peak, to the site. I can use a Holmium laser because the fragments don't need to be so small. They can be between 500 and 700. The settings is 2 joules and 10 hertz. And for this here, it has to be dust because the fragments will pass through the ureteroscope, except if it's the ureteroscope that we mentioned this morning, the C-bag, and we don't have it available in Latin America, only in the States, and the recommendation is necessarily dust. And here we would have to use a high-power laser with a low peak power that will generate dust, and the parameter would be 0.5 joule and 10 hertz. In conclusion, the integration of suction in these and fans reduces intrarenal pressure and temperature, improving visibility and the control on the intraop conditions, and this will lead to a stone-free rate and offer the patient a better procedure.
¿Alguna pregunta? Yo te quiero preguntar, Hugo.
Velocidad question. Hugo, you wrote it there, but you're setting nowadays for a ureteroscopy with the suction sheath is 2 joule 10 hertz. And the question also aims at when would we have thought that we would use 2 joule for a flexible ureteroscopy. This has changed. And I don't know, something important to define this, if it's different if you have the stone in the kidney or in the ureter. So then you can have the risk of stricture, ureteral stricture. Who would have thought that you would do a flexible procedure with those parameters? This is a different surgery, the different setting, even if the laser is one of the ones you showed here, and I think like Mariano does, this is so interesting, the fact that we have changed basically the setting, but as we saw initially, when we used high frequencies, very high frequencies, but in true practice, in vivo, we don't use them.
¿Alguna pregunta, algo más?
Question?
Bueno, muchas gracias.
Thank you.
Dale, Hugo. Hugo se queda, viene Jorge Aguilar y Guadalupe Colucci Camuso. Y vamos a hablar y cerramos, porque hasta aquí vimos el buen uso, ¿no?
So far we have seen the good use and when things go well, but these tools can be used wrongly and things can go wrong. So Hugo, please. How to prevent stenosis and to close, and thanks to the speakers, the level of the course has been huge. It's 6:30 and we have many people, and we have spoken a lot about settings, but what happened with the complication? Because we see more and more patients with ureteral stenosis, strictures, and those who devote to reconstructive surgery have to work there. And there are two main important details. Let's follow up the patient. Not only do we treat the patient, and 6 months later they come to our office or to some other colleague because of a place, because of pain, or because the kidney was damaged by the procedure. So we do a lot of things, but we don't follow our patients well. It's not so clear in the literature what are the rates of urethral stenosis. There are many many retrospective studies. We don't have prospective studies. The follow-up is not so long. But there are certain things that have been clearly established. The most important is the patients who have more risk factors are the patients with impacted stone. Another factor is the size and the location of the stone. It's different. The setting I use for a patient with a stone in the kidney, where I can increase frequency and temperature differently than in the ureter. That's why we try to mobilize the stone to the kidney. The trauma that happens if, according to the energy, the size of the equipment and the sheath, energy, and the time, the surgical time. So for the young urologist, we have said this: if I have a surgery in which I am going to devote 60 or 90 minutes, I should do a percutaneous antegrade approach. Or if I refer that to an expert, or I ask them to come with me to the surgery, what is wrong is if I exceed my limits and then I have a complications. This was published 2 months ago, and Way presents several factors. What are the main factors that have proven to increase the risk of stenosis? One, the time from the patient, from the colleague to the surgery. In Latin America, what happens is that many patients take a long time to get to the emergency, and then they are taken to the surgery.
About 3 months, the P is 0.13, location of the stone. You can see the figures on screen. The stone about 0.5 centimeters, high risk. Duration of surgery is not just 90 minutes. We may reduce it. In this study, it was proven that above 66 minutes, there is a risk of ureteral stenosis, and water consumption above the amount of liters that you saw there. This is what we see: a 42-year-old patient with a left lateral colic. He had to be taken to reconstructive surgery. This systematic review is a thorough review of 43 studies where the Prisma systematic review comparing different procedures. You see that risk factors are proximal stones are 0.16. Patients with ureteral perforation with laser fiber, the risk is 7 times more of strictures, hence the importance of working with low power, low energy. If I have a ureteral puncture, patient follow-up has to be very stringent, 4 to 6 weeks, but perform a tag not only at months 1 but 6 because there is a higher risk of stenosis. Impacted stones and hydronephrosis also important. It's not that I just do a 6-month follow-up and that's it. Many patients will have the strictures a year after surgery. So who had impacted stones make a point in the case history, because these patients have a higher stenosis or stricture risk. And the main cause of legal problems faced by urologists is because of endourology. The patient comes back with stenosis long time later. Thermal injury, it's not only low energy but low frequency. It's a thermal injury. And with these high power lasers in a sensitive ureter with an inflammatory process, there will be stricture, and there will be lawsuits brought against surgeons and the companies manufacturing the lasers. And what happens with pneumatic lithotripsy and holmium laser for management of middle and distal ureteral calculi? The use of lighters was associated with a higher incidence of ureteral stricture post-URS vis-a-vis pneumatic energy in median and distal ureteral stones. Conclusions: the incidence of ureteral stricture is not as high, provided we comply with the requirements for a safe URS. Impacted stone is the most common risk factor. We need control studies, randomized ones, to tell us what the main risk factors are. Recommendations are important. Basic principles are the same. First, use ureteral access sheath that is as small as possible, or if possible, do not use sheath. Less than 60 minutes is the ideal surgery time. When you finish the procedure, inspect the ureter as a routine practice. We sometimes remove the sheath and don't watch it, but do watch it. Consider the duration of a stent based on what you saw during the surgery. In the case of impacted stones, do follow-up imaging, work with low energy and low frequency, and try to have smaller fragments for a reduced migration. Thanks very much. Any question? I think I know the answer, but if you leave a pigtail stent when there was a ureteral injury, does it have an incident? We discussed it in prior talks. Evidence is not as sound, but it's better to have a catheter. If you have a lesion, better leave it rather than have to place it when there is a filtration. That's a very important point. One thing is a mechanical injury. Mechanical injury is cured with a catheter. We have all caused a mechanical injury. The catheter is very noble. If you boil it or burn it, there is no catheter that may spare you. So we have to differentiate that injury from thermal injuries. They are totally different. Our resident, fourth year, performed a very interesting review of how many patients eliminated the stones spontaneously, and those who have proximal diseases will not eliminate the stones normally. If you have a large impacted stone in the proximal ureter, the percutaneous approach or the anterograde is the best one, because you will be there for 1.5 hours, and that's not for free. There's no free lunch. Let's put up my presentation, please. Remember, as Hugo told you, the more energy, the more frequency is more power, more temperature. And the smaller the cavity, the higher the temperature. The ureter is the worst place. It's the worst place to work with high power because it will increase temperature too much, and if an impacted stone, there is no water flow. Well, but did not touch the mucus. Well, there's no need to touch the mucus. Actually, what you did was to boil the ureter. You boiled it, not burnt it. Look at this tweet by Said.
Miren este tweet de Said. Semanalmente ustedes van a ver estas comunicaciones.
Every week you will see this kind of communication. Every time there are more ureteral injuries. For some time now, we've been treating this with balloons. Balloons with a double coating, including paclitaxel. That's our experience at the Endourology Global Congress. And these balloons, the dextran gel includes paclitaxel particles that are slowly released, and during the first 3 months they will have a biological action which consists in inhibiting smooth muscle proliferation, fibrosis. These are the catheters that we have used at the hospital for 5 years now in ureteral strictures, and we will take these minutes to tell you the step-by-step how we perform these procedures. The first step, can we play the video, is ascending pyelography. We must have it clear what the stricture length is. This is a video from Javier Ceballos in Montevideo, Uruguay, post-pyeloplastic laparoscopic ascending pyelography, and based on the length, I will define what balloon I will use. They are all 6 millimeters in diameter. But if I have a strict shorter or longer balloons come from 4 to, I think, 14 centimeters in length. Correct me, Alejandro, if I'm wrong. So if I'm going to choose different balloons depending on the stricture length. So first, what I mentioned, then dilation with a drag-free balloon. I will use a 6-millimeter balloon, but with no drag. I will open with a syringe that will carry this balloon to 10 atmospheres of pressure. It blows up the balloon to 10 atmospheres. I will open the sand clock that at some point opens up. I have opened the stricture. I have torn the fibrosis. This I do with a drag-free balloon for 5 minutes at 10 atmospheres. I try to open up the stricture. There are some tips here. The fiber used is 0.014. Also 0.018 can be used, but 0.014 is more comfortable. You have to lubricate. You see the drag-free balloon. Once you have placed the guide wire after the pyrography, you will move the balloon up along the 0.014 guide wire. Since there is no drag, there's no problem in manipulating the catheter. And there you will feel the second conduit that allows blowing the balloon, and you will take it to 10 atmospheres. You will see some proximal and distal stricture videos where you see a sandwich that opens up gradually. Look at this patient. He had a post-radiotherapy and post-radical prostatectomy stricture. See the degree of stricture. It is interesting to note that in post-pyelography patients, we performed one in Uruguay. It was a post-pyeloplasty, but we could not open the stricture with that balloon. There are balloons that reach 30 atmospheres. Remember, Juan, he had an upper pyeloplasty, a laparoscopic pyeloplasty, and it had stenosis again. So even though we use up to 10 atmospheres, there are balloons that can reach up to 30. And this is the balloon with the extrand plus packet-like cell plus the extrand. So we opened up the stricture. We want this gel and particles to be deposited on the urothelium surface. Our results, 80% of these patients went past 1 year, and 100% have no hydronephrosis. So we have to wait for this series to mature. These rates may go down, but results have been very good. And you were asking, Guadalupe, in these patients, we try not to leave any ureteral catheter on because we think that, did you see the post-double J catheter? Double J generates some inflammation. So in these patients, we try not to leave a double J. In the case of strictures, they were post-ureteroscopy, and in the ones Javier showed, there had been very severe strictures. Out of our series, 20%, we had to place a double J because of pain. Some patients did not tolerate it, and we had to use a double J. Out of 20%, 10%, we removed the double J. They did well, and then the other 10% was the failure rate. Let's show the video again, please. It is an interesting alternative for a serious problem. Hugo showed that this happens ever more often. We have seen there are more retrograde of larger stones. And one thing is the kidney, as Hugo said, and a totally different thing is the ureter. In the ureter, you cannot go past 10, 15 watts, and an impacted stone, as Norberto said, proximal voluminous stones. The first approach is anterogrowth, then dilation with balloon without drag, then with drag, and in our experience, it is not necessary to leave a catheter as a matter of a routine practice. Questions? Guadalupe, you have experience with this. What I think is very interesting is that, if any one of us comes here just doing the same thing, we are very stubborn. We have colleagues in other wards that do not get updated on this and believe that more is better or more is faster, and we will have all ureteral strictures. What is very interesting, in my opinion, about this approach is that for endourologists, it's very simple. Even if we are not hemodynamists and we are not used to using balloons, it's simple to perform. Steps are easy, and if it's proven useless on with poor results, this does not prevent us from performing reconstructive surgery later, which is far more complex and more complex post-op. But as a first option, this has very good initial result rate. It's an excellent tool available to us endourologists that for and for other colleagues who don't do things well. I'm assuming that those patients, sorry, but he's not using the mic.
Bien, no, gracias, doctor, buen punto.
Thanks, doctor, good point. Generally speaking, all those patients have a catheter. This is not a minor detail. Even if the balloon is not inflated, there is a diameter. I don't know exactly which one it is, but if the patient has a stricture completely closed, you won't be able to place the initial balloon. So ideally, these patients should come to us with a double J catheter, even if in the pyelography may be more or less clear, but the 6 milliliter balloon needs for a minimal lumen, otherwise you won't be able to drive it past.
A ver, creo que esto no es la uretra,
This
de la
is
cual no
not
tengo
the
ninguna experiencia. En general, los cirujanos
urethra,
reconstructivos,
but
por ejemplo,
reconstructive
que
surgeons
se cierre todo
prefer
lo que deba
to
cerrarse. Aquí no es el
use one
caso,
size and close
esto
everything that needs
equivaldría
to
a
be
una
closed. This
nefrostomía
would
en
be
todos los
equivalent to a
pacientes y no
nephrostomy in
creo
all
que sea
patients,
necesario en todos los
and I don't
pacientes.
think
En
it is
general, los pacientes que
necessary in
hemos
all of
tratado
them.
eran
Patients that
pacientes
we have
nuestros y otros
treated were
derivados
ours,
con
and
catéteres
others
doble
referred
J.
to us with a double J catheter. Rodrigo, well, excellent presentations. I wonder whether you have any recommendation in transplanted patients. The big challenge is what happens, among other things, with immunosuppression. Guadalupe.
Hay casos publicados con
There
el
are
uso de
published cases using paclitaxel with good results throughout the world. There are indeed. That's a more than valid option. I don't know if Luis is here. Do you have any patient that remember of this 21 patient series? No transplant patients, okay. Mike, please.
No tenemos experiencia, pero sí tenemos
We
bastante
have no
experiencia.
experience with transplant patients, but we do have experience with neo bladders and breaker patients who had to undergo regular mono J catheter replacement. With these patients, we are having very good experiences. And as Pablo said, we have had some with more than a 1 year follow-up. We have had the torture of neo bladder because of the tortuosity of the ureter. And even in that setting, we have had good results. We have a transplanted patient at our hospital. We did not do well with the paclitaxel balloon, even if transplanted patients already come to us with a nephrostomy. So dilation was difficult, even using the drug-free balloon, because it wouldn't open, and we had to perform a different type of dilation. And then, so there's one case, and we did not do well. It was tempting. We should think of those patients which have a significant degree of fibrosis. There are balloons that accept up to 30 atmospheres, and we prevent trauma. It's not the same dilating sequentially vis-a-vis using a balloon. The trauma is not the same in the patients such as the one we operate on with Juan. If they have a significant degree of fibrosis, maybe we should request that we have a 13 or 18 atmosphere balloon available in the operating room. If it's not used, much better, but think that perhaps they will need more pressure atmospheres to open up the stenosis. Congratulations. I could not hear, which may be useful for those who do not perform. This is the time during which you have to leave the balloon inflated with a paclitaxel dilation. We leave it for 5 minutes at 10 atmospheres. We have learned from Ceballos in Uruguay that the balloon tolerates up to 10 atmospheres. Then we bring this to 12 and we use a little plus to see whether we can open it up more. Basically 5 minutes at 10 atmospheres. Apologies, doctor. From your series, did you have any laser caused strictures? All of them are caused by heat. Many of these are our uteroscopies, and at no point did we touch the mucosa, but these were patients with a past history. 2 of them had been subject to radiotherapy and radical prostatectomy, and the others had proximal stenosis. A patient like this that comes to us with this, that's because, I mean, in the proximal ureter, there's something like this, it's no good. How to assess the lack of hydronephrosis? There is always residual hydronephrosis in any procedure. There is some resisted hydronephrosis. They have zero ectasia in ultrasound or CAT scans post-procedure.
Excellent presentation.
I have a question. In countries where we do not have these catheters, for here in Argentina, you maybe have a different case load, but experience with other devices is not too encouraging, I must say. Cutting using holmium, there will be restenosis or restrictures. It's interesting to look at the studies on the right with and without drugs. Curves drop quickly. The robust 3 study, which allowed approval by the FDA, and you see the differences in curves. The curve without drug drops. The alternative would be to go for a reconstructive procedure. The groups that use jugal mucosa, but the alternatives are not too encouraging. We have tried that already. What we are asking for in a nutshell is what alternatives you can offer to the group that are in these parts of Venezuela, of South America, such as Venezuela, where we can find these catheters and assess them. I don't know, but there is a booth, a company booth outside, and you can ask them. Don't go now, because there won't be anyone. They have left already. It's too late. Sandra, one last question. Thank you very much. We've been here for 12 hours. It's a pleasure to have you all in the room making contributions. One last question before the last and last. We asked, and the doubt remaining is how long this lasts. For them, these patients have to be retreated. We were talking about this with Norberto. So far, we are doing well. Studies in peripheral arteries show that the drug maintains activity for the first 3 months. We have no experience in retreatment. Ceballos does have experience. Laura, do you have any experience with retreatment? We haven't had any, because thanks God. Do you have any experience with retreatment, Laura? So, what can you tell us? She's not using the mic. Also interesting to note, unlike hemodynamics, is that a lot of time for them is 60 seconds for balloon dilation, because the heart is not vascularized, so it has to be less than that. And we leave it for 5 minutes. We performed 2 retreatments and they did well. They were patients with a significant degree of stenosis. We managed to open up the stricture, and then we had to complete it with a second procedure. Remember what you were asking. Time between treatment, 4 months in one patient, and some 5 months in the other one. The patient operated on in Montevideo, that pyeloplasty that had failed, plus laparoscopic pyeloplasty that failed when it was not completely open. The stricture, I called Javier and told him, it's not fully open. It's better off, yes, 60, 70% better. And that was enough. Sometimes the fibrosis does not allow you to completely open it, and there's also some spasm in the ureter itself when you perform the pyelography. That tends to improve in the protocol that we have developed with Javier. We leave them with some prednisone for a few days and they improve. And also, even if it is 70%, that's better than nothing. It causes relief, and in longer term follow-ups, we perform bone densitometry to see what happens. There is some stenosis, but this does not impact the kidney. Balloons with both drugs are approved for treating fibrotic stenosis. The values have been approved by the European Union to treat fibrotic stenosis. That's what the approval says. It's like HIFU. They say treatment for solid tumors. Retina, I don't know. But the label says treating fibrotic stenosis between inverted commas, ureter. Last one.
Thank you for the talk. In Bolivia, we don't have this. 2 months ago, I had the opportunity to use in urethra one of hemodynamics. Is there a substantial difference, paclitaxel, with those specifically for urethra? No, there are no balloons for ureter. They are the peripheral balloons. In a short time, there will be a brand that will be called specifically for ureter, but the values are for peripheral arteries. They are the same. The only difference between what we have tested is that they have a double coverage. The difference between dextran and paclitaxel is 2 to 1. And one of them generates less inflammation than paclitaxel. So dextran, at least in arteries, it has shown better result than those with only paclitaxel. So dextran improves the result versus paclitaxel alone. Tomorrow we'll meet at 8. The breakfast is at 7:30 here. Thank you all.